There are a lot of registration. You are very few now at the moment. first case.
Yes, that is great. Hi to everybody. Yes, so we will start with the first case of the day.
Good morning, everybody. The first case of the day is a 59 years old male. He was admitted to the hospital with a recent onset of abdominal pain, and for this reason, he underwent an abdominal US, blood test, and colonoscopy within normal range. After, he did an abdominal CT scan that showed slightly hypervascular and partially cystic lesion of 27 millimeters in the tail of the pancreas. Here we can see the lesion at the tail of the pancreas. Today's procedures are US guided fine needle aspiration with rapid on-site evaluation, USFNA. Operators, Professor Satoyu and Professor Iglesias Garcia. Can you hear us?
Yes,
On room 5?
can you hear us? Oh,
Yes.
now you can. Okay. So good morning to everybody. So we just started the first case. So I'm together with Julio here. Hello. And Matteo in the back, and that very large team of anesthesiology and nurses. And we just started the case. We started the examinations, and we are working with an ICE Olympus. So sorry, Fuji system, and it's coupled with a nice Arietta. So we didn't have coffee in the morning, so you have to excuse us for the small mistakes. So it's a nice Fuji system with an Arietta 850. So we just started the examination with a penetration mode. So this way we have let's say more penetration and less resolution. And what you can see, we just inserted the scope in the stomach. So we are at about 48 centimeters from the incisors. And you already see the mass that was described on CT, and also a bit of the spleen. So what's a bit particular in this patient is that the pancreas is a bit, it's quite long, and towards the tail, we had to torque a bit. You see that the scope is really torqued, and then it's a bit looking towards the tail of the pancreas and towards the spleen. So in order to find the lesion, we struggled a bit. So this is an area that you can miss sometime during usual examination. So you always have to maybe start with the penetration mode to have an idea on where the spleen is, where the kidney, the left kidney is, where is the adrenal, where is the aorta and the celiac trunk, and then you locate pathological abnormalities. So then if you catch the mass, then you can switch to a high resolution mode. So less penetration, high resolution mode, and Julio will help me, will play a bit with the image. So now you see better the mass, which is, we've measured it, it's about 2.5 centimeters. And then you see that now the image is pretty stable. So we had the patient is asleep, is with propofol sedation. So we have a very nice anesthesia team which is helping us with the patient. So that way the examination is comfortable for both the patient and also for us. So we can play with the settings. So if you look at the grayscale, you see that it's a bit inhomogeneous and it has some cystic spaces inside. So Julio is helping us to show a bit the cystic spaces there. And then, of course, we can use with this very nice machine, we can use all the techniques from
Before starting, Adrian, my first question to you is: with your expertise, B mode, with this high quality B mode, what is your first suspicion?
I think,
with no other images, what do you suspect?
Of course, you can go through the differential diagnosis of focal pancreatic lesions, but the first suspicion is a neuroendocrine tumor. So it's inhomogeneous with cystic spaces. It's nearby the spleen, but there is a slight, if you look, there is a slight demarcation line here. So it's it's not belonging to the spleen. We were discussing that the differential diagnosis with the accessory spleen can be made, but the accessory spleens are really round. The tissue is really similar with the spleen, so it's exactly the same. Here it's a bit hypoechoic. The mass is a bit hypoechoic as compared to the spleen. And in accessory spleens, you see the bridge sign, which was described some years ago. So the accessory spleen connects with the spleen through a small limb of tissue. Here we see a slight demarcation in between the tumor and the spleen. And then we can play with we have a lot of settings here. In the first one would be, for example, E-flow. So you see that E-flow, it's a modified power Doppler. So it's a bidirectional power Doppler. So you also see the direction of blood flow. And you see already that the mass is hypervascular. So it has a chaotic architecture. So you see a lot of vessels inside. And then we can switch to maybe DFI, which is really nice. So you see also the macro vessels, maybe with some necrotic, a small necrotic area in the center, but the vascularity is chaotic. There are abnormal vessels here, mostly in the periphery of the lesion. So maybe the central part is a bit necrotic. So whenever you do a fine needle aspiration biopsy, you should maybe avoid that central part, and you can try to do a fanning technique and go a bit on the side. So this is also very nice. We can also switch to elastography before doing contrast. And you see that on strain rate, if I try to keep it still, you have to leave the scope very still. And then we'll switch again, maybe
to have the size of the ROI
exactly
perfectly. Should be 50%. The lesion not more than 50% of the ROI. That's why I increased the size.
So you see, it's very well delineated, and it's a hard mass as compared to the surrounding tissues, and that's compared with the GI tract wall. So Julio is doing a strain histogram. So you see, it's a very hard. The values are very low. So it is a low stiffness lesion, as we would have expected. And then we can also switch. We have also shear wave. If you want to play with different types of elastography, we also have shear wave. We can try to hold the scope still. We did a lot of measurements, and you see there is a lot of variability in between the measurements.
Yes.
But anyway, the median values for elastography are 22 kilopascals, and the speed is 2.73 meters per second. And I mean, elastography tells us both methods, both strain elastography and also shear wave measurements are telling us the same thing, that it's a hard lesion as compared to the surrounding tissues.
The only concern with shear wave elasto is that the variability that is measured in the number that is to the right of the square should be always over 50. So when you have values below 50, it means that there's a lot of variability, a lot of side movement. So I think Adrian and myself, that we've been working with elasto for many years, we still are more believers in strain elasto in solid lesions when we're using this advanced imaging in pancreatic solid tumors. We also love a lot the imaging of DFI, but I think it would be nice to give contrast so we can see the comparison of the standard contrast enhancement for showing the vascularization as compared to DFI. Adrian.
Exactly, because it's DFI. We both think that will not replace contrast harmonic imaging due to various reasons. So DFI is a technique which doesn't use Doppler. It's derived from the grayscale, the B mode. And you see large vessels, so macro vessels. With contrast harmonic imaging, you see also the perfusion. So you see also the blood flow in the capillaries. So we have the system set up already.
Yes.
I'll increase maybe a bit the...
Yes. We've already injected the contrast. We are going to see now that the contrast will arrive.
So you see it already. So you see that it starts through the arteries, and now you see that it's a hyper-enhanced lesion. it's a very nice image, even as compared to the spleen. So in accessory spleens, it is the same. So the signal intensity is the same in the accessory spleen and the spleen. Here you can see that the
Also the-
lesion
also
is
the
hyper
necrotic.
enhanced, yeah, with a necrotic part in the center. And you see that it starts to wash out. So this is also a sign that it might be a malignant lesion, and it gives you an impression of the degree of differentiation already by looking at the contrast. So you see now that it's already, we are at 1 minute. So for contrast harmonic imaging, we usually record only the first minute, because you can catch the arterial phase and also the venous phase. And because this is stable, we can play a bit also with the time intensity curves. But you already see that it's a hypervascular lesion. So
So I
that's
think
what
probably now the question
imaging shows.
the question now is telling everything. We know it's hypervascular lesion, highly probability of an neuroendocrine tumor because of the pattern. We know that it's a hard lesion, so it tends to be malignant on advanced imaging. So we're going to make a biopsy. But do you think in these cases, these all techniques will make us not making a biopsy in these cases? And for instance, if it's resectable, go directly for
Yeah,
resection. What is your
I mean,
belief?
this most probably resectable. So it's a, although it's a large lesion, it's a 2.5 centimeter lesion. It's not related to the vessels. The splenic artery and splenic vein are a bit far away. It's nearby the spleen, but I think that the surgeons can safely take the lesion without touching the spleen too much. So I think they can do it laparoscopically or robotically if they want. The problem is to convince your surgeon that you can get some nice images, even color images, and they should operate based on that images. So it's still difficult. So usually, at least in the centers where I've worked, the surgeons want the confirmation on pathology. Then the patients want a confirmation on pathology. So even if the mass is resectable, they still require the US guided fine needle aspiration biopsy. And the procedure will
will
show
go-
it, because
while Adrian is inserting the needle, it's true, for instance, that if you go to the guidelines and the NETS guidelines, they state that for an endocrine tumor to complete the staging, you need to have the proliferation index. So today is still somehow mandatory in some cases to know if it's a G1, G2, G3, is to do a biopsy, because the only way, and we know that with the final biopsy, we're able to get the Ki67 value. So in this case, of course, we expect to have a high proliferation index, high Ki67, but we need to prove it.
Yep.
And of course, maybe in the years with more and more advanced imaging and more comparative studies with surgery and the specimens compared to the different patterns of advanced imaging, maybe in the future we can skip in some cases to do a biopsy. Because believe us, when you have these cases with such an amount of vessels inside to put a needle, sometimes they're a little bit frightened.
yeah, we have a roundtable a bit later on complications. So we'll try to show you what can happen. But we have a nice needle here. It's a Charcot needle. So basically, it's a 22 gauge needle. It's a fine aspiration biopsy. So it's a histological needle, which is very nice. So it's very sharp. That's why the name Charcot. So it's very sharp. And you have two buttons here. So we'll unlock the first one, and we're just getting out the sheet. You have to be careful not to play too much with the up-down wheel and the elevator when you're taking the sheet out. And Julio is already showing the plastic sheet, so you can
Yeah.
see where it is. We already did a pass before the live, so sometimes when you do the first pass, especially with the histological needles, I don't know what's the experience of Julio, but when you do the second and the third pass, it's a bit more difficult
Yeah.
to go through the muscle layer of the stomach. Not specifically the lesion, but the muscle layer of the stomach. It's a bit more difficult.
Probably we bend a little bit the needle after the
Exactly.
first
So-
pass, and sometimes it's a little bit harder to go for the second pass. But the advantage of these core needles is that if you go straight, sometimes with one pass, you get very good samples.
So I unlocked the.
Dr. Sartorio,
Yes.
do you listen?
Yes.
I am trying to connect from the audience. I am Enrique Perez here in the audience with Rafa. A single question. What do you think about this cystic component in the modification of the technique? Do you think you will have less possibilities to have a good specimen, or the histological results will not be really impacted by the presence of a cystic solid lesion? Or how do you modify your technique at this regard?
Okay. Yes, I get the question.
The question is about the
cystic
component.
component. In this case, it's quite. The idea is always to go to the solid component and try to avoid the cystic part, because we know that it's going to be easier. The premise, when you only have a cystic component, then we usually tend to go for cytological needles, and if we really need histology, the other option is to do a Morey. There is a through the needle biopsy forceps, which is a little bit tricky, but sometimes can provide an information what is major only cystic component. In this case, I think Adrian is going to target or try to target the solid part.
Solid part. The only thing is, could you help me and hold a bit the scope, because it's whenever you puncture from the stomach, what happens is when you try to go with the needle in, then the whole scope is pushed back. So you see that we struggled a bit. So when this happened, if you cannot do it, we could do it, but when you cannot do it, then you have to exchange the needle. So we're doing what is called a slow pull. So you see that the stylet is retracted, and whilst we are doing movements back and forth movements, and we're trying to fan a bit the lesion. So we try to rotate a bit with the up wheel. I'm not using the elevator, so I don't like to use the elevator, but sometimes it's needed.
Yes, Paolo.
Yes,
Paolo.
Paolo.
Yes.
First of all, welcome to EUROEUS.
Thank you.
And second, thank you for this great demonstration. I tell you to the audience, to the auditorium, and to all the people attending online that they can follow the results of your biopsy through the US Express channel. So we will interview the pathologist, and we will see the results by VivaScope and the Rose. So thank you, stay tuned, and we go to present the next stage.
Great.
The next
I retracted it. Hello.
The next case is a 23-year-old female. She's unfit for surgery for a osteogenesis imperfecta. Documented episodes of hypoglycemia and positive 72-hour fasting test with elevated insulin and C-peptide levels. Abdomen CT, MRI, gallium-68 PET, and USFNA were performed and showed two distinct pancreatic glands located at the body. It is 17 millimeters, and at the
the short failure of the left side hip. She then performed local tests with the positive outcome for the antidepressant process. US government for a perform of the antidepressant process. She then affected the new episodes of hypoglycemia and the new MRI from and the two glands in the body of the pancreas, which is stable at 17 millimeters. And the urination process, which is slightly increased up to 16 millimeters. These are the lesions after 68 kilograms. And is US
operators are Professor Palazzo and Professor Fusaroli.
Laurent,
Okay,
Pietro.
nice to meet you. You hear me?
Yeah, we can hear you perfectly.
Okay.
First of all, thank you and welcome to EUROEUS. And then you have your 20 minutes time slot to perform the procedure. Thank you.
Okay, so we are working with the Olympus scope, linear scope, therapeutic scope, and the console Olympus EUROEUS2024, which is a new console with contrast and everything. There is no DFI. So the lesion is still working. The secretion is still coming from the lesion. Second possibility, there are other lesions which are secreting insulinema. The patient has Mean syndrome, so it's likely that she could have other lesion. She has 17 lesion into the body, which is considered non-secreting because of calcium test angiography, which is a very good technique.
Stain with acridine and fast red to allow the visualization on the focal microscope. So I think that this could be enough. Yeah, well, the sample seems very have a very long sample. Really, just with the microscopic evaluation, we could say it's for sure adequate. Okay, let's see if the videos
So we have now the probe on the second matrix as a special scaffold. So now we do a smearing procedure. It takes less than 1 minute. And then afterwards we put in the Vivas probe, which is a control microscope. So we are not smearing the tissue. We will simply get the optical sections of the tissue. So the entire tissue is then preserved for the final morphological analysis and even for molecular analysis. We have two dyes, so as you saw, one is, so I'll do a second passage. So the first passes alcohol to facilitate presentation, then we use acrylic orange. Acrylic orange binds to the DNA, that's why then we see the morphology of the nucleus. And then we implemented a second dye. This is more for the extracellular matrix component. Also, you see very well fibrosis, for example. So the two dyes are reassembling hematoxin and eosin. So what the pathologist, the cytopathologist, will be able to see is an image that is very similar to hematoxin and eosin stain. So if you come, so now we mount the specimen on, we call it like a sandwich method. And then now we are ready to come up. So we are ready to put it into the microscope.
how quick is the
There's no smearing of the tissue. We create the patient, or we can have the patient. You see here, you see on the screen, you see the macro view of the sample on the second matrix. You can recognize already here some tissue. Now we take the image of that and being already fixed. Now don't expect to see a classic or image coming here on the left side.
The right equals the central of the lesion,
Like here,
which means that you have
already see cellular details.
right equals so
Now we simply select the region that we want to acquire. And now the acquisition starts. So what you saw was one single field of view, which is like approximately 500 microns square. So now it's acquiring the entire sample and putting together hundreds of these single fields of view. And when it's done, the pathologist can immediately zoom in and visualize details. Of course, everything is already digital, so it's digitalizing fresh tissue without cutting the tissue, without smearing the tissue, and the pathologist or second pathologist doesn't have to be in the endoscopy room, but this can also be done in a remote way. Yes, without affecting the material. So the person that's doing this on site is not smearing the material, so it's not affecting the sample. And afterwards, you can use this for standard evaluation, immunohistochemistry, or even molecular. So as you see also here, there's a lot of material. You preserve the biosphere, so you really see the passage. But here, another advantage is that here, even if you have blood, so you will not see the blood. So the blood will not interfere with the evaluation of the tissue. It's also a big advantage because we know that in many cases blood is very important. So we're almost done, and then we show you the details. What you can already see here is that you have a lot of material, but you don't have a lot of cells yet. It's more, you have more similarity. So now if we
Now with the technology, you can help to understand what we have. It's a good sample. We have this slide. Really simulated, so let's see a good question. So in a few minutes we can take adequate. Yeah, I think so.
and is it?
And the CI have a calculator performance. So my first impression is that we have a neurorecord.
And here the technology.
It was also one of the ultrasound impression. Okay.
We also
Now
saw
we will make a comparison with the normal here, the normal appearance current. But it looks like this. So I like very much when Vinoscope allows multiple levels of evaluation because really you can appreciate the whole cell. So it's really wonderful. Okay, so this is your other questions. Your sample was excellent.
Question, I say, okay, I will be gentle for them, but finally, intubation is really better in that case, and I regret to have only sedation. Okay, so now we will try to work. So we will use a 10 millimeter RFA needle, and I will use, because there is no duct, I will use okay.
So can I go back to the B mode?
Yeah, of course. Of course, we have to.
As far as I know, with the microscope is the box, so that you can not only manage for the on-site evaluation, but you can also take the sample and manage to do ancillary studies and anything you need from the sample.
Yes. So we removed the sample from the microscope, which was put on this special magnet. So, and now this can be simply fixed formally and used for standard immunohistochemistry. Also immunohistochemistry, but standard morphological analysis. So
I think it's one of the advantages of this system is that you can have three things at the same time. You can do histology, you can do it on site, and you can do it from abroad. I mean, you can connect with John Hopkins if you want, or I can connect with Adrian, or with Milan, with Dr. former Professor Doglioni for the evaluation. So I think this is a great step up forward in terms of the evaluation of the sample that we do by USG.
And of course, patients came from TV and already by now the there was
Of course, because to know that you have a good sample or not a good sample, it means that you can skip an additional procedure because you do not have the correct evaluation. Because we know that a USG sampling is not 100% accurate. We still have 10% of cases in which we cannot get the diagnosis in the first shot. So it's very nice if you have this opportunity because you can really know if you need to go for an additional pass or not. So I think it's nice, and I think it is going to become the future in our units, probably in years. Okay.
for eliminate the blood. Yes, to allow also the visualization of the cells. But here, for sure, we can stop. Thank you. I will give you a try to do the
with the 10 millimeter active part at the tip of the electrode. There is a fully
but as you can appreciate, they are very scanty in here, and it's mainly bloody. So there are also some very, very poorly, they are not cohesive like Pilates there. So because it's very blunt, it's difficult to get them attached to it. So in this case, if you have only this material, you will suggest other samples, other pastel. Now we have a lot of material for the blog, and I will go for
Take time.
now I have
Of course, this lady, we have to take time. She has recurrence of symptoms. We have to be efficient.
And Pietro, regarding the follow-up of these cases, because this is also somehow challenging to decide how many months passed from the first treatment to the second one, what are you expecting in terms of follow-up? If you are performing successfully, for example, the RFA today, will you propose in 1 month or 3 months, 6 months, and how?
Yeah, I think it's important to have a clinical follow-up, first of all, to see how the patient is doing and if hypoglycemia has receded or is still persistent. And usually a CT scan control at 1 month would be a proper follow-up. And then maybe we need to consider coming back when the patient is still symptomatic or CT scan shows evidence of active disease, as this was the case after all. Of course, as you see, we are struggling a little bit to identify the proper position where to put the needle.
Okay, can you keep me the lesion, the scope? Really, really, you keep it, you don't? Okay. Like this, okay.
Preparation is everything. So as with any FMB, it's even more important, of course, when you're doing such an invasive treatment that you take all the time is needed.
Please keep it, and you see the show to the lady, to the nurse, the area I want. This, you show that? Okay, so now you take it. No.
And the patient is in a lateral position?
Yeah.
Left lateral decubitus.
Okay, so problem. Perhaps Pietro, you will move to take the scope.
Yes.
Yeah. Take gloves and take the scope. If we want to be efficient, I have to have my cross section because I cannot keep the scope in my hand and the needle in my nose or my ears. It's the needle. I need my hands. Sorry.
Yeah, the apparatus, of course, it's a little cumbersome.
Like Laurent, do you use sometimes a balloon to help to stabilize the endoscope?
Yes, I have the balloon, but the breathing is strong. You see, see, Pietro?
Yes.
You see, like this. Okay.
I think you are inside, Laurent, now.
I don't see it. No. Keep it like this.
Yes.
You see, I want to see it. I'm take it. I take it.
Okay.
No. See up here. You see? It's not good.
We see that this is very challenging to have the needle exactly.
It is challenging indeed, because in this case it's a retreatment, so of course the lesion is a little blurred and
Keep like this.
yes.
What is in your view, Pietro? What is the risk to
like
treat
this.
the necrotic area?
There is no risk in treating the necrotic area, but there will be no effect either. Of course, we need to target the active remaining part of
Show me the lesion. I'm inside.
Yes.
I have to remove it.
Okay, nicely inside. You can see the needle exactly.
Yeah.
So, yeah, very nice, Laurent.
So now I'm good. So you can start. Started.
Okay.
Stop.
So we did like a 5-6 seconds.
Yes.
Stroke with 50 watts and a 10 millimeter electrode.
Okay, so now we look.
Laurent?
Yes.
Pietro? Perfectly on time, 20 minutes. You can continue your application and the audience can follow you on the US Express channel with the interview and so on. We are going now to present the next case in room number 7. Thank you very much.
May I do another
yes, of
contrast, please?
Un altro
Yeah.
How are you doing? So the next case is a 59-year-old male. In February of 2019, he had a pancreatic cancer diagnosis, for which in September of the same year, he underwent a pylorus-preserving total pancreasectomy, followed by chemo and radiotherapy. During follow-up, in July 2021, evidence of disease recurrence with liver metastasis detected, and also the presence of portal stenosis, for which the patient received portal stenosis and elastic bandage situation.
High standard and I know that others are using sometimes 30, and one is very big, they use 20. Yes, the issue is less you have watts, more you are dangerous. More you are watts, it's 50 the high level, less you are dangerous. Okay? Here, that is not the concept, because there is no that. Okay? I use 50 because the remaining lesion was around 1 centimeter. You see, the remaining tissue was around 1 centimeter. We have a 10 millimeter probe, so I use my standard settings, which are 50, and I'm happy with that. When there is 1 centimeter, 12 millimeter, 15 millimeter, 50 watts, and 1 centimeter, works well. For bigger, I think that we are feeling lower settings and to make several shots.
So now we're ready for contrast enhancement. If you look with your camera at the screen, it would be interesting to see what we get.
So you can inject, you can inject.
We inject contrast right now. So our system injects the contrast. Injection is being done.
Okay.
Timer is running. Okay, nice. So you can see Paris. You can see a nice non-enhanced area. Exactly. Where we apply the treatment.
You see?
And that's in favor of very efficacious treatment.
Yes. Here I do not see any nodules.
Exactly.
Any residual nodules. What I know is that the crown, the rim of the lesion could be positive.
Okay.
However, usually the symptoms disappear.
Okay.
You understand?
Okay. It's clear enough. So you're very happy with the result from what I understand.
On what I see, I'm very happy.
Okay. So in this case, since this is a retreatment, would you do a second treatment or is this enough?
No, I think it's enough.
Enough. And so the next step will just to follow the patient clinically.
Yes.
See how she does. The contrast is very good, David, with this UM3.
Yes, it's very good. It's what I want, black and white. All the other discussion on contrast for me are not different. I want black and white.
And in terms of the bigger lesions, how many shots may be needed in the same session?
On the bigger, how many shots?
Yes.
I stop at 4 is the maximum.
4 is the maximum you apply. Okay. Thank you.
4 is the maximum I use.
Thank you. Okay.
So, I will move to the other lesion.
So we'll go to the next lesion now.
Wait to see what happens on contrast.
The one that is considered non-functional. This one.
Yeah,
right?
yes, this one.
So the staff is happy if we take a biopsy from the other big lesion in the body.
Okay, so we move back to
Okay, so the idea is to localize the second lesion.
Second lesion, we remove that.
I don't want the bowel to move. Can we give a Buscopan now? And then after that, I'm gonna take the Axios 20 millimeter, okay, and I'm gonna preload it with the wire. I'm gonna freehand access the loop, but I'm gonna have a wire into the Axios as a backup in case I need to bridge it or anything like that. So my plan now is to use that angle between those two vessels. You can see there's one vessel here around noon, one vessel around 3 p.m. My aim is to basically go right in that, right where Sandeep is showing us the arrow going. That's probably the safest way to do this. Another technique will be if you can get there with the EOS scope or pretty close, you can do retrograde, anastomosis. But this was not possible. There was too many loops between. We did this slide before, so this is probably the safest.
That's right.
And more efficient technique. Can I have the access?
Especially we had the history of several interventions done by the afferent loop to reach the hepatico-jejunostomy site, and several failure interventions were done. And there was always a difficulty in reaching each time, increasing with the passage of time. So this would create a short path to reach the final destination in times to follow up. Look at Michel. He is fixed to that loop. He is not moving from that area, and that's the most crucial part. Now that he has placed the stand, we'll check it once again. Yeah.
Now we have to regain our angle.
That's right. And the landing space is quite good. Why are there several arrows there?
This part,
So you will not treat this part here.
Yeah, you do the lateral part, it's far away, far away. You can say that with that. So the needle is here.
Yeah.
So I'm gonna line up the bowel so that I have enough space
So it goes like this.
to deploy the action. So here I am now.
You see the tube here. That's a tube there.
There's a tube there. The axis is right there.
That's the other part of the tube. Yeah, yeah. I don't know why they're coming.
There's a lot of there's an invasion of arrows. So I'm gonna ask our contact man to remove the arrows.
Okay, and I'll just stay with one and keep it in the parking space.
And now the axis is hooked up. I'm gonna be ready to go.
So thank you, Pietro.
Sometimes one or two cutters, apparently.
It's the.
I always say that interventional endoscopy is a two-doctor procedure. It's not a single doctor. Like in the surgical theater, it's always two surgeons. In some cases, three surgeons.
Yes, I agree.
This has two benefits. First of all, you're not alone and you can discuss with another colleague what to do and what not to do.
It's very important.
And second benefit, the second operator is learning the procedure.
Yes. So now, the next step is
More, little more, yeah.
A little
Deform
bit
it.
more, yeah.
This has to be
Deform it.
deformed more.
It is a little bit more, just like this. Here it is. So,
Yeah.
so people say it goes from a ball of soccer to a ball of American football. That's how they say. So I'm going to lock it now, and I'm going to deploy it into my skull, just like that. X-ray, please. At this stage, actually, I'm going to push the wire. X-ray. So I have a wire as a backup here. Here is I have my wire. You see the wire.
the backup. And then, now, what I'm going to do is, I deploy the little thread. I'm going to now open it.
Below, we are on the left. So I have to move on the right. Okay.
Coming up, it's the water at the backup.
So if you can push some hole, because at that moment she starts another time to press a lot. Yeah, it's not possible. It's not There is two things which are important therapeutic or biopsy or what you want. The way the patient sleeps, the position of the patient. And after, you can work. Even you are the champion of the world, if the position is not good according to what you have to do, and if the patient is not sleeping, it's not possible.
It can be dangerous.
Yes, but you have not to do it. You have to do it. You cannot.
And in particular, when you're doing gastric biopsy, the excursion due to bleeding is more pronounced.
And through the liver, you have the liver, which is between the lesion, the area, and the diaphragm. But into the stomach, you have no liver between. So you have the left diaphragm, which is moving, and
in contact with the area of interest.
yes. And when you have a very fatty patient, it works because you have so much fat between the diaphragm and the stomach and the pancreas that does not work. When you have a small lady like this, the transmission of the diaphragm is very strong.
Transgastric pancreatic biopsy is more difficult.
So Michel, you have 5 minutes. This time I know that
It's also matter of the thickness of the muscle. Yes. And sometimes it also happens that I'll show you a case when we come to the session later on this morning that you push the gastric wall away with your needle and you lose sight of the needle. Okay, so this is why it's important to do the door knocking technique. Because with the freehand technique, you might lose the needle visibility during advancement of the needle.
It's actually a very, very good question. And we were talking with Giuseppe and then people like it. You don't want to create an astronaut who flows through the space and react at the level of the theory and practice. Because if you do that,
do something to improve. But you are free to do what you want.
So it's the way to optimize the positions.
No, but you haven't to do it if it's not.
You don't have the perfect position.
You remove the scope and you do that another time. The patient has to see.
developing after 10 days, it's fully developed after 3 days. The data for every day. And the fact that it's still away from the anastomosis, the food will not enter there. That. It's a very good point. The size of the animal, never beyond. If you go beyond, you can say,
In your clinical practice in France, do you perform all the procedures under the propofol or you intubate some patients?
No, for difficult case, everybody is for example, if it's my unit, the patient is intubated for
IFA.
Yes, of course, because you see, we wait 10 minutes to put the needle. And now we are in function and we 10 minutes in front. So, but for standard EUROEUS guided biopsy, no.
Just the propofol?
Propofol. Only propofol. Nothing else. Only propofol. And for difficult EUROEUS guided biopsy, which means that the patient has already been biopsied 1, 2, 3 times. If it's difficult, intubation. Because if the patient has already been punctured and the results is not thing, it's not because the doctors are not good. It's because it's difficult. And when it's difficult, you have to be in the optimal setting. So, when it's a standard case.
Thank you very much. I'm very happy to have you room number 7. Very happy. Tonight you are going to sleep very well. I know for sure. It's not, you don't have a nightmare on your room number 6. I know. Number 6 can become a bad number. Thank you very much, guys.
So I will show you what I call modified slow pull.
Okay, let's focus on the new one.
This is, so first of all, I verify the length of the course of the lesion. Can I help you? So second thing when I do that, I come back at the beginning, I remove 3 centimeters because this stylet is more difficult, and I ask to the nurse to remove 50 centimeters immediately.
Immediately, one shot.
Yeah, one shot.
Okay, let's go.
1, 2, 3. And now, so now stop, I adjust because I want to have the maximum length of the needle inside. And I do no door knocking method. I tap. I change the path.
Each time you advance the needle,
Yes.
full slab was the
Correct.
Okay.
Correct.
I'm done with the experiment.
Okay, I do one or two more. And in this kind of lesions which are very vascularized, never aspirate. Never. Never. Never.
In order to not contaminate the specimen.
Yes, finally, when you aspirate in this endocrine lesion, you aspirate the blood. And doing that, the tissue does not move in your needle. Blood which is moving. So you replace and the doctor has to look at what he has obtained.
Sorry.
Oh, sorry. Okay. So I have to check.
Let's go.
To get an idea what the whole pancreas looks like, to see if there's something you're spitting in the tail looks a little different. We'll go over the anatomy as usual. So I always start in the stomach, and I always face the front, I face the liver, and you can see one end of the liver here, the other end of the liver over here. So the middle is here. And then I'm going to just start torquing with my left arm.
Sì, no, faccio. Vai, faccio due letrini, Aspetta.
What's your first impression?
It's a white tissue. So here we have the diagnosis on this. On this one.
The second pass?
No. Practically no. It depends. But I don't do cytology in my unit. I do only histology. So everything is put in formalin.
And no rose. So there's no rose.
No rose.
You evaluate that later.
I look. I see white tissue, and it's good. You see the white part. See the white part is
this is the one that provides the diagnosis. Okay. Shall we let them in the room know that you are happy with the specimen?
Yes, I'm happy. I'm happy with the specimen.
So we'll continue with the pathologist.
From the hilum all the way to pretty much the ampulla here, all from the stomach. And this is pretty good because this guy's he's not skinny, and we're still getting very nice imaging all the way down to the ampulla here. Ideally, you want to see the pancreatic duct at the same time. So if I'm at the genu, I can see the pancreatic duct here, and I should be able to follow it down towards the head. It's not an easy move, but I can see the ventral pancreas here. And
Now we are preparing the smear. So we have split the volume between normal life that we currently do for adequacy. So we have very rapid hematopsin using staining. And part of the material is for vivoscope.
Okay.
So we split the two. And now we will make a comparison. We usually use do adequacy or needle aspiration with a 25 fluid, not with 22. And so this is very bloody, so we will see what happens in the two conditions. And both the material that is here in the alcohol and the one that we have used for vivoscope will be then prepared for cell block. So it will be used for histology, immunohistochemistry, molecular, whatever. Yes, so everything comes and will be used.
That's another thing in ultrasound. You know, what looks good to you may not look good to somebody else. But the important thing is to make sure the image for you lets you distinguish what you want to see.
So I can see the pancreatic duct here, and then his pancreas is a little bit inhomogeneous, but I wouldn't certainly call anything close to chronic pancreatitis. And if you're going to call, it's a whole different chapter. But if you're going to call chronic pancreatitis, it shouldn't be maybe. You only call pancreatitis when it's clearly abnormal, or you can say it's clearly normal. But everything
small convexity in which the material is
Placed, yeah.
placed, and it's very useful then for the cell block.
It's completely automatic. You don't need to do anything. Just place the specimen.
Just staining, and then the material is placed there, and they will make, and now he will make a scan.
Yes.
That can be monolayer or multiple layers, so you can
The
also go deep.
the operator who decides how to go.
Yes, yes, but the machine do it by herself.
still
Yeah,
following that. I'm pretty sure that's all pancreas. Okay, and the splenic vein is underneath. So everything makes sense. The anatomy has to make sense. So the duct is here, the
Wow,
vein is here.
that seems impressive,
makes
eh?
sense that everything here is still pancreas. So I'm still trying to follow up.
This is the preview, and now he will make a larger.
And then these images should be interpreted by a physician, or you also get a diagnosis from the machine directly.
No, the machine will not give you the diagnosis, but you need the pathologist to decide the pathologist to tell you what it is.
Hope that the patient doesn't have chronic
So how does it scan from up down, moving to the right side of the specimen?
I think we're basically looking obviously for a suspicious mass, pancreatic duct obstruction. People say you're looking for little cystic lesions like this here.
We see how it creates the panel actually. Yeah?
But I don't know how that really changes your management. I think the Dutch group have shown that if you start sampling these lesions, you sort of end up sometimes causing more confusion than anything else.
Not yet, so we hope so.
Demo version, you can say like
that.
So you're happy how
Yeah,
you're
I
happy?
like it very much. Yes.
Could they help you in terms of accuracy or even in terms of it goes more fast?
No, it's a matter of accuracy of different type of material, because when it's very bloody, because doesn't lose anything, and for us it can be very difficult to manage. But yes, it's a matter of material, and then it allows then immunohistochemistry and to perform also molecular analysis.
Here you zoom in manually.
I'm zooming, yes, because here we have just granulocytes.
Yes.
Here we have this very hyperchromatic nuclei, so I'm looking for the diagnostic material. This is difficult to interpret. Yeah, now.
This is the highlight, right? This is the portal vein coming out of the liver.
There are a lot of nucleus. Yes.
And so this guy looks like he has another node here. Looks like he's got some kind of inflammatory process kind of going on in the retroperitoneum. So in the tail here, I'm really not seeing anything really suspicious. They previously biopsied, I believe,
this very hyperchromatic nuclei, we can go eventually on multiple layers to interpret better. Also, so those one are better, but it depends on the layer. Now we will move to also to the slides. Yes, and also on the other side, on the left to me, they look like neuroendocrine.
Okay.
Yes, and so, and now we will move.
So if you didn't have the slides, you had only the microscope, you will feel confident to provide the diagnosis of neuroendocrine tumor for this specimen?
Yes.
Yes. Okay. Let's see the slides.
Now we will see the slides.
Thank you very much.
To avoid having false positives by seeing very subtle things that you see by EUS, it's almost better to use a test that's a little less sensitive. Really only detect so we've seen basically the whole pancreas here, all from the but many people don't do a deep enough intervention to the ball find the so you
Again, here is the same. So these are blood cells. These are more suspicions. Here we have those isolated ones. But for here, it would become very difficult to manage.
Down through the head of the pancreas.
But again, this is not something that we currently do on 22. That's the main difference.
This mainly for the 25G.
Yes, yes. It really looks different, and this is what is normally done in our routine. So with 22, if you have...
We don't see the image.
Okay.
Very.
So this is the bulb station.
Be very difficult to even see, but again,
Okay, I see.
25 it's the one that we use for this mirror, and 22 is for biopsies. So it's normal. I mean, it is.
I get it.
Okay. So I will go for all of them. For all of them.
And by the way, when you're in this station,
But it's all the same.
It's same appearance everywhere.
Yes.
Cross-sectional views of cystic disease.
To see what our colleagues are doing.
Going up to the wall here, because if you get this view, you know, this is the tip of the uncinate process. So this is all pancreas here. So then I'm just going to come back, and you have to keep in your mind, this is uncinate, and you're here, and the papilla is going to be around here. Okay, right around here. So you're going to pull back, and I tell the fellows, I say this is the hardest station. Just get into this position, torque left about 25 degrees, and look for some ducts coming around here. If you don't see them, go back to neutral. There's some little stuff going on here. Come back a little bit further, go left again, and then I see maybe a duct here, okay? And I'm going to pull back a little more, and it's getting darker, so I know I'm in the ventral pancreas. So the ducts should be going to, so I think there's a duct here, and the PD at this position goes like this, and then it goes up to the papilla. So I'm here, so I'm going to pull back to here where the papilla should be. There, okay, and we should see, I think, it's really, he's got a very lobular ventral pancreas, so it's quite hard to see. So now I'm just kind of, I'm pretty sure this is the ampulla now, but this isn't the best way to do it. You should be able to find the ducts, but this, I think, is the ampulla, which means that if I torque right, I should see the pancreatic duct somewhere. Yeah, there, it's kind of right in here, okay? And then there's the PD going to the ampulla. So once you're here, if you torque left, you should see the bile duct, and there's the bile duct. Okay, so this is how you get a long view of the bile duct from the papilla, which is here all the way back to here. So this is a nice view to look for stones. And when you are looking for stones, it's very important to get this view at the papilla because you can miss stones at the ampulla if you don't really get this view from the ampulla. I've seen that many times. Stones impact the dishes, the ampulla, at the ampulla if you don't really get this view. And again, here's the pancreatic duct. So you can follow the pancreatic, you have two choices now. You can follow the pancreatic duct around the genu into the stomach. And you would, again, exclude a divisum if I see the pancreatic duct leaving the ventral pancreas. Or if you want to focus on the bile duct, you can follow the bile duct like this. The bile duct will come back, and then it goes up into the hilum this way. Okay, and now it's going up into the hilum. Here's the portal vein again, and we're back to where we started the first time. So this is a complete view of the pancreas. Now I'm going to come back here and focus on the pancreatic duct, and now I'm coming across the genu here. This is another good view to make sure you don't miss lesions just at this junction between the head of the pancreas and the genu, and now we're going to fall back into the stomach and back at the pancreas here again. Again, we saw multiple nodes, like shoddy nodes all around this guy's pancreas. But basically, I see nothing dangerous, nothing personally I would biopsy. I would just
Anand,
recommend he get
will,
MRI.
will the aspect, Anand, will the
Yeah.
aspect of the ventral pancreas raise a little bit of stress, and would you change your routine in terms of screening or shorten the time of screening? What are the meanings actually of the microcysts and
Well, I'm not even
micronodules
sure
we
they're
have seen on the ventral
microcysts.
pancreas?
Yeah, I'm not even sure they're microcysts. I can look again, but I wouldn't really. It was really completely limited to the ventral pancreas. So I just think it's
And
just.
what do you tell the patients after this procedure? Would
I
you
would
say,
still tell them
okay,
we'll do an
you're
MRI in
fine?
6 months and then once a year, and I wouldn't freak too much about the appearance. I can see there's a very globular ventral pancreas, and if these were cysts, it would appear on the MRI. I think more convincingly. So I would just still MRI in 6 months, then once a year. Some people like to alternate MRI with EUS. As I say, I'm not very. It's not like I'm looking for these patients to do. I find that EUS is very. I don't know. It never seems to really show anything very useful in our experience. I don't know what everybody else would do, but or people are really doing. I think if you're going to do screening, you have to have a protocol. Like you have to have an idea of what you're going to do with the results.
And
Because
can you hear me?
yeah,
Yeah. So great examination. It takes the time that you usually spend for 3 or 4 procedures. Thank you very much for showing us all the anatomy and to discuss also about the possibility to over diagnose in this patient. So now we move. Thank you very much.
my pleasure. Thank you.
Now we move to the pathologist room because we have already performed this morning 2 FNB procedures. As you remember, the first one in the first case performed by Adrian Saftoyo in the differential diagnosis of neuroendocrine tumor, and the second one has been performed by Professor Palazzo in the patient whom he has treated a neuroendocrine tumor. So now we move to the pathology room. Professor Pedica is one of our associate professor in the Department of Pathology, and she's going to present us the cases. Please, Federica, thank you very much for joining us.
Thank you. Good morning to everyone. Thank you, Professor Archidiakonou. So now we will move to the first case that we have went through this morning. Here we have, first of all, we have assessed the material for the smear and also for Vivascope. So now we will go through the procedure and we will see what comes out from Vivascope and from the smear. We have to say that it has been used a 22 gauge needle, and so it can be difficult for, let's say, the normal smear to be prepared on the slide. So now we will see what happens with Vivascope. We put some of the material, which was quite bloody, on the cytomatrix, and now we will go through the procedure and see the slide.
Okay, so in other cases, we show you how the procedure works directly from the putting the content of the needle. So we don't have a set coming, but you see it then afterward. But in principle, if you come up here, so the content of the needle is directly put on this special matrix, the cytomatrix, which is especially designed and developed for cytological, but also microhistological material. And the content of the needle is retained by the special matrix. We do a fast staining procedure that takes less than 1 minute. And at the end of that, so there is no smearing of the material, there's no interfering to the material. At the end of that, which you will see then later, we mount this in between glass slides, and then we put into the scanner, and the result And now here, so in approximately 3 minutes from putting the content of the needle on the cytomatrix, we have then an image like this, which is the already digitalization of the fresh tissue, and now the pathologist will evaluate the image, so she can then zoom in the different field of view.
Thank you. So as you can appreciate, we have a very cellulated lesion, and if we go deeper, we can appreciate that we have a lot of small intermediate size cell with the salt and pepper and chromatin. Uh, we can appreciate that there is some cytoplasm. It can be not sometimes so easy to see the perfect detail of the cytoplasm, but the nuclei are very um, clear, and so we can assess directly on this smear that we have adequacy for the diagnosis. Since it was very bloody, what came out from the slide, it was bloody, and so we have just a few number of cells on the glass compared to the site to the material that we can appreciate with Vivascope. But again, it depends on the material that you have. So if it's very bloody with cytology, can be very difficult to with core biopsies to allow for the preparation of the material. Instead, with Vivascope, it is all retained in the cytomatrix, and so you can appreciate the whole material. So then we can make the comparison there on the slide. Here, if you can turn around. Okay. Okay. Sì, sì. Okay.
Professor Pedica?
Yes.
Yes.
Here is the. We are going to the microscope. The how it looks like. Okay, so here we have the same cell that we have seen with Vivascope. Okay, and here we are. So that's the same. Okay, and this is on the cytological material that we routinely use for diagnosis.
Thank you very much for
You're
this
welcome.
fantastic demonstration of the use of Vivascope to
Thank
detect the specimen in very few minutes. So now we are moving to our first connecting center from abroad. It's my pleasure to connect again with Hong Kong with Professor Anthony Teo, who is clinical associate professor of the University of Hong Kong. And I see they are already performing the procedure. So Anthony, can you hear me?
Yes.
Oh, great to see you. Welcome back to EUROEUS. Thank you very much for joining us.
Yeah, so I have with me Dr. Kevin Chen. Oh, hello. So she is
Hello.
our assistant professor in Prince of Wales Hospital. Thank you. So we have a case of metastatic pancreatic cancer. He's a young gentleman, only around 43 years old. He first presented with obstructive jaundice late last year. At that time, I did a CDF for him. And then this time, he was on chemotherapy until recently. Started complaining of gastric outlet obstruction. So this time, we are planning for a urostatic gastroenterostomy for this patient. Do you have the X-ray films? So just now we have performed a EGD and then inserted a guide wire past the stricture. The stricture is at the D3 level. So we are performing this with the freehand technique. So Shannon is inserting the oral tube and hoping to traverse the stricture and use the oral gastric tube, oral tube to distend the small bowel. So Shannon, you are having some difficulties?
Yeah, so the stricture is at the D3, but as you can see on the X-ray, I couldn't really use I couldn't really get the feeding tube across the stricture. So now I'm inserting a ball tip within the feeding tube, hopefully to make the feeding tube more firm and stronger, stiffer. So then it helps me to pass the feeding tube across the stricture.
So sometimes I think with these strictures, we also can have some difficulty on inserting the oral gastric tube. So sometimes we may actually need to reinsert the OGD and then push the feeding tube down. I think we have changed to a linear scope already. So let's hope we could push the feeding tube down without this.
So in some centers that I've been to, they use a nasal biliary drain instead of a feeding tube. So the good thing about using a nasal biliary drain is that you can insert it through the scope. So the chances of not being able to pass through the stricture like now is much lower. But unfortunately, in Hong Kong, we don't have the largest French of a nasal biliary drain that we found was only 7 French. So that's why our routine is to use a antiflex. Okay.
So I think many of you have heard about the trial we published in Lancet Gastro this year. For study, we compared years gastroenterostomy with duodenal stent. In that study, we used the EPAS technique for the gastroenterostomy. But right now, we don't have that double balloon device anymore. So we are doing this with the freehand technique. So right now, the positive can pass through the stricture, but the feeding tube cannot. So Shannon, what is the plan?
So I've encountered situations like these before. So I tried doing this procedure with just the ball tip for water infusion. So the downside about using a ball tip is that it's only 4 French or 5 French. So the water injection would be much slower. But I guess if you can't pass the feeding tube, then this is our only option.
Would you consider inserting the gastroscope to push the feeding tube?
I think we can, but I'll finish the contract. I think we can, but I've done cases with the ball tip. Okay. So I'll insert the ball tip a little bit. Okay.
Seems like you have some movement. The system phase on.
Okay.
So Shannon, you have tried both the EPAS as well as the freehand. I think many experts have said that you don't need the EPAS balloon. What is your comment on that?
I think EPAS is very good for beginners. Because it's a very stable platform. A loop of distended valve is there, and you can just directly puncture it. So it's very safe. The whole procedure is very stable, and there is no stress in that procedure. But the bad thing is it's very cumbersome. You need to exchange a lot of scopes. You need the overtube and things like this. But with the water infusion technique like this one, it's quite a relatively simple procedure and less steps. But sometimes it gets a little bit stressful when that loop of valve is not too distant.
So I think for experts, both any technique you use, it's okay. But of course, you have also seen experts on the tests, especially during workshops. So the freehand technique does require some skill, and you really need to descend the small bowel and exchange devices quickly in order to deploy whilst the small bowel is still distant. I think we're going to try again.
Hi, we have a question from the audience regarding the French of the catheter. Should we aim for a jejunal?
The one that we are using is a 10 French for that here.
So So the nasojejunal tube we're using is a 10 French. It allows quite a lot of saline to be extracted rapidly. But right now, it doesn't seem to be going through.
It's a little bit stuck at the, I think it's at the middle of the structure.
It's a stricture, yeah. So, I think we have two options: either to use the ball tube or insert the gastroscope and push the tube down. So,
I think we can just try
the ball tube catheter.
Yeah, okay. How many? So, for me, I like to keep the guide wire inside, not do the USGJ. As long as you're feeding, and yeah, we connect at the back of the feeding tube. So putting the wire in here actually gives me a good anatomical idea of where the DJ flexure is. So later when we swap to the US scope, I would aim at the DJ flexure. So I know that some experts don't use guide wire, but I feel that this way is easier and quicker for me to find a suitable loop. 你可能要揸住呢一堆路，咁啊跟住呢個放一放俾我望，係啦。
Okay, so I guess we are now changing to the US scope. Okay. So what I'm doing now is to infuse the small bowel with saline. Because this is only a 4 French catheter, it's a bit small. We might need a bit more time. But it looks like it's getting a bit more distended on the X-ray.
So another time when the catheter may fall out is when you insert the US scope, because now I'm pushing the US scope in with the catheter in situ. So I usually do it under fluoroscopy guidance just to make sure that the catheters don't coil in the stomach. I'm inserting very, very slowly. Okay. So now with the wire, as you can see, I can identify. So this way is the wrong side. I'll try to identify the loop profile that is distended. So I can go here.
Right.
So as you can see, I've already identified this loop profile. So we know that the stricture is in the D34 region. So I'll try to see if I can go away from it. We also see our guide wire in the US loop. So with this, I should trace this loop profile. And then I know that in front, because the X-ray is guiding me, I know that I will see this long loop profile in front of me. So you see there are actually two loops profile in front of me now.
I hear from the audience, it's true that this is very important and sometimes very challenging to choose the good regional link from the anastomosis.
Very good for.
I don't know if you are listening to us or not. So what are your advice regarding the choice of the good place to perform the anastomosis? Because sometimes you have a lot of different regional limbs dilated.
Can you say that again? Can you repeat that again?
Yeah, sure. I was discussing the choice of the correct place to perform the gastroenteral anastomosis, because sometimes you have a very dilated jejunal limb at several points, like for example in your case actually. So how do you decide to go further in one jejunal limb or another? How do you choose the place?
I think there are several things we need to consider. One is whether it's close to the stomach or not. Here you can see a vessel. I think that's a vessel. Yeah.
So I was going to puncture this loop because it looks quite nice. But you can see here that there is, I'm not sure what vessel it is, but it's quite prominent. It's a big one.
You are not afraid when you are targeting one distal jejunal limb to pass through another structure like another jejunal limb or even a colon structure, because at this point can be challenging.
Yeah. So this looks like a nice limb of small vowel, which is quite different. I'm gonna inject freely, see if there's any effect.
So for me, I usually try to choose a location if I have the option nearer the DJ flexure. Because with the guy wire, I know where the DJ flexure is. And the reason is because anatomically, the D4 and the DJ held in a relatively fixed structure. It is fixed by the ligament of Treves. So theoretically, I think that the chances that my stent will slip away is much smaller. So that's why I just prefer a more proximal location. Of course, you need to decide. It has to be distant to the structure.
Okay.
So let's see the doctor. Oh, so
I don't know.
if I rotate right, that vessel is gone. If I rotate left, that vessel is right here at the 3 or 4 o'clock meter.
I don't know if we can have larger the endoscopic ultrasound screen, maybe.
We change it and can we change the sequence? Maybe? Yes, thank you. So this sort of file is quite the standard.
So you see,
Yeah. And the distance between the bar and the stomach is only 5 millimeters. Okay.
okay, 呢度嚇1、2、3。
So I think the key to this procedure is, take your time, find a file that is well distended, very close to the stomach. Of course, we try to locate the DJ flexure as well as possible. And can't, then just go for the safest file, which is closest to the stomach. And for this patient, we also injected buscopan. So right now, Shannon has already deployed the stent in the channel. He's pulling back to try to visualize the stent.
So you should expect the stent. You should expect to see the stent in the right upper quadrant. So in general, it's a right top and down scoop position. It's here, the whole gang. So now you see the edge of the stent at the 3 o'clock region.
You can push it out there.
So sometimes the axial stent gets stuck. So sometimes you need a little bit of force to push the stent out. So in general, you should see blue colored fluid coming out from the from the stent to confirm. So as you can see here, you actually can see a bit of the blue fluid. So suction a little bit. And you can see the blood fluid coming out.
Maybe I should remove it.
Congratulations, was a very, very challenging procedure. We have been discussing before regarding other internal anastomosis about the benefits of dilation. Are you suggesting also intraoperative dilation during the same procedure or not at all?
So we do not routinely dilate it because in general, after 24 hours, it automatically dilates. So I think it's okay to just leave it as it is.
We have also one question for the audience regarding the usefulness to inject some of you through the nasogastric tube to identify a correct intestinal loop.
One of you. I think you can do that, but we don't routinely do it. So I guess if you inject monoview, then you are injecting it intraluminally, and then you need to change to a contrast imaging mode to see it. So that might make it more difficult.
I think the use of the guide wire is very helpful in identifying the correct limb, rather than using contrast. Because I think water infusion, if you're able to dilate the loop profile, you would see water and a distended loop profile. So as the addition of contrast, I'm not really sure it helps a lot with the identification of the
And what is your protocol afterwards for these patients? You are like recommending a normal diet in 48 hours, the day after, or a progressive diet? How are you proceeding?
In general, we wait for 1 day, and then tomorrow we let the patient on liquid, and the day after we'll let the patient on soft diet, and after that we can discharge the patient. And in the long run, we tell the patient to avoid high residue diet and to avoid large chunks of food like post-hysterectomy patients, and have small frequent meals. So in general, this is how we deal with our patients.
Can we have please a bigger picture of fluoroscopy just to see the final situation?
We have the X-ray as well, please. Thank you.
Great.
So this patient has two axials. So on the patient's right side, you can see the CDS. CDS, we purposely make it more angulated towards the hilum. So in this way, there's less chance for the opposite wall of the bile duct to hit on the center of obstruction. And on patient's left, you can see the gastroenterostomy.
Anthony? Anthony?
Yes.
Thank you.
Thank you very much. Thank you very much for joining us. A fantastic demonstration, fantastic procedure. I hope to see you again in the next future and for sure joining us for the next EUROEUS 25. Thank you very much, guys.
Thank you very much.
Thank you.
Bye-bye. Thank you.
Bye-bye.
And now we move to the presentation of the next case in room number 5.
So the next patient is a 33 years old with a female. So the patient with self-palpation in January 2024, like an abdominal tenderness. So she undergo abdominal CT scan and MRI that show multilobulated fluid-like lesion of the pancreatic head with septation of 50 per 63 per 6 per 50 milliliters in size. Suspect for serocystodenoma. No dilation of MPD and CBD. The blood test shows normal tumor markers. Today's procedures, US guided fine needle aspiration with rapid onset evaluation. The operators, Prof. Soroli and Prof. Palazzo.
Pietro, can you hear me?
Of course,
Pietro?
very well.
Okay.
Yeah.
So thank you very much again for coming and joining us and show us what you see.
Yeah, thank you. I will need all the help of Laurent and of all the people in the room to try and solve this difficult case. So if we can have the EUS image, the scope is, which is a therapeutic linear scope from Fuji. It's the EG740UT with a 4 millimeter channel. Is already in the short position in the second portion of the duodenum. So you can see the abdominal aorta, which is the main landmark in the abdomen for looking at the pancreas. And if I torque counterclockwise, I also see the inferior vena cava. So I want to stay on the plane of the abdominal aorta in order to find the head of the pancreas. And if I pull back a little bit and torque the scope, I want the scope to be nice and straight outside the patient. Here we come in front of the pancreas. We can see a little portion of the pancreatic duct there. Thank you, Laurent. And we already see this huge.
So this is the Santorini duct here.
Santorini duct over there. You can hear also Laurent, of course. Bile duct up there near the probe. So the papilla is at 9 o'clock in this moment. So the pancreatic parenchyma looks pretty normal. We have a beautiful imaging with this advanced linear echo endoscope. So you see that both the bile duct and pancreatic duct do not show any abnormality, no dilatation at all. So if I pull back the scope gently a little bit, we see this large lesion. And as you can see, there are septa inside. So these are macroscopic cysts. At first sight, there is no evident solid component inside the cysts to assess. No evidence of solid components.
No calcification.
No calcifications also.
Yes, we will do it, but not. We have to wait.
We have a previous evidence of poor or no enhancement at all of the septa, but we might check this again with contrast. So, Laurent, do you think,
yes,
yeah,
yes,
we can have an idea of how big
with the size,
this lesion is? Yes. You see, it's more than 6 centimeter in diameter. It's roughly 6 by 6.
yeah.
Yes. So, differential diagnosis, since this is a young lady, we're in the head of the pancreas, we might be looking at a macrocystic serous cystadenoma. This is one option.
This is the more frequent.
The more frequent.
Okay.
But also, I think we should consider an side branch IPMN.
Why not?
Why not?
Why not? It exists, so why not?
Yeah.
Even this size, even a younger lady, it's possible. And it could be a very rare mucinous adenoma, but so much septum are usually not seen in a large mucinous adenoma. And finally, it could be a cystic angioma,
Yes.
which are possible in young patients and which are a part of them into the pancreas and a part outside the pancreas. So
another question I think we should ask ourselves is this cyst arising from the pancreas or from the mesenteric sleeves, maybe like mesenteric cyst?
here we seems to have the beginning inside the pancreas.
Yes.
Seems to be covered by the pancreas.
Surrounded by pancreatic
Yes,
parenchyma. And this is also the evidence that was shown by MRI. We are looking for some possible communication with the pancreatic duct, maybe down there, if you sometimes.
Pietro?
Yes.
Pietro, we can already exclude, I think, pseudopapillary tumor from the leukoplate.
Yes, but usually they are the wall. Solid pseudo-papillary tumor usually has a wall, and usually have also a solid part in in one area of the cyst, on the border of the cyst. You find a solid part, which is small or big, but it's very rare and likely never that you have a solid papillary tumor with only cyst.
So now I'm scanning through the stomach. I want to take a quick look at the rest of the pancreas. You should never make the mistake of focusing on the lesion of interest only. The pancreas has to be seen completely in every EUS examination. Otherwise, we might regret it. Sometimes we might see just the big lesion and we overlook some smaller things, but that might be more important.
So here the spleen, so we are at the tip of the tail.
Yes.
Here, okay. So there is nothing. This is the splenic hilum with the vein and the artery. Then the vein, the artery, then the tail, and there is nothing.
Nothing. So, and also the pancreatic duct is completely normal.
Normal. Yeah, we see it. And the pancreas is perfect.
The pancreas is perfect.
It's the
So,
demonstration of pancreas.
so let's go back to the duodenum
Yeah.
now
And we will try to do contrast.
Yes.
When it will be okay, d'accord.
So I'm pushing the scope back to the duodenal bulb in order to have a stable position. When you are looking at a lesion that is in the head of the pancreas, also when you intend to perform some sort of tissue sampling, the long position in the duodenal bulb is more stable than the short position when coming back from the second portion. So I like this position better. You
Me
see,
too.
we are now much more stable than
So
before.
we will prepare the contrast. Wait, we change the settings. Okay, so here we have mechanical is 0.16.
I will reduce the size of the image. Maybe
Yes,
we
yes.
can look at the whole lesion. Yes. Okay, nice.
Okay, so 0.16, and we are ready.
Is the focus automatic with the contrast here in this setting? Okay. So with this view, Laurent,
Yes.
I think we can investigate the outer walls of the
Yes,
cyst
and the septum.
and the septum, and probably
This septum.
I will try to rotate around
Yeah, yeah.
and try to
And
get a glimpse of
so we
the
are
whole lesion.
expecting a strong contrast and a long duration contrast in serous adenoma, and the contrast will disappear in 20, 30 seconds, 40 seconds in the rest of the possibility.
Yes.
So
So
you
if
can
we're ready to inject, I think we can inject the full vial in 4 seconds. Then we start the counter. Can we start the counter, please? Okay, contrast is coming. You have to look at the right part of the screen, right part. So I think, Laurent, we have a nice enhancement of the septum.
yeah.
It's definitely enhanced. The
And
outer walls are also enhanced. I look around a little bit.
now we will see if the bubbles continue. The duration of the contrast is long or short. When more than 1 minute after the injection in the thin septum, you still have bubbles moving. It's highly suggestive of serous adenoma.
And this is the case, isn't it?
And this seems to be the case, yes. You see, the septum are very thin and you still have the bubbles moving inside, you see? And this is very rare and in my opinion, never occurred in other type of cystic tumors. Of course, on the crown tumors, cystic, they have an enhancement, but this is an enhancement of the wall, and they never have a 6 centimeter size, and the contrast disappear quickly.
So now we have to
Laurent,
discuss.
there is a question
Yeah.
in the room.
Yes.
The question says that sometimes the cyst is so big that you cannot focus on one area, you have to move around, and the time of contrast is short, so you don't have time to
We
see
have to move around.
everything.
We do it gently because we don't want to create artifacts. Because if you move it like this, everything seems enhanced, and that is of course a false finding. But if you
But here you still have the bubbles moving in the small septum. It's very, very, very rare outside the cirrhosis adenoma.
yes. So now I think we should ask ourselves, what should we do next? What's the indication to do? What the right thing to do? Has this lesion been sampled before? No, never. So probably we should go back to classic old school and do sampling of the mm, cystic fluid and see what it looks like. We look for CEA, we look for amylase, we look for glucose and cytology, of course, and try to make a differential between SIRS and IPMN. Is this the plan?
Non, ça c'est le contrat de connexion.
So
De
if this
revenir
is the
au
plan, we need antibiotic
Ça, c'est non, il y
prophylaxis
a
for the
le
patient.
MD est toujours inscrit.
It's been given already. Great. And what needle should we use? Is everybody happy with this decision in the room? Does everybody agree that we, given the young age of the patient, we should try to have a definite answer for her and maybe not send her for
Can you please raise hands for those who are in favor
for
of
lifelong follow-up?
FNA?
Because the other chance is only follow-up.
Everyone is happy with your decision, Pietro.
Yes. Is
And
someone
there
in
is a
the
question in
audience?
the room. There is a question. Do you consider also using through the needle biopsy forceps in this case?
Yeah, that's a good point. It could be an option. This device is not available, as I understand, but it could be an option.
And the other option could be Cellvisio.
Of course, it would be probably the most useful
Yes.
tool
Yes,
to have a.
Cellvisio in cirrhosis adenoma show you the pathognomonic aspect. And if you haven't, it's not cirrhosis adenoma. If you have, it's 100. Through the biopsy, needle biopsy in cirrhosis adenoma, it can work, but you have only 65% sensitivity. So, okay? And because it's very vascular, you have, in many cases, hemorrhage. When it's an hemorrhage in a 3 centimeter cyst, it's not a problem. When it's an hemorrhage in a 6 centimeter,
Okay.
it's more.
Okay. Thank
So
you.
I think the needle is good.
Thank you for talking about hemorrhage before the puncture. So
No.
I can. You said I should touch wood.
No. It's when we use through the needle biopsy.
Okay. So speaking about needles, I think we need a large bore needle, like a 19 gauge here, and maybe a cytology needle, not a histology needle. Is this a cytology or because they're showing me a shark needle, but I presume that is a FMB needle. What about an FNA needle? Have you anything available? Because we don't really need the FMB needle in
No,
this case.
because we have nothing to FNB.
And it could be in.
And it could be
And
more.
Pietro, what are the markers that you are
For
planning
the
to
for the
ask
safe for the safety of the procedure, FNA is better. I'm trying to concentrate on one large cystic cavity like this one. Could be good. Of course, I don't want to traverse all the septum.
No,
and
because
do,
this one is a big septum and it's.
I'd like to leave it alone
Yeah.
and try to concentrate
This
maybe
one.
just on this one.
Pietro, what are the markers you are planning to ask for? And there is
Sorry?
a question in the room. If there is a discrepancy between
Yeah.
glucose and CEA,
Ah,
Yeah,
the
yeah,
cost.
yeah, 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 yeah.
If
Yeah,
it's
yeah, yeah.
possible, if
Yes.
it's possible.
There are two parameters which are interesting: glucose and CA, and glucose can be done on glucometer. So in the room, we know. We don't wait from the laboratory test. Of course, we do also lipase, of course. Of course. But lipase in serous adenoma is often normal, but often abnormal. So, like this.
So this could be.
The question was if there are discrepancies between glucose level and CAEA level, what
Microtech.
would you consider good?
So we are going to use a
Gradually.
19 gauge FNA needle by Microtech. And we also, thanks to the suggestion from Julio, we also have a glucometer here in the room. We might try to do a real-time glucometric evaluation, which is a new form of ROSE. So this particular needle is not wheels, but buttons, which is, I find it very convenient to use. The blue color for the FNA needle and the red color for the FMB needle. I have to tip down a little bit in order to allow for the needle to be securely in place. And then I have to find my position again in front of the cyst. Of course, this needle is very stiff. So this cyst is the gallbladder. It's not the pancreatic cyst anymore. Okay, now I'm in front of the real pancreatic cyst again. Okay. So I'm trying to pull back gently and see what I can do. Let me see if I'm able to advance the shaft of the needle at this point. Pretty. Okay. Okay.
Another
Now,
small question, single question from the audience regarding the antibiotics. I think you have already recognized antibiotics in this case. What about the diclofenac administration?
I didn't quite get the question. Did you, Laurent?
So
Yeah, regarding the use of antibiotics in these cases and also diclofenac administration.
I think that antibiotics, we still have guidelines recommending for antibiotic prophylaxis. So I would definitely say yes. Regarding diclofenac, there is no evidence that it's recommended to do so. So you see the tip of the needle over there. I see no particular vessels that should be hampering the procedure. What do you think, Laurent? Do you think this is a safe window? So I retract the stylet a little bit. I let the needle free. Here comes the needle. And now I'm inside. So I advance the stylet again to clear the needle of some cells from it. And we can remove the stylet.
Laurent?
Yeah.
We must move to another room, but thank you very much for the talk and nice demonstration. We will wait for the evaluation of the fluid markers and some cytology also. So
Okay.
now we move to the presentation of the next room, room number 6.
The next case is a 46-year-old female. She had an emergency room admission at the last January for new onset of jaundice. Blood tests showed increased cholestasis levels, and the abdominal CT and MRI scan showed lesion at the liver hilum. It's about 5.5 centimeters, suspected for cholangiocarcinoma, infiltrating proximal bile ducts, Klatskin type 3A, and cystic duct. Multiple lesions within the right biliary system and infiltration of portal branches.
Okay? Professor Shahal, Professor Di Matteo, Pablin, Francesco, hello.
Hello.
Welcome to EUROEUS. So now is your turn.
Oh, thank you so much. So we already introduced my co-pilot, Professor Matteo, and then we have excellent team here. Paulo, we have Marta, we have Mauro, and we have Rafaela helping us with anesthesia. So we heard about the case, and we were trying to come up with a plan on what our strategy is going to be. I'm starting with the scanning of the liver, left hepatic lobe, and as we come closer to the porta hepatis, you start seeing quite a bit of a bulky adenopathy. So there you start seeing the lymph nodes. You see the portal and IVC going close. Just quick, as I torque clockwise, immediately you start seeing the aorta, celiac axis, and then it's an easy scanning if you want to scan the pancreas. There you see the genu, portosplenic confluence, going back to the body and tail. So left kidney and then spleen. So I think back home I would have gone for the lymph nodes because we are a liver transplant center, and the role of EUS in hilar cholangiocarcinoma for us is scanning for any lymph node for nodal staging. We don't go after the primary lesion, but this patient is already metastatic, so the goal here would be to go after the primary mass. So I'm in the bulb right now, and where you start seeing the common bile duct, and you start seeing the irregularity, thickening of the wall, and as I talk counterclockwise, tipping my big wheel away, you start seeing the primary lesion. It's a rather bulky lesion, very heterogeneous. I estimate this to be more than 2.5, close to 3 centimeter in size. So we're going to go after the primary lesion, and we can talk about the pros and cons and the risk of going after the primary versus nodal staging. So I'm using the Olympus linear scope, and we are going to go for a 22 core biopsy needle. I'll be using a Microtech core biopsy needle. We already did the Doppler exam. It's not an intensely vascular lesion. Cholangiocarcinomas by nature, they are highly fibrotic. And I think in anticipation for ERCP, another thing that I try to do is I see if I can follow the bite above that. So this appears to be a rather long lesion. I guess the stricture is going to be at least 2 centimeter long, if not more. And then once we get to the ERCP part, we can talk about the strategy on how we tackle the hilar lesions and some of the important points in terms of the volume assessment, targeting the right versus left. It's not so much right versus left, it's about the volume that we try to drain. And this person, I think you saw on the imaging, has a really hypertrophic left lobe. So not 30%, looks like almost 50% of the drainage comes from the left lobe. So as we see, this is a Doppler core lesion, and I'm in the bulb. So we are going to go after the mass, and we have the digital on-site analysis. So we
push there.
Okay. So what are your thoughts, Matteo, about going after the primary versus the lymph node?
Yeah, I think
it was a nice light yellow with fluid, and the glucometric analysis showed 99 milligrams. So this was for us a clear demonstration. You were saying that this is a serous cyst adenoma. You were saying you had a similar case last week.
The same. Typically the same, young lady, large polycystic lesion with a lot of symptoms. Contrast, we show that the contrast remains more than 1 minute or 2 minutes inside the septum. Fluid which was like urine. Why it's like urine? It's because you have small blood, spontaneous blood into the serous adenoma, which are so vascular and it sometimes like water, but rarely. The majority of cases, you have some bilirubin inside, so it's the reason you have this color. And when you have this color, the non-mucinous, non-viscous, you know it's a cirrhosis adenoma because you have a cyst with bilirubin, and the cysts with bilirubin are usually 99% cirrhosis adenoma plus the glucose.
Now
Sorry. You mean you explained that when cysts are so big, it's difficult to maybe find the correct origin of the cyst from pancreas or mesenchymal cyst. Do you think glucose in this case could help us? Because I don't think we don't know.
I think we have no doubt about glucose levels of mesenteric cyst, but still, as Dr. Palazzo pointed out, the cyst was clearly surrounded by pancreatic parenchyma. So in this particular case, I presume there was no doubt that this is a pancreatic cyst.
It's mainly into the body of the pancreas that you can have discussion, neck, body, because sometimes the cysts are clearly outside the pancreas and they are close to the pancreas, and you don't know if they are born from the pancreas or they are pushing the pancreas. So in that case, it could be interesting to do a series of mesenteric cysts and to know which is the level of glucose in mesenteric cyst, and perhaps it will be low. Perhaps if it's high, it's not discriminated. It cannot discriminate, but it's low. Why not?
So now we will send the patient the fluid for CEA and amylase evaluation, which we expect to be both very low, and also we will send it for cytology, but I don't expect any information from cytology. I think there will be no cells in that fluid.
And finally, we have to decide what to do on that lady. If we say it's a cirrhosis, okay, and I will say, well, right. If we say that, we will say to her, ultrasound every 3 years.
Yes.
These are the guidelines.
Percutaneous ultrasound.
Percutaneous ultrasound every 3 years is sufficient. But we have to be sure.
Yeah, but so we cannot discharge her from follow-up. So follow-up is still necessary.
Every 3 years.
Okay, and what about through the needle biopsy? Do you think in this case would be useful, or?
We discussed during the session through the needle biopsy in cirrhosis adenoma can work, but not always. The best through the needle technique is confocal, because confocal is 100% specificity and near 100% sensitivity for cirrhosis adenoma. So if you have the aspect, the contrast, the glucose, the CEA, and confocal, it's 100. It's 100. Now with everything we got, if we have a low CEA, low amylase, we are at 99.
Yeah, but in that case, if you did a confocal, I think that septum was probably too thin as a target. You should go for the wall.
On the wall. So you have to choose
not to the septum.
Not the septum. On the wall. Okay, so we are 99% sure it's a cirrhosis adenoma. We can stay like this and do just every 3 years. But in the unit of petrol and in my unit, we do confocal.
Okay. Okay. Thank you so much.
Thank you very much.
See you later.
Vogliamo andare io? Giovanni, la setta proiezione, sì. Presenta questa saletta, sai come il
We are going to see.
So mainly the risk of bleeding. So as such, when I'm going in this location, you're going.
Drinking lots of
interview.
So are you enjoying the
Yes.
conference?
Since the coffee has arrived, I'm in a much better mood.
When you arrived?
I
This
arrived
morning?
yesterday. Yeah.
Are you, what do you think about the last procedures?
So,
What about the cyst?
so the cyst, they should not have punctured that.
You shouldn't
It was a big mistake.
Don't tell them.
No, I mean, it's not going to change management for sure. And he's lucky he didn't get any bleeding or anything or infection so far. But
So you in your hospital, you would what do you do?
because I think if you're going to puncture a cyst, it should be because it's clearly going to change management.
Yeah.
So in that cyst, no matter what they found on the analysis, there's nothing that was going to change management. And if that was a mucinous lesion, which I think it ended up not being a mucinous lesion, it had no criteria for surgery. The Fukuoka criteria, based on mural nodules, main duct dilation, there was none of that. And also, it just makes sense to me that a cyst that is that big, 6 centimeters, it has no mural nodules. There's no way this is a dangerous cyst. A mucinous lesion that becomes dangerous, by the time it gets to 6 centimeters, it's going to have mural nodules, very heterogeneous content, everything. So for sure, this is a benign cyst or a congenital cyst or some cyst that, whatever it is, it's not dangerous and it's not going to
But you
change.
just continue the follow-up?
Yeah, so we would say MRI, if it's a new cyst, first time, I would say MRI in 6 months. And then if it's stable at 6 months, then once a year. And that's it. And it's also important if the patient is very elderly, wouldn't even recommend follow-up because if you can't operate anyway, there's no point. But I think you have to reassure that in general it's very, very benign. It's like a mole on somebody's face. Some people have big moles, small moles, but they can get bigger, but it's not dangerous.
Okay. Do you think in that case the contrast could help us?
Because I say even if they on the cytology they got, for example, dysplasia. Okay, very scary. But still, in my hospital, they would not operate on somebody who has dysplasia. There's no nodules, there's no wall thickening, there's no nodes, there's no mass, nothing. They would still follow it. So they still wouldn't, even if the CA was 12 million, they wouldn't do anything. I mean, you don't operate because the CA is high. So it would still be, it's primarily the morphology. And if there's no signs of aggressive behavior, we just follow. So aggressive behavior is large mural nodules. The mucus starts getting very hazy, meaning it's becoming very cellular, wall thickening, pancreatic duct obstruction, or symptoms. But if you don't have any of that, we don't do anything.
Okay. Thank you. See you later. Maybe
use ways to evaluate the access to further hepatogastroscopy before passing to ERCP. I mean, to check if the intrahepatic bile duct is enough dilated, how to position the position of the scope is getting, and so on. So, do you think this will be a recommendation in these cases?
Yes, so yeah, you bring up good point. So EUS is not just for the diagnosis, you're also trying to plan what the next step is going to be.
Probably.
So yes.
Sorry to interrupt you. While you are waiting for the rows and to decide what to do, we move to another room just for a while to present the case because they are on the right point now. For the people who wants to follow your case, you can follow on UX Express channel directly. Okay, thank you.
Great, thank you.
See you in a while.
See you.
Next case is a 67-year-old female. In 2022, she had a diagnosis of breast cancer treated with chemotherapy and surgery with no residual disease. In February of this year, she had an ER access due to dyspnea and jaundice. She received CT scan and MRI scan, which revealed a large lesion involving the right liver segments, extended to the biliary carrefour, the portal vein, the gallbladder, and the pancreatic isthmus, with also multiple distal metastases. We performed a US FNA with confirmed diagnosis of metastasis from breast cancer and ERCP with drainage of the right liver lobe with uncovered stents, but we never opacified the left liver. Last exams showed no difference in bilirubin levels and also a persistent dilation of the left liver bile ducts. We are going to perform a US hepatogastroscopy.
Sandeep,
Yes.
Sandeep, Michelle.
Yes.
Bye.
Great to see you again. The room number is the right number, so I think that you are safe. So please go ahead with the case. Thank you very much.
Thank you. Thank you. At the outset, I would like to thank Paolo and the entire team. A fantastic facility, and I'm enjoying the company of Michelle. And Giuseppe has been extremely helpful. Thank you, Giuseppe. So you have the fluoroscopy image and the EUS image on the screen. As you heard the story, this lady has CA breast, which has a large metastasis in the liver. It's causing right and left system disconnected. What I have on my EUS is where is the arrow here, and this is the dilated segment 3 duct. If I trace it clockwise turn, I trace it to the hilum. There's a stricture somewhere here, which is not so obvious on the MRI done recently. At the same time, you can see there's a tumor all around. So my aim is only to drain the segment 3 duct, which is dilated, in spite of the efforts of the right biliary system drainage. The bilirubin has not come down, and we will do a hepatogastrostomy.
So if we can show the X-ray, I think it's important so we can understand exactly what has been drained and what need to be drained. So I want you to notice the position of Sandeep by fluoroscopy. He literally went through the easy junction and then up so that he has a perfect angle to basically have access to the left hepatic duct branch.
So Sandeep, Michelle, Sandeep, you are using a Pentax instrument. So what you feel about that? Because
I have
you are an Olympus guy.
No, it's a beautiful instrument, and I have Pentax EG38J1OUT. And I have the Olympus needle, which is primed with contrast and saline. There is no stylet inside, and I'm trying to go through a window of parenchyma, which is here. So this parenchyma is my cushion. I'll puncture somewhere here, and this wire will coil somewhere here. I expect if it doesn't go across, I will leave it here and then create a fistula between the stomach, the liver capsule, and the wall, and come all the way inside, and then place a partially covered stent. We can decide on the stent as the wire moves inside.
For the young user, he's really hugging the stomach wall so that he's as close as possible to that left hepatic duct. So that is a very important concept. Very, very close with the transducer to your target.
Okay, here it.
So he did also some color flow Doppler to make sure there's no vessels.
Yeah.
You know, he's gonna redo it just for the camera, but he already did that. So those are the little things that you have to do, you know, in preparation
Fluoro
for your
once again,
stick.
please. Yeah, fluoro. Yeah, I have the needle out. Okay.
So we can remove the color flow now.
I have the stable image, and here
With a
comes
very
my-
nice image. You can see the transducer against the gastric mucosa. The needle is coming out. You see, he has a
Use fluid to have a centrifugate and see what. I would check the okay, so let's do the second pass as soon as it's ready.
How many cameras? One, I would say one for the staining.
Then we will water and alcohol.
From what I counted, it took about 5-7 minutes
No, it's you can
No,
stay
I mean
ready.
from the time that we perform the function till the time that you can check that at the microscope.
Yes,
Around
let's
10
say,
minutes.
5, 7 minutes.
5 7 minutes. Yes.
The only thing that can change is how much the material you have, and so you have to discriminate what to keep for the smear and what to use for histology eventually. Also, because if the
And
patient
now-
is metastatic, we try to have material for NGS.
Yes. And now in this case, the second pass didn't provide a lot of material. How do you handle it? To use everything for the smear?
Yeah,
Everything for the
because
smear.
first of all, adequacy is the first hit, and then we
Next photo, Federica.
well polarized and okay. There is browning because of air. Probably just an artifact of information, but it's not the picture. Again, here probably leukocytes. One are leukocytes. By now, now, we are this is a fibrovascular material again, but it can be again. These are very polarization of
Let's let them know. Go back to the room. Are we gonna tell them? Yes.
Hydrophilic, but very difficult to manipulate, than to go to a 25. But that will be like the next approach if you really cannot get anything across.
Thank you, Michelle, for taking all the questions. It's true. I'm not moving my needle. I'm staying there where I am.
Yes.
That's most.
So it's
crucial.
very comfortable now. You know, you want a cappuccino? And type of wire you can use if you don't want to switch to Terumo will be a Visiglide. So the Visiglide is kind of a hybrid wire between a stiff wire and a hydrophilic guide wire. It has a very long hydrophilic portion, which you can play. And I know that a lot of Asian love. I mean,
Visiglide,
in
yeah.
Hong Kong they love Visiglide. Korea love Visiglide. Well, what do you use, Sandeep?
Yeah, Visiglide or Terimo.
Okay, so you see, we kind of start using a lot of Visiglide as well, and then the Terumo, which is completely uncoated, completely hydrophilic, but
easily?
very difficult to use. And when I was a fellow myself, it took me really 2 months to become comfortable to use a
Floor,
Terumo.
please.
And in addition to guide wires, regarding the movements of the needle, do you think there is a place of coming, pulling back slightly or changing a little the axis
It
when we
is,
have already punctured the bile duct during this very challenging
yes.
step?
So it is definitely very important to have the needle
So you see thank you.
oriented
Just
in
a
the right
person.
direction.
Oh yeah, it's a perfect placement of the wire. It's followed the stricture at the left hepatic duct and gone to the CBD. Let's
Yeah,
keep pushing
very,
down
very nice.
as deep as possible. Please go ahead. I'll. Yeah, the magical fingers. Yes. Okay. Yeah. Yeah. Keep. Okay. The longer it goes, the better it is. No problem. Okay.
So
Then we'll hold back here and we'll exchange now. I'll exchange. Remove the needle and you push in the wire. Fluoro. Yes. So this exchange has to be 1-to-1 while I keep looking at the wire on EUS.
So you see by EOS, you're now looking at the area where the wire entered the biliary tree. And that is really the most important portion of the procedure.
So that's a
This
wire
is
there.
probably one of the hardest parts. Do not lose the access, do not lose the wire. And basically, you need to keep that angle. Everything else is pretty much standard. But this part of the procedure is the hardest part. Keeping the wire into your field of vision.
So arrow is pointing at the wire exiting from the scope. And yes, here it comes. I'm holding the wire.
And one more time, you can see how minimum of a distance there is between the transducer and the target by EUS. And that is a very important concept. The biggest mistake you can do now is to switch to an endoscopy picture or
Never.
to create a gap because you will lose
Sister.
that beautiful angle of entrance of the wire into the biliary tree. This is really the ABC of EUS guided procedure. So now, what are we gonna do to create the
Fistula.
fistula
Using
stotome?
Yeah, we are using over the wire 6 French cystotome from Endoflex.
Okay, so that is probably the best instrument to create an anastomosis. The first one to
let's
use
finish
that
it off.
instrument and describe it and push forward is Mark Giovannini. It's his favorite instrument to create a fistula. You can use also Hurricane, which has a very pointy end. We do not recommend the needle knife because, unfortunately, the fistula it created is not.
I will check with the cam. Here.
To the use of the
Yeah,
cystotome. So
so-
once you have used the cystotome, you can go ahead with your stenting, or
Yes.
you will be dilating in addition to.
So
to the
that's a
cystotome.
very, very good point.
All
With
set?
the cystotome,
Next to the primary lesion, there was a lymph node. So she might have done all
She transverse the middle node.
We don't have anything. Let's see now the third one.
With the fourth one from the lymph node. I know sometimes, huh?
Takes a lot of time for every result.
We're not competitive. Third one also from the primary vision from a different needle, also not competitive. And now we wait the results of the evaluation of a fourth pass done the sharp needle from the lymph node.
exchange.
Okay.
They're removing the stotome. They're keeping the wire in place. One more time, you have to respect the ultrasound picture. It's very important to stay on ultrasound until the very last moment, because the best angle is the EUS angle to place your stent. If you change your angle now, your stent will not go through.
ERCP route, so we'll stick with the plan and see what we find. So in this case, I would have gone for intraductal fluoroscopy guided biopsy and possibly cholangioscopy guided biopsy as well. And plastic stent. Yes. Yes. And anyways, even if we had confirmed diagnosis of cholangiocarcinoma, we have transitioned to plastic stent. We don't do metal anymore because our patients are outliving the plastic stent. The metal stent.
So you have to treat the complications of the metal stent. Traction.
So, right. So,
right.
Whether we do Y-shape or we do.
In terms of the plastic stent change them regularly in the or whenever the patient presents with the symptoms.
No, we do plan because most of these patients can undergo palliative chemotherapy, immunotherapy, so they're immunocompromised, correct? So we bring them back based on the size of the stent we put in every 10 to 12 weeks. Yes. And most of the higher you need 12 or more. Yeah.
Now the moment of truth.
So now, in your experience for passing the stent, what are you looking exactly for? You are looking at the endoscopic ultrasound point of the axis or the fluoroscopy?
Yeah, you always in this space look at the image by EUS, and then of course the fluoro helps you confirm.
Yeah, but what is the idea was bring the right.
That is hypertrophy. Yes. So normally, normal level would be 30% of the liver volume. So in this case, it almost looks like 50%, which is what you should. Yeah.
And this thing comes in the American deadline.
Correct.
Will publish that here.
Correct. Correct. Absolutely. So I think we have to move on to the RCP.
Okay.
I mean, the good news, we don't have to be, as long as we're on the biliary tree, we should be fine. And I think you're very stable there. Your stent is definitely into the biliary tree. You can see it.
But I just wanted to go 2 centimeters inside more. That would be very useful. I don't have enough space to play around with. Do you think we should take a cystotome again and then take it in?
I don't think so.
There's little damage to the wire. I think the wire has also got burnt. There's little shearing happened. It's tough.
Can I feel?
Yeah,
sure. Thank you. That wire is tired, huh? If you're stable.
Yes. Go. You can take it down like the previous time.
That wire is really tired. If you're stable, we can try to put another wire. You want to try that? Are you stable?
I'm not sure if it's.
Can you advance some more the stent here?
No.
And at this point, you have the possibility to exchange with the cystotome again in order to have a new
That's
bladder.
right. That's what I was thinking.
That's fine. We can do that.
This will be an option, maybe.
This looks like a good position for me. And I think I'm inside. Let's take a cystotome.
I really think you are inside.
Okay, so we exchange.
We change.
We think you are inside in the angulation.
From here. Because if you're inside, you can deploy it now.
No. I think it's very peripheral.
Because we can inject. But you don't even have to remove the wire.
The uncovered part of the stent is measuring actually 3 centimeters, if I am not wrong.
So we have an 8 centimeter stent with this 2.4 distal part is uncovered and rest is. We're putting little contrast by the side of the stent.
Okay. X-ray.
Laura?
So you are expecting to deploy the uncovered part into the biliary tree?
First we just check. There's some air coming in. Okay. And it's outside. It's outside.
Okay.
No. I think it's. Is it?
I think it's in. Yeah, you're pacifying the branches.
So then we change the wire then.
Okay, now. Okay. You want to change the wire?
Then we change the wire.
Okay, good.
This wire is little.
Can I have a new wire, please? Just stay where you are. Huh?
Yeah.
Can I have some water, please? Give me some water, please. Okay.
So it's a complete team effort.
Yeah.
Everybody is giving their right inputs. Screen, Laura? Screen, please. Screen.
X-ray. Are we definitely in?
It's
definitely.
Side
Okay. Can I have a new wire, please? With the hydrophilic
So
end. Like
which wire are you expecting to
I
use
would
now?
like to have a Visigline. Can we have a Visigline?
And at this point, the angulated or straight tip?
What?
Angulated is better, but I don't have an
Visigline?
angulated, so we can use straight as well.
Yeah, regarding there is a question from the audience regarding how much wire do you need to have in place for a hepatogastrostomy?
So as deep as possible. If my wire had gone across the papilla into duodenum, I would have been very happy. This situation would not have occurred. Which wire?
Okay.
Giuseppe? Which wire?
Again, a Visigline.
Yeah. Thank you.
Okay.
Yes.
Okay, Sandeep Michel.
Yes.
Unfortunately, from Hyderabad, they are pushing to have to be online.
Please go ahead.
Yeah, but you will be online on the US Express channel. So continue the procedure, and we will look at you on the other channel. So now it's my pleasure to give the line to Hyderabad, to the Asian Institute of Gastroenterology. I think Dr. Basha is already there to start the procedure. Hyderabad, can you hear me? Okay, great. Hello, everybody. Hello, guys. Welcome.
Hello.
Welcome again to EUROEUS 2024. Sorry, Dr. Basha. Welcome again. You are taking the part of Sandeep, who is struggling here in Milano. So please go ahead and welcome again.
So thank you, Dr. Paulo, and the entire team of EUROEUS 2024 for giving us this opportunity. And we are ready here with the two interesting cases. And with me, the entire team is here. Dr. Mohan, who is everyone knows, he is expert in third space and enteroscopy. And Dr. Asif, Dr. Nitin, and the anesthesia team headed by Santosh sir, Dr. Tejas, Dr. Srinivas, and our senior technician, Mr. Srinivas is there, Sridhar. The entire team is ready, and the supporting AV team. So we are ready with the case. So can we have the case details? Coming to the case history, she is a female patient, 66 years old. She had a carcinoma of vaginal wall. So that was diagnosed in 2017. For that, she has taken radiotherapy and chemotherapy. And she was doing fine until a few months back. Now she presented with postprandial vomiting and not able to tolerate the food and there is a weight loss also. So if you can see the CT scan, we can see there is a circumferential thickening at D2, D3 with a luminal narrowing and with obstruction, and there is a dilatation of the proximal D1 and stomach. And this is mainly happening because of the multiple lymph nodes around that region, which are responsible for both obstruction and also she had some ureteric obstruction also. So this is the background, and ultrasound guided FNAC from that lymph node came as squamous cell carcinoma. So it's a malignant obstruction of gastric outlet, so requires a GJ. So in this particular case, we are ready to demonstrate US guided GJ with a double balloon catheter balloon, that is EPAS balloon. So for that, this is an interesting recent paper from a multi-center led by Professor Anthony Theo, which is comparing US guided GJ with enteral SEMS and showed the efficacy of GJ when compared to the this EPAS. So with that is about the case details. Now we are already ready. You can see Dr. Mohan is here. He is expert enteroscopy person, and the thing is here we require a catheter. For that we require to pass a guide wire across the narrowing, and over which we'll pass the double balloon catheter. The difficulty here is when we actually check with the endoscopy, the lesion is almost in the distal part of the duodenum. That is almost distal D3. You can see on the, can we have the fluoro picture on the, yeah. So you can see on fluoro that is actually in the deep D2 and there is a grossly distended stomach. So what we did was we passed endoscope with over tube outside, but the endoscope was not able to reach the site of obstruction. So Dr. Mohani is here, who is an expert enteroscopist. So Dr. Mohani is passing the enteroscope. This is not endoscope. We had used enteroscope. So we passed the enteroscope through the overtube so that we could reach the site of obstruction. So on endoscopy picture, you can see there is infiltration at the distal D3 area. We could reach with the enteroscope, and now we pass the catheter with a guide wire, and the guide wire is across the structure, and that is how the enteroscope helped here to reach the site of narrowing and pass the balloon catheter. So now what we are doing is we'll keep the catheter and the guide wire in place, and we'll remove this enteroscope, but we'll keep the outer overtube at that place only. So the purpose of enteroscope is here is just to reach the site of the narrowing, pass the guide wire across the narrowing into the distal jejunum. You can see on fluoro, we are removing the enteroscope. Now what we are doing is we are keeping the overtube inside, and there is a guide wire across the narrowing, and that guide wire is deep into the proximal jejunum. So now we'll take that double balloon EPAS balloon catheter here.
Since the narrowing was in deep into D3, our endoscope could not reach, and we took the help of this 200 centimeter long single balloon for our wire to pass. Now we have crossed the wire across the narrowing, and Jahangir will now pass the EPAS balloon.
So this is the EPAS balloon. The cameraman can focus on the balloon catheter. This is a EPAS balloon catheter. You can see this. It's okay. So this is a balloon with two balloons. It's a catheter with two balloons, which are apart 25 centimeters. And you can see this is the catheter. I'm loading over the guide wire. You can see this is the tip of the catheter, and this is the black mark, and around here there is one balloon, and this is another black mark, radiopaque mark. This is another balloon. So in between these two balloons, there are multiple holes so that we can flush saline, and we can occlude by distending the balloons. and we can inflect some saline so that we can pass the water saline so that we can have adequate distended jejunal segment. Now I am passing the EPAS catheter over the guide wire.
You can see the
You can
markers on there.
You can see the radiopaque markers at
kink, slightly kinked there. Yes.
So you can see when the balloon catheter is passing, there is a bend, and which was not allowing to the pass catheter. So I adjusted the over tube so that the catheter passed. Now it's in the second part of the duodenum, and I am trying to pass
across. Now the stricture is there.
This is the site of the stricture here. So little tight and difficult. Yeah. So now I think we can push the pass catheter down there, and
wire. Yeah, we can.
So now the balloon catheter has passed the site of narrowing. So what we do is we have to pass the guide wire much deep. So we'll take out some wire which is at the tip so that we can pass.
Hi, one easy question. How many French has this system? The diameter, please.
Tracks conveyed through the stent in a ready channel. Landing space, that's why
technique, you are not using Buscopan or other similar drugs to avoid the peristaltism of the small bowel?
Very important question. We do use the Buscopan, sometimes glucagon. If you find peristalsis, especially that is important when there are too many contractions, we can appreciate here it's relatively stable. And sometimes after we pass the EUS scope, then Buscopan definitely will help here. So now both the balloons are distended, they are well in position, and we can distend the center intervening area so that we can do the rest of the procedure. Now what I am doing is I am removing this overtube. Now we don't need. The main purpose of the overtube is not to allow the EPAS balloon catheter to recoil. Now we can remove it and we'll start inflating the center part. Meanwhile, I will be ready with the EUS scope. So we are using here linear EUS from Olympus with the ME3 system. You can see the center part is now distending. So you can see by the time Mr. Srinivas is flushing the saline, I'll pass the EUS scope. So this is the linear EUS scope. You can focus the scope here. So now I am passing the linear EUS scope. So now we take the scope close towards the distended segment and then we'll start evaluating. You can appreciate on EUS image, this is the balloon, the distal balloon, and we have to, I think, push some more so that we can reach the proximal balloon segment.
Yes. You get the concept.
It's a straight wire, as you can see, it's an O25 disease, so we do our best to have all of our so usually if you are treating with a higher antibiotic, you will have people with accessory for like
Yeah, high transfer only external left, right? Is there any picture? Yes. I'll take a picture. Okay. Yeah. Allora, un O5, okay. This one, 4.5 centimeter external. Yeah, this one. Quella.
Looking fine to me, but only thing is I am moving the front and back so that I can have a better segment. Can we have
Do you think that one of the advantages of this technique is to avoid pushing the small bowel? Because this is something we are always scared of when we are doing the gastrointestinal anastomosis, to push with the lamps the small bowel. As here you have two balloons fixing somehow the limb. Do you think that this is more fixed when you are doing the perforation?
Yeah.
So it does fix the bowel and converts a very difficult procedure. Less chance factors are there. Bowel is fixed. It's like a pseudocyst drainage now. because you have fixed the bowel and so much better with this.
So now I think I'm close to the bowel, jejunal limb here. I'm looking for a better segment. If I can find that a vertical limb that is easy target, but let me explore here. I think we should be fine. Can we have some buscopan? Some more water. So we will insert some more saline there, so that we can have some more distended limb. Okay. Yeah. So you can appreciate there is distended jejunal loop. The only concern I am doing here is the momentum is quite thick here between the stomach and the jejunal limb. So we'll try to find a place where there is as much as less momentum as possible. Yes. Yeah, yeah. You can have some more also. It's This is okay, sir. So I think this segment looks fine. We'll go ahead.
This is very interesting how can be challenging to find the correct loop to perform the anastomosis. Here, for example, in this position, you will say that there is an interposition or another jejunal limb. We cannot see very well in the air space of the right side of the endoscopic ultrasound view, but it seems sometimes that there are like some overlapping jejunal limbs. Like
Yes,
here
yes,
on the
it
right
is very
side, for
important
example,
thing
in the upper
that
right
we
side.
need to, yeah. So that's a very concerning and important thing. We should be very much careful about. So as you rightly said, this is the loop where I am focusing here, and if I am tracing, it's going and dipping down there, and the main aim is to avoid such intermingling segments here. So what I'm doing is I'm trying to find out a place, fluoro, where there should not be any intermingling vessels. Yeah. Yeah. Now you can see that is the intermingling bowel there, that side, but it is not coming in the way here. Yeah, I think this should be fine. This is fine. So I think we'll go here.
We contrast between here. Okay. Balloon. Yeah. So now you can see this is the magnified fluoro. Yeah. So what I am trying to do is, can we have some more water so that I can confirm the flowing of water here before a puncture? Yes. Yeah. Okay. So now the catheter I am trying to pass here. Yeah. You can see this is the balloon hot axios catheter here. Yeah. Yes. This segment is fine. There is a lot of movement. We have to be careful this while puncturing. Some hold here. Yeah. So this limb I wanted to go in. Some resistance while I'm pushing the catheter here. I have not burned the cavity, but you can see there is some resistance here. Okay, yeah, now it's fine. It's fine. We have to see the limb again. Okay. Yeah. So there are the movement is there.
So
From the X-ray image, it seems that the endoscope is very far from the space
yes.
between the two balloons.
yes, that's what
Are
we
you
are.
aiming for the part that is between the two balloons? Because it seems a little bit
Yes. I'm exactly
too
doing
far.
that. Yeah. So this is the part exactly between the two balloons. So I'm trying to be there. This is okay. There are two segments between the other. So this is looking okay. Yes. Yes. So can we hold scope? Yeah. So here we need to be little cautious and careful before the puncture, because once we puncture, we don't have any option of taking back. So what I'm doing is now looking for an ideal loop there. Yes, that's fine. So I'll go in. Yeah. Because of the movement, what we are doing is here, I'm trying to, yes. Okay. Yeah. I'm just finding out the standstill movement of the loop so that I can go in easily. Yes.
And how much centimeters, or what about the distance you are expecting to have to deploy the stent? This is something you are measuring in all cases, or here you are comfortable only with the
I'm comfortable
endoscopic
here
ultrasound view?
so that yeah. So hold here. Yes. Hmm? Yeah.
Now you are using pure cut.
Yeah, we are using pure cut, 100 watts and
Okay.
effect 5. Yeah.
Because somehow we see that you are doing push and pull back movements to get in.
Yeah. So what I am doing is, we could see huh?
Organic.
No. Better. Okay, better. Can we have some more water so that we can sleep with it? Yeah. Yeah, we are finding some difficulty here. Yeah. I think there is some issue with the loop there. Yes. So let me position this. So we just punctured the gastric wall.
So for the moment you are looking at the resistance of the small bowel limb, but you didn't perforate. You didn't use the cut for the moment, or you been using?
Yeah, I just I think the catheter has fit the gastric wall, but jejunal
Okay.
lip is fine. Yes. Can we have some more saline? What saline? Okay. Can we have some more? Yeah. There is one jejunal loop is coming in the way. So I think that is creating some problem there. I think this limb should be fine. So we'll target this loop. Yeah. Yeah. Now we are in. Yes. Now we are in. I lock it here.
Yes, you're in.
Yes. Now we'll take off this safety hub. Push some few centimeters down there so that we can have enough space. I'll lock
Yeah,
it here.
this is something very interesting because now you are pushing the contralateral wall of the small bowel in fluoroscopy. So if we can see the fluoroscopy image, we will see that the catheter is slightly pushing the contralateral wall. So this is also
Not a whole lot of data, but a lot of us will guide it first so that we can break the sclerosing type cholangiocarcinoma, which is often difficult to diagnose, and then do brushing and then intraductal biopsy. And then finally we'll put the stent in.
Okay.
So back home, I we use a couple brushes, one for routine cytology, second one for fish, and sometimes we send it for NGS as well, next gen sequencing. So here we're just going to do one brush and do fluoroscopy guided biopsy. We saw the area of the picture where the waist was, and then finally we will stent in.
No, guys, why do you not?
So for brushing, generally, fluoro, what we do is we try to go beyond the area of the stricture and then advance the brush out and then slowly pull back, because especially good in patients with PSC, we can advance the brush out because
Fluoro. Scopia.
Because if you try to open the brush and you're below the stricture, there's always a risk of brush-guided injury. So you go beyond as the fluoro.
Is there a specific number of passes that you should do?
Yeah, a good question. There's a recent study that was published in Red Journal which showed about 30 passes increase the yield. So generally I do about 15 back and forth.
15, okay.
Yeah. Fluoro. And then I always ask if my esteemed assistant here is feeling any resistance. And if they do, then I look at the fluoro and try to adjust the angle. But it looks like it's going smoothly.
Yeah, definitely.
We go 15 times and then we get the brush in. And then finally, I personally not just cut the brush and send it, I ask them to flush the tubing also.
Okay, for irrigation also. Scopia.
Perfect, we are in the good spot.
Ancora?
Vediamo. Good. Not a whole lot of data comparing different type of brush, but anecdotally, maybe some may perform a little bit better. But nonetheless, the key is making sure we use enough, at least 10 to 15 back and forth. And then as you see, there's a lot of effluent that comes in the tubing. So That's the reason behind flushing the tubing on gut wire. We can do it at the downside evaluation on this. Yeah, it looks like 12 may be short. What do you think?
We discussed actually about the length of the stand and the
Yeah.
arguments in favor of 12 or 15 centimeters. What's your opinion, Dr. Matteo? What would you place?
I rather prefer to use the same shape of the biliary tree. That's why I was asking
about the
if
pigtail.
double pigtail or not. It's a personal point of view, of course. And we try to put always the bigger size. It means 10 French instead of 25. But there's a rationale to select a straight because the force makes probably act with the stenosis. Could be good. I think so.
I think I agree with your strategy. We also always go with 10. We don't stock it in the halves. But another point for the question about the length of the stent, I think 15 you have to be careful because sometimes it can migrate internally and it can cause trauma, hepatic capsule perforation. So you have to be careful that you leave enough duct in there. For that reason, pigtail is probably also safer, less trauma to that. So.
From a practical point of view, do you use to measure manually the length?
Right. So, when we were doing the sphincter tome, you basically look at it. It's about 4 centimeter or 5 centimeter long. With the brushing, it's the same thing. Dilating balloon, we use the Hurricane. It's about 4 centimeter long. And that's why we made that assessment that you need probably 15 to get it deeply seated.
3, 6, 9, 12.
You need about a couple centimeter out and then couple beyond the.
Exactly. Here, the reason for not placing the 10 frails, you feel that you did not pass?
We have, we did 6 millimeter balloon dilation. I don't have that concern. We can go with 10. I would have gone with the 10.
Okay.
It's,
I don't know if
I
you
think
have
the
it
10 that
available.
we have here
Is that the
is
15, no, we have 8.5, but it's the new type of stent that the internal diameter is 10 French.
So it's
It's a thinner, yeah.
The proximal and distal part are thinner, and the central part is 10
No. The internal lumen
It's 10 French.
is 8.5, but the 10 French is 10 French external, but it's
internal
very thick.
Yes.
So it's the same
More or less the same.
diameter of 10 French.
So now we will do the intraductal biopsies.
Biopsy. So this is like a luxury for me. This is wire-guided biopsy. We don't have wire-guided biopsy.
How do you feel about safety of intraductal biopsies? There are many reports in the literature who say that it could be difficult, dangerous, also cause some bleeding.
So I personally haven't had that. Of course, on the rare instance, you have a highly vascular intraductal type cholangiocarcinoma. There might be a risk associated with that. But another thing for rare cases, especially somebody with the portal biliopathy, you may, cases where there may be varices, you want to be careful in that situation. But I haven't had many cases where we were dealing with the complications of bleeding. So you notice I really went closer to the papilla. Yes. So this is the same technique for fluoro. For even non-wire guided intraductal biopsy.
Kissing the papilla.
So I think it might be catching on the wire.
First of all, I do not know if I want to thank you for giving me the case because it's very complicated. Probably evaluating
Yeah. So you don't get this problem with the non-wire guided. Fluoro? Alright, we are getting closer. So the waves that we saw was pretty close to fluoro. You can see the reference. Alright.
Thank you, Lydia.
We are already in the liberalizing, and here with let me show you
A little bit more.
This is the classic schema that was detected in the MRI. So it's an heterogeneous, it's predominant equal coil heterogeneity.
Is it open or closed?
Close, definitely close.
How about we open it a little bit?
Yep.
Fluoro? Fluoro? And the PG stamp is out.
The antidote that is also an irregular flow, that is an idea that might be an involvement of the bottom vein. But also we see a lot of vessels in the surroundings of the tumor that are already shown.
Well,
And this is probably
non-wire guided, certainly I would stick with those. Fluoro again? Yeah, I don't want to lose the wire access. Suggestions, Francesco?
Developed by the infiltration of the tumor. You can see that we have collateral.
Yeah.
Position of the scope. Down from because yeah. Fluoro?
Yeah, no, if I go in the non-scope position, it's
Yeah. Look at this.
I don't want to lose the wire thing. I think this is I can go with just a simple fluoroscopy guided, non-wire guided. Open a little bit, open.
We see that it's a vascular infiltration, probably giving us information about 9% of the tumor. But I'm going to skip
Yeah.
so
If I go wrong, yeah.
So because if we move back a little bit, we start to see ascites. So this is another sign of really advanced disease.
Yeah, bravo.
All right.
That's
open.
More bladder full of stones. Probably
Fluoro?
an analytical station, not so much.
So is it open all the way?
Yeah.
More bladder. And when we look
Fluoro?
at the liver, in this part we don't see
Can you
really
keep it on? There you go, perfect. So the key is, slowly leaning into it and then slowly closing it. So you have to communicate with your assistant to close it slowly, because if you close fast, it's gonna jump.
Close.
And then you feel if there was a tug. Yeah.
Yes.
So I felt the tug, and then hopefully we'll have a tissue.
Do you use multiple biopsy?
This was my
Minimum
question.
3.
Minimum 3, okay.
Yeah.
In the same section, same bite.
So yes, if I have a trap attached, then I would chop, 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 collect it in a trap, suction. But since we don't have a trap, we have to go one at a time. Got it.
Again, we see the pancreas, which is not so much normal. So we see the dilation of CBD with an incoherent parenchyma.
Rosome brushing, very few cells, not malignant, normal cells.
This is a tough one.
And the rest of the 2 passes, the last 2 passes were also negative. All 5 negative.
No, they didn't. They did. They put all that.
Ah, okay. The last one.
Yeah.
Okay.
So depending on what they see on the 5th pass and then the brushing and then the biopsy, they may have to do spy on the next time around.
Yes.
So we have located the there is a dilation of the duct. And we saw a slightly visual enlargement of the peritoneum, probably related to the tumor, and again, it's a lot of lymph nodes. That is going to be very important for the confirmation of the diagnosis. Okay, I don't know if there's any comment or any idea, because this is a very tricky case. So
Can we give her at least 2.5 liters, 3 liters of LR? She's young, she can take it.
Yes, we can imagine. Via.
Yeah. We are finishing the first one.
They are already three elements that the vision is not detectable.
Laura?
We can go forward for performing your second round.
Yes.
So now we can do the master.
All right, open.
Yes,
Laura?
So that's the CBD recently.
Tell me.
There you go. Yeah, perfect. Now, close slowly.
So now we turn anti-clockwise and try to follow.
So as he's closing that, gently 4-5 cells are pushed towards the wall.
Yes.
I can feel it. All right, open. Close slowly. Fluoro.
So very important from the
Close slowly.
Close.
Yeah.
Casita telescópica le uso.
Yep.
Go to try to identify the pattern, normal do anti-clockwise rotation, keep up a little bit, and then you will lose the liberalium going forward.
Not bad.
So we can go for advanced imaging. So now we're going to use the TF5. This is a very nice image of TF5 because we can see the
And then,
hypovascularity.
and you can actually see the tissue that looks like fairly decent tissue there.
Let's go the other side. So now we see all the people on the
nice way to depict the lesion. So it's not only helped by tumor, but we can also help with advanced imaging way to identify the tumor itself. In this size is at a minimum at 1.6.
Senza luce è difficile.
I think we can keep
Okay, now move to the third biopsy.
I really expect the same image, but it's very important that now that we are learning on PS5, these are the cases we need to see that in many cases PS5 and Contact Enhancement really behave very similar. It's not exactly the same technique, because with Contact we have dynamic evaluation, we know
Segui il maestro. Mauro, segui il maestro. Vedi meglio di me. Ok. Dovrei lavare.
At least to learn. So I think if we have
We expect that this kind of lesions should be hyper-enhanced and with rapid washout.
Yes.
More than 80% of them. So we will see how we can compare to DFI in this case. And the contrast is already coming.
So now the pattern is quite similar. So now we, as Andrada just already told us, is we have taken the beginning and we start with the washout. And I'm trying to show you.
This one.
Yeah, this is the arrow.
So these are the small vessels inside. This is not so enhanced, this part, but here they are the most important vessels. So during the puncture, you should avoid them.
So this is very important to see and to learn that at the end, the image that we obtain with contrast is quite similar to the image that we obtain with the DFI.
And here is the portal vein.
Yes.
Here and some collaterals, perhaps here.
So this is a very nice demonstration, like with this advanced imaging, we can increase our diagnostic capabilities and highlighting the probability of this lesion to turn to be a malignant cholangiocarcinoma.
What about elastography?
We were discussing. I think this is a tricky case for elasto because we have too much vessels. And whenever we have too much vessels, we have a problem for...
We have to biopsy.
Okay, we have problems with elasto when we have a lot of vessels. So this is not because it's a soft lesion, because at the end, strain elasto is a referral between what we see and the surroundings. And we've tried many times to just have no vessels in the middle, and it's almost impossible. So that's why Andrada and myself think this is not the best case for elasto.
Okay.
So I think here Matteo is pushing us to try to make the biopsy. So we are going to use, well, I need to tell that we're using the 740 echo endoscope from Fuji attached to the Arieta 850. And now we are using a 25 sharp core needle to try to get the sample from the tumor. And I can tell you that if in this case we're not able to get a good position, we have a lot of lymph nodes. So I will try to go first for the lesion, but if not, my second shot in this case is try to go for the lymph nodes. So I think here we have a nice window. First, I will try to.
And do you think, Julio, that there is a difference between the use of the 25 or the 22 gauge needles in this setting?
The scope is quite bended. In fact, if you take a look at the image, I'm quite bended. So if the scope is much bended, I prefer to use a 25, because at the end, what we need to know if it's positive or not. And if you are very bended in these tiny lesions, very well vascularized, sometimes I prefer to go for a 25. We are in the moment of the complications, so better not to have any live complication while doing the procedure. So that's why in this case, I prefer to use so we're inside of a lesion. So we start to, okay. So it's in a very tiny place, small lesion. So I'm trying to do a little bit of fanning, but getting rid of the vessels. Okay.
I think fanning can be challenging in this kind of setting with small lesions and a lot of important structures around, as the bile duct or vessels. Are you actually recommending doing the fanning using the big wheel or using the elevator or the scope? How are your suggestions for performing fanning in these teeny places?
To be honest, in cases like this, do whatever you can. I mean, just if, okay. Okay, we've just did a slow pull because it's quite well vascularized. So it's a very nice question, Enrique. If the lesion is over 2 centimeters, you can try to do fanning with your big arm, sometimes with elevator. In these small lesions, so well vascularized with a lot of vessels, when you're inside, just try to use all your tip and tricks. That means take the needle a little bit out and see if with the arm goes, then go back inside again. If not, use the wheel a little bit. But be open-minded and just trying to find the place you think it's the way it's better. I cannot tell you in this type of small lesions which is best. Just depends on how the thing is going.
Julio?
Yes.
Andrade, thank you very much for your demonstration. We wait for the cytopathologist, but you are waiting, and you are on the next session for complication in the auditorium. So you need to move to reach the auditorium, and then we will let you know how it will be the final results of the procedure. So now we move to room number 6.
Okay.
Thank you very much.
Thank you. Thank you.
Professor Charles, Professor Di Matteo.
Okay.
Can you hear me?
Oh, yes. Hi.
Yes. Thank you. Thank you. We have had a very long look view of your struggling to obtain the adequacy of a specimen. So please just show us and explain us what we have done until now.
Yes, so not atypical for cholangiocarcinoma, as we know, because these are the sclerosing type, notorious in terms of lending up cells to do the diagnosis. So we did 5 passes. The first 4 EUS guided. The first 4 were assessed on site. The last one we decided to put in formalin. And then next we went on to do ERCP. And we got into the left system as was our plan, because on MRI we saw that it was hypertrophic. So almost draining 50% of the volume. So with my excellent assistant here, Francesco, we got into the left side. We did intraductal brushing. We did fluoroscopy guided biopsies. We have 3 nice big bites. And the only thing we didn't do is cholangioscopy. So hopefully we'll have a diagnosis with all this. And we are putting a stent in right now as we speak. It's a plastic stent. We can disengage. So any thoughts on any different strategy from the panel or audience? So we did do balloon dilation first, then we did the brushing, and we decided to go with the 15 centimeter long stent because it felt like a fairly long ductal system, and we were right about that. Perfect. All right, we can break all the way. So questions?
Yeah, hi. We were discussing here from the panel in the audience about the follow-up of these patients. You are expecting to change these plastic stents for metal ones, or you are expecting to follow depending on symptoms or further cholangitis, or to re-change by other plastic stents? How do you expect to perform the follow-up in this case?
Yeah, good question. You know, at our center, my practice is I moved away from metal stents. We do plastic. Once it's a biopsy-proven cholangiocarcinoma, we do RFA at the outset, and we try to do it with the stent exchanges. Not every stent exchange. We see how the stricture looks like. So that's our strategy. We stick with the plastics.
Okay, and you are changing the stent in how much time or how many months, or how are you?
Yeah, so usually we try to get in a 10 French, and if we do, based on the type of stricture, we bring them back every 3 months selectively. We don't wait for them to get symptomatic, so it's an elective stent exchange every 3 months. And in this case, we didn't inject, well, we injected a very little contrast once we were deeply into the left hepatic lobe, just to confirm that's where we were.
Okay.
So we did contaminate the right as best as we could. There's always
Maybe we can have the
microcontamination.
fluoroscopy image in the big size to check to see how is the final result, and what was the size and the length of the stent you have chosen.
So
Was
yes.
7, 10 French, or?
So it's I think we have here 8.5 French, which I'm told for all intention and purposes, it serves in terms of patency equal to a 10 French. And based on the balloon dilation, we estimated we'll need minimum 15 centimeter. 12 would have been too short. So we used a 6 millimeter hurricane balloon, which is 4 centimeter long, and we estimated the length of the stent based on that.
Okay, and are you recognizing previous dilation in every case when you are performing stenting, or this is depending on the stricture, or this is not mandatory at all?
So this is based on the stricture. Oftentimes we are doing multiple stenting, and I would if I'm doing ERCP first for the diagnosis, I'll do balloon dilation first. We do brushing next. And then finally, if I'm putting multiple 10 French stent in, I'll put the first 10 French and then dilate next to the, if it's a really high grade fibrotic stricture.
Side to side?
Correct. And then put in a second stent.
Raveline, once you have histology confirming cholangiocarcinoma, the strategy celebrating. The strategy would be, Raveline, if you have, can you hear me still?
Yes.
Hello?
Yes.
Yeah. My question is, in complex situations when you have segments not connecting with each other, do you feel that plastic stents really solve the problem, since you are draining just a little bit, just a small sector, sometimes less than 10% of the liver? You cannot put multiple 10 French stents at the same time?
Yeah, you bring up a good point.
How do you manage the kind of situations?
Right, you bring up a good point. And especially type 4 stricture, you know, ERCP is not always the answer for palliation, especially in complex type 4 stricture. We may not be able to get across all the segment and palliate the patient. This is where you can do a combined approach. You can do EUS, ERCP, and of course, IR. You know, a lot of places, IR still is considered the standard of care, especially if person is resectable. They do IR guided drainage first. So I think it's absolutely okay to go that route rather than putting in a small stent in a non-dilated segment or not completely across the stricture. So I agree with type 4, we have to be very careful what our goal is and what we are trying to achieve before we start.
Thank you, Pauline.
Thank you so much, guys. Thank you, everyone.
Brava.
Thank you. Oh, yeah, sure.
Sì, grazie. Wow. No, vieni anche tu, Alberto. Sei il padrone della sala. Cioè, non puoi non venire. Il maestro qua.
Thank you so much.
Brava.
Thank you.
Sì, perfetto, infatti il mio prossimo farò questo. Ottimo, va bene, grazie, troppo buono. Grazie.
Paolo, are we going for a break or? Oh, we expect to come.
We have 10 minutes before the session, so if you want to move around, it's possible.
Okay.
Next
minutes
will
break.
be the session for the complication of diagnostic EUS.
Okay.
Okay. Thank you.
Thank you so much.
Yeah, thank you, everyone. So we have 10 minutes. Thank you.
Vado.
Proprio con la 3 dove non prende mai, sto proprio dentro dentro. Ok, mi senti?
Andare. Se si muove la 3 in fondo alla
positives. And so according to our pathologist, this was indicative of solid neoplasm, solid capillary neoplasm. So we will discuss with the surgeon about surgery. So my reflection on this case is be always sure that US FMB is indicated. So in this case, I'm happy that 90% of you think it was indicated. Choose the right needle, right technique, correct approach. So in this case, from the stomach, I recommend the door knocking technique, and always repress the needle when it's bent. Don't try to reuse it. And adopt a zero tolerance to any deviation from an uneventful, nice post-procedure course. My second case is regarding a man, 82-year-old. He has a kidney transplant. He is taking anticoagulants due to atrial fibrillation. He was referred to us because of pancreatic cysts, and this is what we found: several small pancreatic cysts with no worrisome features suggestive of IPMN, branch duct IPMN. We also saw some small nodules within the cysts, but with contrast, these nodules were not enhanced, so we were safe that we were thinking that these nodules were just signs of mucus, so no problem. Then, while trying to complete the procedure from the bulb to the second portion of the duodenum, we had a problem. And this was the problem. We saw yellow in our red screen. We like to see pink, we don't like to see yellow. What was this? It was a duodenal perforation. So my question is, what should we do now? We should refer the patient to the surgeon, start antibiotics and Neil Peros and see what happens. We should attempt closure with clips or with over-the-scope clip. Please let me know, what would you do now? Okay, great. So at least 4 out of 5 of you think that we did the right choice. We tried to close this hole with over-the-scope clip. We placed guide wire in the duodenum because it was somehow difficult to identify the lumen and the perforation site, which is right here. And when we went back with the Ovesco 10.5, 12 millimeters diameter, it was really hard to push this apparatus beyond the bulb because of some substenotic duodenum, and this was probably the cause of the perforation itself. Luckily, when we removed the guide wire, it was possible to slip into the upper genu of the duodenum and find the perforation. As you can see with the twin grasper, we are able to grasp the two edges of the perforation, pull back the tissue inside the cap and release the Ovesco clip. And at final endoscopic check, we were reassured by being able to insufflate the duodenum and see that the Ovesco clip was nicely closing the defect. So my reflection on this second case, again, be always sure that EUS is indicated. When you are doing something that is appropriate, you're always safe, whatever happens. The problem comes when the indication is weak. So you are allowed to refuse some indications that you don't agree with. Be alert in identifying complication during the examination itself. Do not either deny or hide the complication, and be prepared to react quickly, keeping calm and steady attitude toward the solution of the problem. And after, be frank to disclose what happened to the patient, his family, and colleagues in order to get the best outcome possible. Thanks.
Thank you very much, Pietro. Are there any questions from the audience?
Well, I will have
Julio.
just a question or a comment, Pietro. Would you think is the minimum time that we need to have a patient and there's a follow-up after an FMB or an FNA? Can we discharge after 30 minutes? Do we need to wait 1 hour? I know in our beginnings in Santiago, we admitted the patients for an FNA that we don't do anymore. So, but do you think there is a time for check for complications after the procedure to be standardized to all of the audience? How do you do in your center?
Yeah, that's a pretty interesting point, Julio. And I see the attitude here is very variable. I speak to colleagues who keep the patient just for 30 minutes. In my opinion, there is no strong evidence to say what is the minimum time. I think personally that 30 minutes is not enough. So we tend to keep this patient for at least 2 hours when you do a pancreatic biopsy. And I think 2 hours is a decent amount of time to be able to detect any sign of deviation from a normal course. But I think this is also open for discussion. I'm sure all of those sitting here will have different practices in their units.
And what do you think about when we have a bleeding? When do we go for arterial embolization? Which are the indications?
Yeah, sorry, I didn't hear very well. You were asking about bleeding?
Yes, for bleeding, for their treatment. When do you treat them by embolization? by angiography.
You mean bleeding after pancreatic biopsy? Usually, luckily for us, these bleedings we see are irrelevant, clinically irrelevant. But if you see that the patient is also experiencing some clinical sign like pain or hypotension, then you have again to be very aggressive in identifying any possible complication, and you ask for blood work, abdominal X-ray, whatever is needed. I will never discharge a patient home if I'm not sure he or she is fine.
Thank you. Are there other questions? Yes, please.
Is there an indication for post-FMB pancreatitis prophylaxis? For example, sales or aggressive migration? What do you do if you consider in peculiar cases?
I'd like to hear from the panel because I know what Andrea and I think.
To be honest, the rate of acute pancreatitis post an AUS guided FMB or FNA is extremely low. So, and we don't usually use a routine, any kind of prophylaxis on AUS guided. Is during the technique that we try to avoid to puncture the PD. If it's non-dilated, if you can go through a dilated PD with no problem, in fact, in some complicated cases, if you have a huge dilated PD, you can guide the puncture through the PD, but if it's non-dilated, avoid it. If you avoid the risk of acute pancreatitis after an FNA or an FMB is below 0.05%. So I think there is no really an indication like in RCP to give NSAIDs or aggressive fluid therapy.
But what we can say, Julio, is that with these new FMB needles, these needles are more aggressive. We see more hematomas. We also experience greater difficulty in introducing the needle into the lesion. Not by chance, some companies have changed the design of the needle in order to make it sharper and reach the lesion easily. So also this has to be taken into account.
Okay. Are there other questions? If not, thank you very much, Pietro. It was a pleasure as usual. And I invite the next speaker, Adrian Seftoyo, to present the next cases. Please, Adrian.
Thank you very much, and thank you very much for the kind invitation. We were just as an introduction, we were not keeping the patients too much after US-guided fine needle aspiration procedures. However, I will try to show you two cases just to show how things change. So these are my conflicts of interest. You probably have seen a lot of advanced endoscopy procedures, and you probably know that during the past years, we have almost completely changed to fine needle biopsy, to histological needles. And this has been shown in meta-analysis. We know they work better, and we know that we get an accuracy of over 95% in solid pancreatic masses. And in the case, in inconclusive cases, the second USFNB also gives a 50% conclusive diagnosis. So it's really nice to see the images. We know by using contrast enhancement and elastography, we already have an idea that this mass will be a pancreatic adenocarcinoma. We do the fine needle biopsy. There are no problems. The complication rate in the literature is less than 0.5%. However, things can happen in interventional endoscopy procedures, and I'll try to show you two bleeding cases. So whenever you have an extraluminal or an intraluminal bleeding, you have to keep calm. So all bleeding stops eventually, but you have to keep calm. So this is the first case. So it was a 56-year-old male patient with a left renal cell carcinoma with radical nephrectomy 17 years ago, so 17, diabetes type 2, hypertension, and the MR and MRCP report was a suspicion of autoimmune pancreatitis. Then we did an EUS, and you see it by color Doppler. We did color Doppler, we did contrast, we did elastography. Contrast harmonic imaging showed these two both nodules, and you see they are united a bit in some sections. So there were two nodules. One was in the ampulla, so exactly in the ampulla. The other one was in the pancreatic head. We did a contrast harmonic imaging. Both nodules were hyper enhanced. So they were hypervascular in the arterial phase with washout in the venous phase. They had low stiffness, and we went for a US-guided fine needle biopsy, which showed there were metastases from the initial renal carcinoma, so 17 years ago. However, during the FNB, we had a slight bleeding suspicion, so we saw something in the bile duct. We weren't really sure. So the questions here, so what are you going to do? It's Friday afternoon. You want to go to the seaside, so you don't take pictures. You don't write anything in the report. I know this from Anand. You send the patient back home, and you go away for the weekend. Then the second option is to call the attending surgeons. They were not convinced by our US. So they should do an emergency Whipple procedure. I wouldn't advise you to do that because the surgeons, especially during the weekend, might not like this option. Third one is to call interventional radiology. You suspect a bleeding, so maybe they can locate the source. The last option was to call an advanced fellow to do an emergency RCP and follow up the patient. I'm not sure if we have the voting system, but I'll tell you what we did. So we sent the patient back home after 2 hours. The problem is that the patient came back in the emergency room 5 days after the US with fever, jaundice, right upper quadrant pain, and black stools. And one of my colleagues did an emergency RCP. They tried to cannulate initially. The biliary cannulation was quite difficult due to the malignant appearance of the papilla, and the needle knife fistulotomy was performed. So they did pre-cut fistulotomy. So they entered directly in the bile duct, and they placed 2 plastic stents, 2 10 French plastic stents of 9 and 7 stents with efficient biliary drainage. At the time of this CRCP, there was no bleeding. However, next day, the patient presented with hematemesis, melena, hemodynamic instability, drop in hemoglobin, I think 6 grams. And this is how the second ERCP looked like. And cleaning up the clots took 2 hours. So you have to be very patient. The patient was intubated, of course, and it took 2 hours. And you see there was active bleeding in the second duodenum. It was really difficult to locate the papilla and the plastic stents, so it took some time. At one point, a bit of blue appeared in one corner, so actually the stents were located more radiologically than endoscopically in the beginning. And finally, I won't leave you the whole movie, but cannulation was achieved and a self-expandable metal stent was placed inside the bile duct. Now, of course, the question and the discussion will have to be if our initial US-guided FNB caused this bleeding, or if the subsequent ERCP caused the bleeding. We were not sure about this, but it might have been our initial biopsy which caused the bleeding inside the bile duct, and then after placement of the stents, because the pressure decreased in the bile duct, then it might have been followed by the bleeding in the duodenum. And then I'll try to show you a second case. So straightforward case, 72-year-old male patient with a pancreatic head mass identified on CT, referred again for US and the US FNB. We did again elastography, we did contrast harmonic imaging. The mass was hypoechoic, it was inhomogeneous, It was invading the terminal part of the CBDM pancreatic duct. And the diagnosis, we did a new SFNB. The diagnosis was of pancreatic adenocarcinoma. So now, so it was pretty straightforward case. What we did when we took out the echo endoscope on withdrawal, we have seen a lot of bright red in the stomach. So actually we changed the EUS scope for a therapeutic gastroscope, and we saw a very small Diolafol lesion of about 3 to 5 millimeters with a slow arterial but pulsatile bleeding. And you can see the lesion that was bleeding at the level of the gastroesophageal junction. So one of the young doctors just injected, I think it was only a few mLs of adrenaline, diluted adrenaline, and the bleeding stopped immediately. So now the question is, what are you going to do with the patient again? It's Friday afternoon. You don't take pictures. You don't write in the report because it's a minor Diolafol bleeding, and you send the patient back home. That's the first option. Second option is to call the surgeons for an urgent Whipple. They don't like that, so they will not come for sure. Then you should call interventional radiology. Maybe they should be careful to admit the patient and maybe to do something. And the last one is to call an advanced fellow who should follow the patient in the afternoon and maybe do a second look GI endoscopy. So what we actually did, although the patient was feeling well, he wanted to go, actually he was from the Black Sea coast, he wanted to go to the seaside, not the doctor. However, we kept the patient in. After 6 hours, he was sweating, he was tachycardic, he had orthostatic hypotension with 3 red blood stools, hemoglobin dropped of 5 grams per deciliter. And then the attending doctors, they took him for an ultrasound where the stomach was filled with inhomogeneous content. So this is how the stomach looked like. On the second look, upper GI endoscopy. And there was an adherent pulsatile clot at the level of the GI junction. So looking a bit retrospectively, we should have clipped this in the first place. However, the bleeding stopped immediately, so we didn't thought it's a major bleeding initially. However, during the next 6 hours, it developed further. So actually what we did is we placed 4 Locado clips of 16 millimeters to close the defect. So starting with these patients, we decided we want to keep the patients a bit more in the hospital. So we tend to keep them for 3 to 6 hours. Usually we keep them for 6 hours. We measure again the hemoglobin. If there's no hemoglobin drop, and if the patient is feeling well, we just send him to patient. Yeah, that's what the junior doctors saw in the stomach. They weren't sure what's this, but it was actually a big clot in the stomach, which was seen also on ultrasound. And you'll see the clipping in a few seconds. It's not easy to place clips at the level of the gastroesophageal junction, but if you turn the defect slightly, so you have to turn it slightly at 6 o'clock, and then you'll be able to place clips. It's a bit more difficult to place clip in retroflex view, but directly you can safely place clips. So I think these are the 2 cases. Those were the teams. So you see that there were several doctors involved. So we think that most of the doctors should be also trained in interventional endoscopy as well. And we had a lot of nurses which were involved in these 2 cases. And please remember, you have to keep calm. All bleeding stops eventually. And I think we are seeing more and more bleedings with the new histological needles because they are a bit more aggressive towards the pancreas and the surrounding vessels. Thank you very much.
Thank you very much. Very nice cases. And if there are any questions from the auditorium. So the solution is to keep calm. Yeah. And this is available for all of us. Yes, we all have complications.
So, Adrian, do you recommend for checking hemoglobin and red blood cells when you experience some minor bleeding before sending the patient home, or it has no value in your opinion?
I don't think it has a value. I mean, for FNA, we were always sending the patients back home after 1 or 2 hours. Nothing happens.
No, I mean just in case you suspect the bleeding is going on.
If you see something during endoscopy, if you see a small hypoechoic appearance surrounding the tumor, so if you have the slightest suspicion of bleeding, I think they should be kept at least 6 hours. And you should check the hemoglobin at 6 hours intervals. Otherwise, I agree, it's a safe procedure. The complication rate is really small. So I think those two were among 1,000, at least 1,000 US FNB procedures. So it's really rare, but it can happen sometimes. So. And again, especially with the new histological needles, because they are a bit more aggressive, they tend to become blunt. You have seen it during the live demo today. So the first pass was really easy. On the second and the third pass, they become a bit blunt, and you cannot go through the muscle layer of the stomach really easy. So you have to push more. When you push more, sometimes the needle goes on the side, and you can damage the vessels.
I just want to ask you and to talk together about the risk of bleeding and antithrombotic therapy, because I think this is the most important. There is a recent meta-analysis considering all the anticoagulants, the direct oral anticoagulants and warfarin also. Which is the most, let's say, dangerous between the antithrombotic therapies? Where should we give more attention, and if the bridging therapy with heparin it increases the risk for bleeding or not?
If I can say, both patients were they didn't report any anticoagulants, so both patients were without any. At least if you take our experience with polypectomies, I think clopidogrel is the most aggressive, so you should be very careful with clopidogrel. You should stop it for at least 7 days. That's what we do, and switch with a low molecular weight heparin. Then it's the direct acting anticoagulants, and then I think that the rest are pretty safe, and aspirin is also safe. So we didn't have problems with aspirin. We didn't have problems with low molecular weight heparin, although we tend to stop. We don't do the morning dose when we do FNB, but there's no proof of that. But with clopidogrel, we had problems, especially for polypectomy. I don't know if for FNB.
I think we should take care, because US FNA and FNB procedures are considered as high-risk procedures in the ECG guidelines. So we have to take into consideration that we have to respect these days which are indicated very clearly, because even in this situation we can have problems with our patients, and if we do not respect the guideline, then we can be judged as a malpraxis. Thank you very much for your presentation. Julio, it's my pleasure to invite you to present your case, please.
Okay, thank you very much for the invitation to be part of this complication in EUROEUS. And thank you very much, Andrada, for highlighting the problem of anticoagulant therapy and antiaggregant therapy, because my case is a little bit different to the ones that have been presented by Pietro and by Adrian. Because, I mean, this is summarizing that we know we have in EUROEUS complications that can be considered as local complications. We can have perforations, we can have bleedings, infections, pancreatitis post an AUS-guided FNA or FNB. But we need to be aware of systemic complications. And that means that when we're doing an AUS, diagnostic AUS, we are not only doing the puncture, we can not only perforate with the scope, but we can have problems related with the sedation. So we can also have cardiovascular alterations because of the way we manage the patients. And although this is many times related to the anesthesiology, sometimes we are ourselves doing the sedation of the patients. And we need to take into account the complete patients, not the patient, not only what we do while we're doing the US, but how we manage the case completely. Because in fact, if we go to the complication rate, and this is just to highlight what we have already saw, the complications in AUS and AUS-guided sampling is not so high. It's between 0.3 to 6.3 in total. But if you see, and if you focus, almost everything is related to bleeding, everything is almost related to perforation, but we all know that we can have other type of complications when we do an AUS-guided sampling or just an AUS-guided diagnostic without doing any kind of sampling. And we need to take also into account when we talk about the theoretical contraindications for AUS, and this is to link with what Andrada told us, that is anticoagulant treatment or non-substituted coagulopathy, the inhibition of platelet aggregation by clopidogrel and other thienopyrimidines. So this is very important that when we look to our patient, we need to understand all of these contraindications or medium contraindications before we start to do the case, because we can have a lot of complications afterwards. So with this background, that not everything is the complication because of the puncture or because of the AUS, I want to present a case that the team here in Santiago know all very well. This was a 75-year-old female with an arterial hypertension, with a secondary myocardiopathy, with a mitral stenosis. Also, she was with an atrial fibrillation under anticoagulant therapy, with a dyslipidemia, hypothyroidism, and obesity with a type 2 diabetes, with a liver cirrhosis because she was a usual drinker in Galicia. She usually drink every day the home wine, which is as bad as the non-home wine, and underwent a renal transplantation in 2020. So this is the background of a complex case, very usual in our clinical practice with a lot of comorbidities. So the patient was under surveillance because of the liver cirrhosis to check for liver cancer and the evolution of the liver disease. And during the follow-up, in the percutaneous ultrasound, we detected a pancreatic lesion. The initial report of the percutaneous ultrasound, it was a mixed solid and cystic pancreatic lesion, very close to the one that we performed, Adrian and myself, this morning during the live case, with the hypothesis of a neuroendocrine tumor. So the patient was initially referred for a PET dotate, so a Galio study, and this is the report of the Galio study. So showing a lesion in the middle part of the pancreas, positive for Galio. So again, highly suspicion of neuroendocrine tumor. So in this point, the patient was referred for an AUS-guided tissue sampling. The question, I mean, if we see the lesion and it's positive for Galio, the question is, should we have biopsied this lesion in a 75-year-old patient with all of these comorbidities? But we did it. So first time pancreatic tumor, we sampled 25 gauge crown needle, and we didn't get enough material. So we went for a second shot. So the second shot, we make a sample again with a 19 gauge crown needle. And also, I think Danny can remember that we did also a Morey to try to optimize the result of the cystic part. And we were very fortunate because it was a neuroendocrine pancreatic tumor, G1, with a K67 below 3%. So at this point, we were extremely happy because we have a positive diagnosis for a benign pancreatic tumor, not deserving any kind of follow-up or surveillance because of this lesion. But this same afternoon, after we performed the procedure, the patient, something happened within 24 hours after they used an FMB, and it was really related to or within the procedure, and is that the patient arrived to the emergency department with a decrease in the conscious level, aphasia, and a right hemiplegia. So a CT scan was performed. That's going to be the videos that I want to show you. And unfortunately, the CT scan in that point was normal with no alterations. But in the angiography, they detected a thrombus on the left carotid artery. Fortunately, the interventional radiologists were able to remove the thrombus. And so after the intervention, the patient presented a complete recovery, no sequela, and after 7 days of admission at the Department of Neurology and Neurosurgery, the patient was discharged, and we saw the patient a couple of weeks ago, and she's doing well. So the point here is, but Julio, why are you taking this case? Because it was nothing related to endoscopy. But my question is, it was related to endoscopy. Because when we analyze, and this is the video of the angiography, so we can see, I'm not a good radiologist for neurology, but I can tell you that there is a thrombus in the left carotid artery that was removed by the surgical radiologist, and the CT scan showed no defects, no alterations, and a former MRI that was performed afterwards was also normal. So in this case, when we want to analyze, it is important that complications are not only related to the procedure, to the scoping, but can also be related to the complete management of the patient. So when we analyze what happened, remember the patient atrial fibrillation, anticoagulant therapy, and in this case, when we analyzed, we did an incorrect management of the anticoagulant therapy, because although we stopped, the patient was under warfarin therapy. So we stopped according to the guidelines, but the problem is that we did not restart the treatment according to the guidelines. We take too long to restart the treatment. And because we take too long, the patient developed a thrombo. So if you want to remember the guidelines, we just said high-risk procedure, warfarin, the patient belongs to the red boxes. So we did an incorrect management of the anticoagulant therapy because we start too late. And before we restart, the patient developed a stroke with a thrombo in the carotid artery. So my message is, remember that we are not only endoscopists, we are doctors managing patients. And I think it's very important that we take all the patient into account and be strict to the guidelines. Because if you be strict to the guidelines, the time you need to stop clopidogrel, the time you need to stop warfarin or the new anticoagulant therapies, follow the guidelines, because you will skip a lot of problems not related to the procedure itself, but related to the management of the patient while you're doing a diagnostic EUROEUS guided sampling. So this is just the message. Be aware that the patient is not only the technique, is not only the scope, but it's also managing the complete patient whenever you manage your patients. Thank you.
Thank you very much, Julio. Are there any questions? Thank you so much. So the message is that in our practice, we still have complications, but this is available for all specialties, not only for gastroenterology and endoscopy. So we have to be prepared to keep calm, to look very closely our patient after the procedure, and to take into consideration that up to 5% in cystic lesions, we have complications, even severe complications in our patients. Thank you very much for your presence and your attention.
Let's start with the next session, please. If you take your seat, we are a little bit in a hurry. Yeah. So good morning again. And welcome to this Fujifilm Symposium at EUROEUS 2024. As innovation is running, the goal of this symposium is to explore the advancement in endoscopic ultrasound, considering both the diagnostic and therapeutic procedures. And innovation is also running in digital pathology with an innovative real-time approach with very important effects on patient management. So today we have three let me say, very experts in this field. And I don't want to take up any more time. So let's start with the first presentation. We have Professor Di Matteo from Rome Universital Hospital Campus Biomedico. And first is Bridging Vistas of Medical Innovation, Unlocking the Power of Interventional Endoscopic Ultrasound.
Hello to everyone. Thank you for the kind invitation at this outstanding event. I'm going to talk to you about the probes of Fujifilm. I don't want to be just a Deplium. Everyone knows already that we got a new instrument in 1 year and a half. This one, EG 740 UT, that has some feature different from the other one. The working channel is 4 millimeter and the scanning angle is 180 degree. But which are the features that are different from the previous probe? Efficient device exchanging. Why this instrument has a G-lock instrument. The smoother device insertion, 4 millimeter channel, more device visibility in endoscopic image. The channel and lens layout are repositioned compared to the previous one, better access to the target, more device visibility in US image based on the 180 scanning range, enhanced image quality, refined maneuverability, and improved user-friendliness. Why? One-step connector, detachable cable, and new balloon. This is a proof in a phantom model between the previous EG 580 that is definitely reduced. But this feature we love so much, the G-lock device, is something that you can maneuver from the wheels of the shaft, and the effect is that you can stop the guide wire at the end of the tip. It's very useful in many procedures. This is a big goal from the company. In fact, you can see from this image, I've tried to show you not the US image, but the radiological image, because you can understand easily how is the position during this maneuver. This is exactly an example in which we use a 90 gauge needle. You can see how is the position of the instrument from the bulb. This is a 90 gauge needle by Cook, HS1. This is the passage with the guide wire, then the cystostome, 6 French cystostome. That's in all these phases, it's very important to keep the guide wire locked. That's why I show you this, and this is the picture from the duodenum. And so you can easily catch the guide wire by a duodenoscope. You can see the guide wire coming from the stomach, the duodenum, inside the biliary tree, and then we can use a metallic stent. But it's very nice, most of all for the biggest channel of 4 millimeter. it's true, this feature, because with all the lamps, it's very easy to manage them. This is an example. You know, now there is a huge amount of uh, always often evidence. This is one of the last paper in which this colleague says that the US guided gallbladder drainage could be a rescue treatment for MBO, malignant distal biliary obstruction. These are pictures from our group in which you can easily see the straight position of the scope, US probe. And this is another gallbladder drainage, but the position is completely different. And sometimes it's difficult to coming out with the 10 French lamps. Even if the windows, US windows, is very, very nice. Another evidence is the US guided choledoduodenostomy and US guided gallbladder drainage could both used in MBO after failed endoscopic retrograde cholangiography. This is a gallbladder EU study from France. So it's very important to have some probes in which you can use friendly this kind of the device. This is a typical, an unusual shape of the instrument during a choledoduodenostomy, even if the image, the window is very positive window. This is another case in which this is quite a typical position of the probe, is rotated medially. In fact, other observation, this is a famous study, Scorpion study, in which choledoduodenostomy with the lamps is used for primary drainage in MBO. This is another strange position, great position by US, but the probe is quite difficult to move. Another one, right position by US, not so complex position by radiology. So this is another nice study published recently in gastroenterology, element study, in which they say that US guided biliary drainage as a first attempt against ERCP in MBO. So this is the evidence. That's why we love to use probes that has these features. This is an example today. You watch the hepatogastroscopy and you watch on X-ray the shape of the instrument is not exactly this, but it's useful to have this bending range of the instrument. Most of all, this is an ideal situation in which you puncture, you get the access from the second segment. But if you get the access from this other segment, you must use the instrument in the bending angle, on the bending angle more acute. So it's so difficult to move the lamps inside. More device visibility. Look at this: elevator, lens, transducer. The new one is lens, elevator, transducer. It means that the position is this. This is the previous probe. The device go out at 1 o'clock. In the new one, the device go out at 5 o'clock, quite similar to the duodenoscope that we use in ERCP. This is another feature very interesting about reprocessing. You can wash the back, the shoulder of the elevator in the both sides, front and rear. So this is the angle. You can take biopsy in an acute angle, more perpendicular. So this is another nice feature that I didn't understand at the beginning. But look at this. The distance from the lens of the device is very, very short compared to the previous one and the other company. This could be useful because you are able to see immediately your device coming outside the tip. This is an example of the new image of a neuroendocrine tumor. But in this situation, you have to use a stiff instrument, a stiff probe, because you're going to use, as you watched this morning, a 90 gauge needle that is used for radiofrequency. That's the DFI picture and contrast medium picture after the procedure. But finally, in VN 2022 has arrived a new equipment from another space that we are going to listen from Professor Julio Iglesias, the new features. And it was immediately an infatuation because it's a very, very nice equipment, more economic, but we are going to see this. And it seems that the speed of image processing is very high. So I'm going to conclude because we got no time. Thank you to everyone, to Kojima-san, to the engineer Shiota and Morimoto, to the Kurt lawyers, and the Italian one, Antonio, and Danilo. Grazie a tutti. Never stop.
Thank you, Francesco. So if you have any question, just take in your mind at the end of the three presentation, let's move for any question in the audience. So the second lecture, Beyond the Surface, Harnessing the Power of the Advanced EUS Imaging, Professor Iglesias Garcia from University Hospital of Santiago de Compostela.
Well, hello again. First of all, I would like to thank Mara for the introduction and Fuji to let me be part of this very nice event to try to bring the diagnostic part of the US to its real point, because I think it is try to change AUS to therapeutics, but we never need to forget that AUS is an excellent tool for the diagnosis of several diseases. And one of the big advantages is as better image we have, as more we can diagnose better and better. So this is going to be a little bit of what is the real situation today of what is advanced imaging from B mode to what we've been seeing in the live cases, and what is the clinical impact of what we can obtain from these techniques that is going to be of real help when we're managing our patients. And it's very important to understand that AUS has evolved a lot since the beginning. And just to let you know that the first real publications about AUS come from 1986. And just to let you know, for the ones that are a little bit older, is the first movie of Top Gun. And now we are in the second Top Gun, and we are moving to the third one, and still Tom Cruise. And although just the same as Tom Cruise has been tuned over the years, I think AUS has been tuned over the years. And just to remind how the advanced imaging has improved, in 1986, Argentina won the world. I'm in Italy. This is a football country like Spain. And we won world champion, but Argentina won it in 1986 thanks to the man of God, that when Maradona scored the goal with the hand. And today with the VAR, this will be impossible. So again, this also changed. The technology has also changed, not only for the football, but has also changed for medicine, and it's changed for us in the field of endoscopic ultrasound. So remember, we started in the 1980s with the mechanical systems with not such a high quality. Then we arrived with the first electronic with the linear echo endoscopes, and the first FNA, remember, was done by Peter Billman, published in 1991. Then we started with the therapeutic AUS with the large working channels, and we start to adapt the ERCP devices to AUS. Now we have our own ERCP devices, AUS therapeutic devices, like Francesco has told us. But now in the 2023, and for the last years, is an increase in the technology associated to the diagnostic part and to the improvement on the ultrasound image. And this is extremely important because it's going to increase the role of diagnostic AUS. So in the evolution, and when we talk about improving image quality, it is not only the color maps of Elasto, it is not only the new DFI, it is not only the contrast enhancement that of course is going to be of absolute help, but everything started with the improvement on B mode. So for the improvement of B mode, we have some techniques that you need to take into account, although when you turn on the system, they all appear, which is the HiCom, the high resolution, the harmonic imaging, and the e-focusing. This is already set in your systems. But believe me that this is the first step to be able to have the elasto, contrast, and DFI. It's very important because as better B mode we have, as better the useless that is going to be, and better is going to be the advanced imaging. And when we talk about B mode, it is high resolution, it's tissue harmonics, and it's compound imaging that at the end summarizing is getting out artifacts and having the real gray color map that is going to be of real help in the routine of everyday exploration that you are going to perform in your units. But come on, we're talking about new capabilities, new options. So for us as endosonographers, the fortune is that we are moving from black and whites and grays to some other colors that were not possible in the past. So when we talk about the new diagnostic capabilities, and this is the topic and very important topic, it is that now we can evaluate the stiffness of the tissues, and we know that the stiffness is different among different conditions. It is not the same a solid tumor as an inflammatory disease or a normal pancreas, for instance. But we also have a lot of information regarding vascularization, and we know from the cases of today that having the vascularization, we are going to have more information on the potential diagnosis of the lesions. And I'm going to skip sampling because we are going to have a topic about EUROEUS-guided sampling that I'm not going to cover at all during this talk. So what we're talking about? What is elastography? Elastography is a great technique that is going to allow the evaluation of the stiffness of the tissues. Today we have two options. We can go for the strain elasto, which is the one that you most usually saw over the last years. This is color maps in which we know that green is soft and blue is hard. But now we also have the opportunity to do shear wave elastography. At the end is very similar to the fibroscan with what we use in the liver, but perform with the ultrasound system, and we can now use it EUROEUS-guided. This is elasto. But the other part in terms of vascularization, we can use contrast enhancement by the use of
Maybe you can tell about the settings we use for the axios placement.
So I think that's a very important point. On the electrocautery, we use AutoCut effect 5 on 100 watts. And this is extremely important because you don't want any coagulation. You don't want to use a ERCP setting. You want to use pure cut in order to transverse through the gastric wall into the small bowel lumen as fast as you can, because if there's any delay and you have to push, you will push away the small bowel loop, and there's a risk of a complication occurring. So this is incredibly important to set it in the correct setting, to use the correct setting.
Going to be vascularized. And of course, there's a lot of ongoing studies, some of them coming from Santiago, in which we're trying to compare both techniques. But come on, with this background, what is real the it's not working? Can you well, this is things of the techniques always happen live. It's better in the presentation than during the live cases. Okay, so let's take a look at how these techniques has improved our capability in the managing of different conditions. If we talk about solid pancreatic lesions, this is a summary on the sensitivity and specificity of elasto and contrast enhancement. And I can tell you that it has really increased the diagnostic yield for the detection and for detecting malignancy in solid pancreatic tumors, and now has an increasing role in local staging detection of a small metastasis. For instance, with contrast enhancement, we can detect a small metastasis in the liver. In fact, this is an example on how we can see these hard lesions usually related to pancreatic adenocarcinoma how benign neuroendocrine tumors tend to be soft because they have a low proliferation index, and how we can detect small areas of pancreatic malignancy in the setting of a calcific chronic pancreatitis. So it's really of help in optimizing the management of solid pancreatic tumors. But if we switch to contrast, if we start to combine, we know that metastases from non-adenocarcinomas tend to be hypervascular lesions as well as neuroendocrine tumors. But in the other hand, when we have pancreatic cancer, it's usually an hypovascular lesion. So it's also of help. And if we combine both techniques, be aware that we can have a very nice approach to what is the potential final diagnosis, and also can guide us on what type of needle do we need. Because if you're suspecting an autoimmune pancreatitis, probably you go directly to use a 19 gauge crown needle or biopsy needle. But this is the new technique, and this is a study that is ongoing in Santiago that we have presented last year. And as we try to compare the pattern of vascularization between contrast and DFI when we evaluate solid pancreatic lesions, and very nicely we see there is an agreement on the pattern in all but one case. So it seems that maybe it is not going to overcome contrast, but probably in a lot of cases we can have enough information to have an approach to the final diagnosis based on DFI that we do not need contrast to use this technique. But it's also critical in cystic pancreatic tumors. I'm bringing here the latest Kyoto guidelines, in which I put in a block letter that one of the worrisome features is the presence of a nodule that uptakes contrast. So a nodule that uptakes contrast, you need advanced EUROEUS imaging to be able to state one of the worrisome features when you manage in cystic pancreatic tumors. And this is an example on how we can see some of these nodules uptaking contrast. Here you can see in the picture. And again, another option is that based on vascularization, you can have a nice approach whether this is really a mucinous lesion or not, like the case that Logan and Prieto performed this morning that tend to be finally a pseudocyst adenoma, is like the image in the DFI that you have in the center of the screen. So contrast and DFI as a good role for diagnosis and the detection of worrisome features and a high-risk stigmata, according to the guidelines, 2024 guidelines published in Pancreatology about the management of IPMNs. But it's not only for tumors. We are checking a lot the role of advanced imaging for chronic pancreatitis, for the detection of early chronic pancreatitis. And we know these techniques as a correlation, very nice correlation with the Roseman classification. But the study from Ito shows a kappa score of 0.9 when you compare the histogram to the histological score of chronic pancreatitis, which is amazing. But it's not only that, but there's also find a correlation between the stiffness of the tissue based on the strain ratio and the presence of exocrine pancreatic insufficiency. So it's really providing information for early diagnosis, but also for the evaluation of patients in advanced stages of the disease. We are now working on the concept of DFI. We know that inflammation induces neovascularization. And if with DFI we can detect vascularization, why not using this technique to detect inflammation in chronic pancreatitis? So this is some of our ongoing ideas and ongoing studies, but we hope to provide more information in the near future. But it's not only pancreas. I mean, we do EUROEUS not only for pancreas. We know that this technique, Elasto, is very useful to detect malignant lymph nodes, which is, for instance, critical when you're managing lung cancer patients to identify which is the node that you need to target. Forget the green nodes, go for the blue ones, for instance. But it's also useful for subepithelial lesions. So we know that the GIST are harder than the leiomyomas, so we can detect the stiffness based on elasto. So if you have a blue lesion, hard lesion, it's more likely to be a GIST than to be a leiomyoma. And we know that the vascular pattern is going to provide a lot of information on how the lesions look like. It means that if you have an inhomogeneous uptake of contrast in a GIST tumor, probably is more related to be a malignant with a higher proliferation index. So it's giving information for the differential diagnosis, but also for stating the potential of malignancy of these tumors. We're also checking if we can use elasto to guide, to distinguish between T3 and T4 luminal tumors. And the data that we start to have is quite nice and quite interesting. And you can see in this image how when we have the green line between the tumor, it's very nice and very likely to be a non-infiltrative lesion. But in the other hand, when you see the blue going down of the lesion, it's very likely to be an infiltrative T4 lesion. So this is another idea of what we can use elastography in luminal tumors. And just coming to the end, recent studies, shared wave elastography, EUROEUS guided. This is the liver indication for the US. It is not only that we are able to do a biopsy today, but we can also do the shared wave evaluation. And the we expect to make comparative studies with FibroScan and with percutaneous shear wave elastography, but the initial data that we are playing in Santiago, it seems that is quite nice and quite comparable. So in one shot, we can have all the information of this kind of patients. And of course, if we keep growing, we will reach artificial intelligence. And I'm sure that if we link artificial intelligence with advanced imaging, it's going to be even of more help for distinguish between different lesions and different conditions. So just coming to the end, briefly, AUS comes from a great past, but I think it has an enormous present, not only for complex therapeutic procedures, but also and mostly for diagnostic indications. Advanced imaging increases even more our diagnostic capabilities in several indications, and I think it keeps growing, and the DFI is a quite recent, just 3 or 4 publication from Yamashita, only today in the literature. Artificial intelligence is coming, and probably is coming to stay, like in standard endoscopy. But very important, I put it in red light, in red letters, never stop learning. Everything related to AUS, anything related to advanced imaging, you need to learn. We need to learn how to use it, because it's not just pressing a button. You need to understand the background. You need to understand what is the scientific information that you're obtaining. So don't think this is pressing a button. You need to understand and you need to learn. Never stop learning. I never stop learning. I've been doing AUS for the last too many years, but I always learn. Anytime Kurt or any kind of the engineers come to Santiago, I always learn a little bit more. So never stop learning, please. And thank you for the attention. And I think we give the word to the pathologist, which is also key and very important.
Thank you, Julio. So let's move on the last presentation. Professor Crescenzi from University La Sapienza in Rome. Instant histopathological diagnosis in the endoscopy room for enhanced patient management.
Thank you. Good morning. I am a pathologist, so I am going to speak about innovation in the histological diagnostic. What we know as instant digital pathology is a new technology that allows for direct imaging, digital imaging from fresh unfixed tissue without the preparation of the conventional slide. It does not require any fixation, do not produce damage in distortion in the tissue, and preserve it for all the additional procedure, and may be used both in histological sample and in cytological sample. The only treatment that is required is some drops of acridine on the sample before the imaging. And this is how the technology works. The technology uses 2 laser sources. The first induces reflectance in the stromal component of the tissue, such in this case of lung parenchyma. The second laser induces fluorescence of the acridine with the nuclei, and the proprietary algorithm merge the 2 images and make the final image in hematoxylin pseudocolor to make it more familiar to pathologists. This technology produces digital imaging quite similar to the conventional histology in hematoxylin, such in this case of perineural invasion, with a good resolution of both architectural and cellular detail. Of course, ultrasound endoscopy is one of the most interesting field of application of instant digital pathology. From the pathologist's point of view, there are 3 challenging issues related to this procedure. The first is that the specimens are a mixture, a complex mixture of cellular material and microcore fragments of tissue. So they require an accurate management to preserve all the parts. Second, the procedure is complicated. Pathologists are often asked for the assessment on site of the adequacy of the sample to avoid a non-diagnostic result. And finally, most patients have advanced tumor, so The sample obtained with the EUS is the only material for the diagnosis, but also for the characterization of the lesion and for the molecular profiling for the targeted therapy. Well, the instant digital pathology is a solution for all these points. This is the workflow. The samples is put on an holder that is a matrix with the positive charge on the surface that retain the material during the process. Some drops of acridine transfer the specimens within the microscope slot and obtain the macro imaging of the matrix. And then you choose the area and send the digital acquisition. You may at this point to have the hematoxylin eosin pseudocolor for the assessment both of the adequacy of the sample and, when possible, a diagnostic hypothesis. Step 1 to 6 require from 3 to 5 minutes. After the microscope the digital evaluation, the samples is put in formalin and processed for paraffin embedding as routine in any pathology labs. In the past 3 years, we have developed a consistent experience in use of the instant digital pathology for solid pancreatic lesion with high diagnostic accuracy when comparing the digital imaging with the final permanent histology, and demonstrating also a short learning curve for the pathologist in the use of such kind of imaging. And here are some examples of some cases observed on the here for at the real-time evaluation in the endoscopy room, and after the inclusion in paraffin with the immunohistochemistry and the proliferation index on the final image. This is an unusual tumor, solid pseudopapillary neoplasm, in which the tumor is composed by cellular papillary frond with hyaline axis, including a blood vessel, and this is the real-time imaging at the time of the endoscopy, and this is the confirmation on the final permanent histology. Also in a non-neoplastic condition, this technology may work well. It is a case of, for example, of a chronic pancreatitis with the atrophy of parenchyma and inflammatory cells confirmed in the permanent histology, and with the positive staining for immunohistochemistry for IgG4. More difficult is the brushing of biliary stricture. In this case, we put some drops of lacridine directly on the brush to see the cell entrapped in the bristles. And you may see all nuclear and cellular detail without remove the cell from the brush. After the digital imaging, you may use the brush as usual in the laboratory. So you may smear the brush or wash the brush in a fixative solution. Also in the thorax, it's possible to obtain all the same information. Adequacy, in this case, of high-grade tumor, and adequacy for the morphology, diagnosis, and adequacy for the final molecular profiling. This is a case of adenocarcinoma, and this is another case of squamous cell carcinoma. And this is a difficult case because a lot of blood in the sample with a large area of necrosis, but in the digital images, it's possible to see small cell with fragile nuclei and molding of the nuclei, such this kind of image with the file of the nuclei. And this is the permanent section The material is the same because during the real-time imaging it was not used, cut, not fixed, not frozen. And finally, histology also demonstrated the neuroendocrine markers positivity. So, small cell neuroendocrine carcinoma. And this introduces another issue, that is the presence of blood cell or a fibrin clot obscuring the detection of neoplastic cell. This is not a problem for instant digital pathology because acridine does not stain the red blood cell, so you may identify the neoplastic cluster more easy. This is the complete workflow in endoscopy room, from the sampling, the loading of the sample on the matrix, acridine, inside the microscope, imaging, and pathologist evaluation, and feedback to the endoscopist in about 5 max 10 minutes. It depends on the interpretation of the result. This workflow perfectly works, but there are some studies that are ongoing for the future. One is instant immunohistochemistry for real-time characterization of the cell and assessment of prognostic and predictive marker. Artificial intelligence also for computer-aided diagnosis in instant digital pathology, and finally, fast molecular profiling of this kind of material. Well, real-time immunohistochemistry is just a reality because it works and only need to reduce the time frame, because at the moment currently it takes about 20 minutes. You may see, for example, a membranous and cytoplasmic antigen stained in red fluorescence in the samples confirmed at the final histology. Also, AI algorithm just work. It was developed in collaboration with an Italian company, SenseLedge. The algorithm was trained with annotated images and is able to identify neoplastic cells in autonomously. And this is how the image is showed. The pathologist that is observing the digital image from a device, a mobile device, may enlarge the clear area to see the cells. So it speed up the interpretation from a remote position. And about molecular profile, this is the current workflow. After the EBUS, there is the histological evaluation, and if adequate, move the sample to molecular lab, obtain molecular analysis, obtain the result, and start the planning of the patient's treatment. This workflow requires a time frame of about 3 weeks, but we know that may be more longer, as we know from international literature. Well, we may change the paradigm with the use of instant digital pathology. Perform the EBUS, check the material, if adequate, identify the cellular area in which you may count also the cell, and mark the area on the complete digital image, translate the area on the macro image, so you will be able to scrape the material from this specific area with the blade of a scalpel, prepare the cellular material for PCR, and obtain the result for the main actionable gene alteration, such in this case in which we obtain this deletion of exon 19 of the AGFR gene in less than 3 hours. So the time frame from EUS or EBUS to therapy planning may be less than 1 day. Then, this is my final remark. What we may obtain by real-time diagnostic in the endoscopy room. Immediate feedback about both morphological and molecular adequacy and, if possible, diagnostic hypothesis. Minimal preparation that doesn't need on-site pathologist or cytotechnician. Full tissue preservation for all analysis, permanent hematoxylin eosin from the diagnosis, and all additional staining. So increase availability of tissue for prognostic and predictive information. Possible remote consulting for first or second opinion from other institution or other part of the same institution. Reduce the laboratory burden because the matrix is paraffin compatible and sectionable, so does not require handling by laboratory personnel to prepare the final cell block. Optimize resource and increase patient safety because you minimize the necessity of rebiopsy, and innovation is still ongoing, real-time immunohistochemistry, AI algorithm, and fast molecular profile that are under validation. Thank you for your attention.
Thank you, Professor Crescenzi, for this amazing lecture. If there are any questions from the audience, please. We have a question from our pathologist. There is any microphone in the room?
Thank you. So I have a curiosity. So concerning, for example, lung pathology, PDL1 is a big problem when you don't have a cell block. So have you got already an experience with VivaScope? Do you see any problems in assessing PDL1 on VivaScope? We tried in the past, and it was it was working well, I mean, but I wonder if you have more experience and any concern about. Thank you.
We are now testing antibodies for constituent of the cellular. The PDL1 is an important issue and is one of the target of this study. Looking at the result we have just obtained, I think that it will be possible because usually the stain now works well, but I have not still the results about PDL1.
Any other question? I just have a comment, since it's really interesting. There are plenty of paper about type of needle, gauge of needle, technique of biopsy. When you perform the biopsy, Francesco, is always with the histology needle, I suppose, or not? And probably doesn't matter the needle.
Based on this technology, it doesn't seem that it depends from the needles, because you catch every single cells and the structure of the sample. You don't smear, you don't do anything more than drop the material on this cytomatrix, and then the machinery makes everything alone. And then you can use your sample for everything you want. Histology, immunohistochemistry, NGS, mRNA, and so on. This is quite impressive. And most of all, it's impressive that you, in your routinary work, you can share what you're doing with other center because it's digital pathology. That's very interesting. All the works paper that there are in literature about EI are based on the smears that you acquire with a machinery. You make a digital photo of this, and then you can do everything. But in this case, you got a bias. Correct me if you agree, because you got the bias of your smear, your staining, your drying of your smear. This is a big bias. With this system, you take everything of your sample and you can watch exactly in every field the structure, the cells without blood. And imagine if you are able to analyze this with the EI, and for me it's very incredible, but I think also for you. And you can have a molecular profiling after a few hours. It's really a new paradigm. I've never seen something like this. And I would say to you that I'm routinely working on this with this style. It's not true, because the machinery is in another level, in another building, but we are working with this aim. We would like to have the machinery in our room and to contact her, sending the image without a letter moving. So this is an ideal work. But as Julio said before, you must learn, and probably this will be just around the corner.
I have one small comment, Mara, because when you were right, with discussing so they use a crown needle, FNA needle from the crown, Francine, fork tip, slow pull, aspiration, nothing, styled, no styled. But we are forgetting some of the most important things of EUROEUS-guided sampling, which is the pathologist. And we all work with very expert pathologists, but when they left or when they are not in the room, it's a big problem. And I think one of the systems, as Francesco is highlighting, is that if you have any doubt, I can connect with you from Santiago to ask your pathologist to give the advice on what is your impression, because and I think the world of pathology associated to EUROEUS-guided sampling is extremely complicated, because we are providing not such big samples in very complicated diseases that pancreatic cytology and pancreatic pathology. I think it's one of the most complicated issues, as far as I know from my pathologist.
Any more questions? Okay, so thank you very much. Thank you all. Thank you, our experts. And thank you also, Fujifilm, for this opportunity. And now let's move on to the next session. If you are ready, I think so. The next session, US guided biliary drainage with Professor Cajal, and clinical case discussion.
Yeah, perfect. Well, I hope you guys had wonderful time this morning, and we'll start this session. This is EUS guided biliary drainage, and we'll hear from the experts some of the complications that they encounter with this. You know, this reminds me of a quote that I read somewhere, that most of us, when we go to the live conferences, we go thinking that this is going to be a NASCAR or Grand Prix, if you will. We are there to see the crashes. So the panel is going to discuss their crashes and see how they were able to navigate that. Our first speaker is Dr. Sandeep Laktakia. He is the Director of Endoscopy and Interventional Endoscopic Ultrasound at AIG Hospital, Hyderabad, India. Sandeep.
Thank you. Good afternoon, everybody. At the outset, I would like to thank Paolo and his entire team over here for having us to this beautiful conference, EUROEUS 2024. It's a very popular conference world over, and I am glad that I'm part of it. So in this session, I would be speaking on the complication of EUS guided biliary drainage, a case that I will discuss and maybe take your opinion in between, what went wrong and why. So this is a story of a 51-year-old man who had obstructive jaundice for 1 month and weight loss of 6 kg in last 1 month. He was a poor, unfortunate patient. Why? We'll discuss that as we move forward. Before we go forward, I'll just like to show this picture to you. This is a story of a big, fat Indian wedding. The man on the screen on the left is Mukesh Ambani. He is in the top 10 richest man in the world. His son is getting married here, and that's his wife. He's the 9th on the list. And he spent a whopping 1,000 crore rupees, which is 0.1% of his total wealth, for this wedding. This was 2 days back. And if you don't know Indian currency, this is equal to $12 billion, which is equal to 11.1 billion euros. So he spent this much amount of money on his son's wedding, which was attended by who's who of the world. You see Bill Gates there. He's a Facebook guy there. Bill Gates and his wife, and Ivanka Trump and his husband. And we had the singers from the Hollywood. I was also prepared to go for this wedding with my family, but I had to attend European US, and that's why I'm here. My dress is ready, and I was told this is not the wedding that they had, this was just the engagement ceremony. Wedding is due in July, which will probably be more costly, I believe. Hence, I'm here. So coming back to the case, this poor, unfortunate. In India, we have a huge disparity of wealth from very poor to extremely ultra-rich guys. So he came with this obstructive jaundice. A CT scan showed a dilated bile duct and intrahepatic ducts, dilated pancreatic duct, showing double duct signs of a periampullary carcinoma. We did an EUS. This is dilated bile duct and the gallbladder. And you could also see the tumor infiltrated in the duodenum. We could shorten the scope and could actually go across the tumor as well. But since there was some duodenal infiltration, we thought might as well do a hepatogastrostomy. And we decided to use a partially covered geobore stent, which was 10 centimeter long and 3 centimeters uncovered internal part, which we used in the case today as well, and 7 centimeter the covered part. A 10 millimeter diameter stent was decided to use. And let me show you the video of this patient. So this is a nice juicy intrahepatic duct, not like what we had in the real case today. Paolo was unfriendly to me today. He selected the tough one. So here we pass the needle, put some contrast inside, and the guide wire goes into the bile duct. We create a fistula between the stomach and the bile duct, and then pass the stent. Looks quite straightforward. And you see the stent being deployed, seen endoscopically. So this was the picture which we saw on fluoroscopy. So what went wrong? The question I can ask, I have the same last picture of the video, and you see this stent here. Would you continue doing the same thing, or would you do something different? We can have a poll from the audience. Would you do a PTBD, place a stent in stent through the same scope, or do a conservative management, or take a surgical consultation? Do you have a poll, Prableen?
Yes, we do.
If this can be done, or people can just raise hand and say,
Yeah.
shout it out.
So choice number 1, if you guys can raise your hand for percutaneous. Number 2, 3, 4.
Oh, people think that it's fine, everything was going well. Okay, so let me tell you what went wrong here. I'll play the video once again, and I'll start from where I left. So this is the stent picture. A fairly long segment of the stent is outside the liver. The margin between the covered and the uncovered segment is actually in the peritoneum. And when we realized this, we also saw some air going into the peritoneum, CO2 to be precise. We tried to place a stent in stent, which could not happen with the echoendoscope. So we switched over to a duodenoscope and then placed a covered stent, which was in the inner part, and this was the other stent, the first stent. So we salvaged the situation of a mal-deployed SEMS, which also happened today, which we also salvaged, and we were pretty happy about it. So lesson learned 1. So if I can go in detail in this case, this is called a candy sign, where you have a candy which has 2 constrictions. So the first arc is the liver capsule, the second arc is the gastric wall. In between is the expanded part of the stent. And this mark is actually the point of demarcation in this stent of the uncovered and the covered part, which is also somewhere here. So the red mark tells us the inner end of the candy, and the blue mark tells you the outer end of the candy. And since this green mark is outside the liver capsule, there's always a possibility of air or bile leaking out from that side and causing problems. So we salvaged it by SEMS in SEMS using a duodenoscope. This is how a geobore stent actually looks like. This is the point of demarcation, uncovered part and the fully covered part. A week later after the procedure, patient had developed fever and abdominal discomfort. And we did a CT scan, it found a subhepatic biloma collections. So there was some between the left lobe of the liver and the stomach. There was bile. We thought that was a bile leak which happened at the time of index procedure. And we drained it percutaneously, putting a catheter there. At 2.5 weeks from index intervention, he continued to have bile drainage coming out through his catheter. It was about 200 ml per day, no vomiting. What would you do now? Imagine this was your patient. You had placed a stent successfully after the second intervention of a stent in stent. Would you do a PTBD? Would you exchange the stent and place another stent? Would you continue conservative management hoping the bile leak will stop? Or you go through the stent and place an antegrade transpapillary stent? Anybody? I thought this was an audience interactive session.
Yes.
Okay.
Audience is awfully quiet.
Okay. So we make all these mistakes. Let's move forward. So we went through the stent using a duodenoscope. We passed a guide wire inside, going all the way across the stent into the duodenum. Looked a decent position now. I'm in a comfort zone. And then, because he was a poor patient, who could not afford another third stent, we dilated the lower end stricture at the papilla and placed a plastic stent, 7 French, 15 centimeter long. The distal end is across the papilla, the proximal end is across the proximal end of the stent in the stomach. So hoping that this would somehow bridge the leak. but the problem continued. At week 4, after the index procedure, he continues to drain bile through that percutaneous catheter. Not toxic, but he has a problem of continuous bile leak now almost a week, about 3 weeks plus over, and he is now getting nutritionally depleted. Still, there is no vomiting. So at this time, this was a picture that he had in X-ray. The stent still looks in position, the plastic stent. The metal stent is also fine. A week later, he comes to emergency ward with cholangitis and hypotension. We get a CT scan now, and it shows air inside the biliary system, some dilated system, some liver abscesses, the larger one in the segment 6. And this was the report of the radiologist who saw the CT scan. We went back carefully and we saw 2 more things extra, which was not reported by the radiologist. The plastic stent has actually moved up. It's now suprapapillary. And also the patient has a lot of gastric fluid, which was ignored by most of us. It was a hindsight interpretation. So at this time, since it was a liver abscess there, patient is toxic, cholangitis, hypotension. So we did a drainage of the liver abscess and also drained the intrahepatic biliary system, which was dilated. This was done by the IR team. We had to involve them now. So they passed the guide wire from segment 8 and 5 to the biliary system and the lower catheters in the liver abscess. At week 6, he still has a persistent drain from the percutaneous catheter. So at this time, decided let's peep inside the stomach and see what's going on. We saw some gastric fluid, and we removed this stent which was placed, and hepatogastric stent, which was 2 stents in telescope together along with the plastic, and we placed a fresh, let me show the video of that. There's a big opening next to the stent in the stomach side. We try to cannulate beside, pass a ball tip catheter and the guide wire. The guide wire remains above the papilla, but nevertheless, we thought that this stent is not working, let's do something, and we then pulled it out. Initially, we thought we'll go beside, but this didn't work out, so we had to pull out the stent, metal and the plastic together, and then cannulate that opening with the catheter. Let me just run it through. And then placed a new hepatogastric stent, again a geobore 10 centimeter long, 3:7 covered and uncovered part. And this drained copious amount of infected bile. We hope that this problem will now get settled down, and it did. So the PCD stopped draining, and the liver abscess catheter was then removed at week 7. But now he started developing gastric outlet symptoms. And for that, we placed a nasogastric tube to decompress his stomach and also placed a nasojejunal tube to the other nostril to feed him also, because he was malnourished and also developed some ascites now. So since the PCD stopped draining, we pulled both the catheters out and converted the PTBD into an internal stent now by the IR team. The patient was really unlucky, and they also malpositioned stent. So they had to place a telescoped stent in stent. You see, this is the first stent which was placed. The red arrows show the 2 ends of the distal stent, but the upper end of the stent is not above the stricture. So we place another stent like this. So finally, he had several stents now. And then a week later, we did a duodenal SEMS. I didn't want to do a GJ now because he had bad luck from all of us. He had me, he had IR team, and his own bad luck. Luckily, this went off okay, and at least his outlet obstruction symptoms stopped. So the lessons learned from this patient was keep your eyes and mind open, discuss with all stakeholders, IR team, surgeons, patient, never compromise. During EUROEUS2024, if you had noted that we deployed the first stent during endoscopy patient. That should never happen. Today, Michel Cahalet was repeatedly saying, always watch the wire, let the stent be seen only under the EUS image, don't try to see endoscopically. So resist endoscopic visualization. Deploy the stent in the channel of the scope, and then you withdraw your scope back while pushing it out. Second mistake that we did was using a plastic stent for antegrade stent. We had a good opportunity there. We were across the papilla. We thought we'll save some money and just place a plastic stent. If we had placed a metal stent, probably he would not have reached this stage. So dual drainage would have worked wonders. A lot of Japanese colleagues do that. Even if the patients were stable, they will put, if the wire has gone across the papilla, they will do is antegrade stent as well as HGS. And the third mistake that we made was that CT, which showed a significant amount of gastric residue, was actually contaminating the biliary system through that hepatogastric stent. And if we had done some gastric drainage earlier, probably we would have prevented his cholangitis and hypotension and his delay in overall management. Thank you very much for your kind attention.
Thank you, Sandeep. Very interesting case. Lot of teaching, learning points we learned from these. Any questions from audience before we move on to the next presentation?
Times before I finally understood exactly what was happening. And sometimes, even after a few cases, I called the rep and said, I need to come back. I want to just try and see what's happening when I do this. Why is this happening, you know? It sounds silly, but when you get into position with the bile duct, I think it's really important to make the bile duct very big on your screen and adjust the controls. I like to use the harmonics to really get good contrast between the black and the white, so that when you're deploying, you can really see if the stent is deploying enough inside the duct to feel comfortable to fully deploy, to avoid any misdeployments in between the wall and the duct. And again, try and make sure the working area is as big as possible. So you don't always have to have the bile duct round. When I get into position, sometimes I'll use the left-right to try and turn this system so that I get a long oval to make it at least more than 15 millimeters to really have enough working space to do the standard deployment, which is pushing in the catheter all the way, then deploying and then pulling back, okay? I also recommend that when you're putting in the system, obviously you have to wet it, it's a hydrophilic system, but I also tell the personnel, be really careful about folding it, about making loops. Try to make sure you do not traumatize the catheter system in any way. You want the Boston Scientific on the handle facing you, okay? And I made one mistake where it wasn't facing me, and I put it in, and then I twisted it to face me. That was a bad idea, because that twisted the system, and then the system, when I was trying to deploy, wasn't deploying properly. So try to keep everything straight, put it in very gently, just to make sure that the whole system continues to work smoothly. This yellow clip here, I just take this off before even putting the system in the scope. I think it's an extra step that sometimes, as you know, you kind of have to go quickly. We do everything under conscious sedation. So you don't want to have an extra step that's sort of not necessary. So I just recommend you take this off completely before putting the system in the scope. It's one less step that has to be done. I think it's really important, and I think you saw today with the gastrojejunostomy, let the catheter do all the burning work. Do not push if it's not going through already. So basically, this ceramic tip is very, very efficient. And I think you have to just take the time to let it burn through. And if you're getting any tenting, I think you have to stop pushing and let it burn and let it almost just slide through by itself. This avoids any tenting. It avoids any artifact that you get from the tenting. And then you don't get that clear bubbling of the water. You don't see the catheter clearly. And it is possible, particularly with pseudocysts, if you don't let it burn through, the catheter can actually slide off to the side. And you think you're seeing the catheter inside the duct, but it's actually slid off to the side, and you're seeing it a little bit not clearly. So if you don't see the catheter clearly, you have to ask yourself if there's maybe a problem with your position, and don't deploy in that situation. Since we don't have any fluoroscopy, and I don't like putting in wires, once I've deployed, I keep the catheter inside the duct, and I try to turn back and get a picture of the entire stent, picture with the biliary stents because they're small, one with the stent inside the wall and one with the outside, to make sure everything is in place before I pull out the catheter. It's really important to keep that catheter in place because it gives you access In case there's a problem, then you can put in a wire. But before you pull it out, try to make sure that everything is in place so you keep access. So again, in bile ducts less than 15 millimeters, or in situations where you're pushing in the catheter, and then you start sometimes seeing the internal bile duct wall separating from the duodenal wall, that's where I'll switch to a forward deploy. I don't know if you guys have tried this, but you can pull back the catheter from the wall, unlock both locks, and then we use kind of an F&A technique where you brace the gray catheter, which is the sheath, and then you push in with your finger to push the stent out of the end of the system, instead of having to put in this catheter all the way and pull it back. So this is really good in small ducts. You can go very slowly. I urge you to practice this on pseudocysts with the biggest stents, because those are the hardest ones to move. If you can do that with the big stent, then you'll have no problem with the biliary stents, which are much smaller. You can also, when the biggest resistance is when you're first starting, there's a seal between the cap and the catheter system, which needs to be broken. So if you have a small system, you can go in without pushing on the back of the wall, just start with the standard technique to break the seal, then pull the catheter back from the wall and start doing the forward deploy. And as I say, it works very well. And Boston is actually coming out with a forward deploy system where the actual, it will not do the original way where you push in the catheter and pull back. It'll actually be a forward deploy click, then you pull back and finish the other way. And I think this will actually become the standard way to do it. When you think about it, it makes more sense to just put in the catheter as little as needed and push out the stent, and having to push it in, instead of having to push it in very deep and then deploy. As I said, I already told you, try to really monitor that the internal flange is not migrating while you're deploying the other flange, just to make sure that everything stays place. And also, if you do have a situation where you, for some reason, it starts internally migrating, it's always good to have a biopsy forceps just not too far away. I've had one case where you could see, for whatever reason, it was open, but it was kind of not fully deployed inside the stomach. And if you have a biopsy forceps close by, you can have time to grab it and just pull it back into place. It's not the time to be asking, in our EUS room, it's not a place where we have a lot of biopsy forceps, looking around for a forceps. So just keep that in mind. And that's it. And if you have any questions, I'm happy to answer. Thank you for your attention.
Perfect timing. We are at the top of the hour, but we have a couple minutes. If anybody from the audience have any question. Great. Well, thank you so much, Anand. Thank you for the panel for sharing the expertise. And now we move on to another set of exciting live cases. Please stay tuned.
Thank you, Paolo. I think we're ready in the room 5 for.
Good afternoon. Can you hear us from the audience? I think so. So we are ready to present the first case of the afternoon. The first case is in room 5. So go ahead.
The patient is a 30-year-old female that in January 2024, for epigastric pain radiating to the back, She underwent abdominal US that revealed a lesion in the pancreatic tube. She underwent an abdominal MRI that showed a partially apparent lesion on T276, no restriction on DWO. The differential diagnosis might be small atypical cystic lesion versus intrapancreatic lymphoma. Tumor markers are negative. Today's procedures, US plus FNA with rapid on-site evaluation, operators, Dr. Petrone and Dr. Tasciani.
Hello, Mara.
Hello, good
Hello,
afternoon.
can you hear us?
Yes,
Good
perfectly.
afternoon.
Yeah.
So, just a very, very quick view of your case, the vision, and then
Sure.
we will move you to the US Express channel. So, if somebody wants to follow you, can click on the Express channel to see your case.
Okay, thank you. So we are with the scope in the stomach now and follow the portal vein and the confluence here. This is the body of the pancreas. This is a young lady, so I try to follow the pancreatic duct and the splenic vessels until the tail. And we can see here the lesion in the very distal part of the tail of the pancreas. That is quite similar if we speak about the ecostructure to the spleen. However, the shape is not usual for an accessory spleen. It's not a round shape. There is some irregular portion here, and also some anechoic structure inside. Probably a small vessel. I'm not sure. With the briefing of the patient, of course, it's not so easy. However, we have to decide and to differentiate
So,
if it's a splenic.
Thank you, Mara. So, if anybody wants to follow this interesting case of differential diagnosis, can follow on the US Express channel. So now we move to present the case in room number 7.
Next patient is a 60 years old female. In 2019, she underwent a surgical laparoscopic cyst restoration, and during the US follow-up, she found a lesion in the pancreatic head. She underwent an abdominal CT, which confirmed the presence of a 30 millimeter lesion with upstream dilation of the pancreatic duct, and also surrounding the portal vein. She was planned for an outpatient US, but 2 days ago she presented in the ER with jaundice. We will perform US with FNA and the rapid on-site evaluation, and then ERCP. Operators are Professor Larigno and Professor Di Matteo.
Hello, guys.
Hi. Good
Welcome.
afternoon.
Good afternoon. So you have a very challenged case.
Of course. I know that we don't have much time, but I would like to thank and to congratulate all San Rafael team for your hard work in here. Not only you, Mara, but also Livia, Matteo, and Giuseppe, and also all the people who are working here in this room, the anesthesiologist Gabriele, that I don't know where is he. As always, anesthesiology is always lost. And all the rest of the assistants, and especially my colleague, that it's a great honor for me to be with him, sharing a procedure that is Francesco Di Matteo. Okay. So now just going to the point, I would like to show you the case. This is a tragedy because it's a young female with a pancreatic mass that corresponds to a pancreatic adenocarcinoma according to the CT scan. And we are going to check that this is a pancreatic adenocarcinoma. And we are going to check some important things about the possibility of having a resection or not. And I have to mention, I have to start the procedure with this. This is the portal vein in the liver. And when I'm following all the portal vein, now I'm looking at something that is not so common, that is finding that the CVD is more dilated than the portal vein. You look here, 2 pictures, 2 ducts. One is the CVD that is below, and the other one is the portal vein. But the interesting point is that not only the dilation of the portal vein, but also that the portal vein, if we follow here, and we are following the portal vein, you look, the mass that is completely, the portal vein is completely inside this mass. So the involvement of the portal vein is complete. And another important point, so this reflects the unresectability in my center, at least in Spain, in my center is not resectable. But more important is what about a thing that we assessed here. You look at two ducts, two vessels. Below you have the mesenteric superior artery. The mesenteric superior artery, thank you, is not involved by the tumor, not by millimeters, but it's not involved by the tumor. But if we look at the celiac axis, the celiac axis is free. But when we follow the celiac axis, we can see how the hepatic artery is entering inside the lesion. So we have an infiltration or a clear invasion of the hepatic artery and the gastroduodenal artery inside the lesion. And this reflects the unresecability of the lesion. So going to the point, the objective of this procedure are two, because the patient is with jaundice. So we need material, we need to get histological or cytological material in order to provide the patient for a not neoadjuvant, but chemotherapy perhaps treatment. And finally, we should palliate the jaundice for receiving the chemotherapy and for alleviating the symptoms of the patient. And so that's the point. This is the picture that we obtained with this lesion with signs in the rest of chronic obstructive pancreatitis. This is the PD in the proximal to the lesion. So following that we document before. Okay, and so we have here another important point before getting the material that in 2 minutes we are going to make a puncture. It's important to see where is the CBD. And you look here. This is the dilation of the CBD. And this is important because we are going to perform after this procedure an ERCP, of course, a first attempt of ERCP. But if we fail, we have to try to search for alternatives for the biliary drainage. And the coledochoduodonostomy perhaps is an alternative. I have to recognize that this position of the CBD that is dilated perhaps is too up. I mean, too in the hilum. So if this patient would be resectable, it's not perhaps a good option performing a coledochoduodonostomy here. And so the next point is perhaps we could choose doing a gallbladder drainage, going to the gallbladder. But for that, we should assess the cystic pattern that it seems to be free, but I'm not so clear, but it seems to be free according to the CT scan and the US. And so perhaps the gallbladder, if I identify, is here.
We can see gallbladder is also a possible target in order to do so we have I don't want equipment that we are using the potential really equipment and attached to the device that is 50. And now we are going to do something
So Jose, so while we wait for the time, we can so I'll start with wrapping up the section and information. We want to you thank you. And we move to the more
The easiest procedure is done. So now is the difficult one.
Tagliamo la sala.
I need aspiration, so now,
Ci siamo?
we will come closer, please. Okay, now we will assess the material for Vivascope.
La sala del
Okay.
pathology.
So the content of the needle is directly put on the special matrix, the cytomatrix.
Non vedo I pathology.
And
We don't have any
afterwards
image
we'll show
from
you
the pathology.
the
Okay, now
staining
it's
procedure.
Okay, go ahead.
So the matrix is retaining the sample material,
Bisogna
which can then be
far
used
vedere
afterwards
meglio
for the final
cosa stanno facendo.
histomorphological analysis.
Gennaro,
or
bisogna
also
far vedere meglio le
immunohistochemistry and
mani,
more complex tests.
le mani di
So
quello
you've
che
seen
sta
this
lavorando.
coming out. Okay, so if you can hold the microphone for
So,
me like
noi
this.
siamo già, li
Okay,
vedo.
so we start with the processing. So there's no cutting or smearing process. First step is a little bit ethanol, 70%. Then we use acrid orange, which is a very, very small dye that diffuse very fast throughout also intact membranes and stains the DNA. So that's why we will see nice nuclear details. About 20 seconds. And then we repeat the staining a second time to have a more homogeneous signal. So again, 70% ethanol. And then again, acrid orange. So all these steps that I'm doing now have been shown to do not influence the analysis that have to be done afterwards. So, and even, for example, immunohistochemistry or molecular analysis. So then the last step is always a saline solution to remove the excess dye. And then we are ready to mount this sample. So as you see, I'm not touching the sample, I'm not smearing it. So I move the matrix into this special glass slides with magnets. And this is what we call the sandwich technique. So we now close this and we collect this. And as you see now, it's mounted between the two glasses. So now we move up here and we put I remove my, so and we put our sample into the Vivascope. And what you see on the right-hand side is a macroscopic view of the sample. Now I close it. I say take picture. And now in a few seconds, you will see the confocal image of the macro image that you see on the. So you can see we already see details. We choose then the optical plane where we want to acquire, and then we simply run the acquisition. So where we can acquire the entire set of matrix, but here is clear where the tissue is. Yes. So so we start the acquisition. So now you will see that an image is mosaic. It's being formed, and this is like many field of views which are put together to scan the entire tissue set. So and it will be done soon, and then the pathologists here they can zoom in. Of course, this can also be done in a remote way. Then please.
So now we can zoom in. We can appreciate nerve in here. Okay, these are normal glands, and here we have something which is more interesting in terms of adequacy, because these are neoplastic glands with this very hyperchromatic nuclei, some nucleoli here. Here there is a necrotic debris. This is a so-called cell-in-cell aspect, which is always suggestive for neoplastic malignant proliferation. So as you can appreciate, it looks like a biopsy. So it's not really a cytological picture, but it's already something that looks histological. And then here there is another normal glandular structures in here. So we have the bull aspects inside the biopsy. Here we have a vessel, and so it's a bidimensional picture, but it looks like a 3D, like an histology, and it's diagnostic for adenocarcinoma. So now we can move to see if there is anything more for the smear. We have another picture in here.
Thank you very much for Federica. So adequate statement for adenocarcinoma. So now we move very quickly to room number 5. Mara? Yes. Can you hear us? Yes, yes, I can. So you have seen we have had a look by the express channel that you have biopsy the lesion because why?
Because we performed the contrast with some of you, and the behavior of the contrast was different between the lesion and the spleen. We compared the behavior of the contrast also was different in the washout. So I decided to perform the biopsy also because she's a young lady. The lesion is 1.5 centimeters. There are some anechoic small areas in the lesion. So I performed the first passage just now.
What do you suspect now for this lesion? Neuroendocrine tumor?
Yeah, this is our first suspicion. Yes.
Okay, so we can follow on the Express channel the results of your biopsy. So now we move to our next center outside Italy to be connected. And it is my pleasure to say hello and welcome to Professor Schalk van der Merwe from Leuven University. Hello, Schalk, can you hear me?
Hello, Paolo. Yes, we can hear you.
Everything okay? Welcome to EUROEUS. It's a pleasure having you here again.
Thank you. Thank you so much, Paolo, for the invitation as well.
Yeah.
I'll ask my colleague, Professor van Marlenstein, to introduce everyone.
Yeah, welcome to
to Leuven. I'm Professor Van Malenstein. Schout van der Merwe is next to me, and Dr. Michiel Bronswijk is also here behind the scenes. And we have our nurses, Nick and Eva, with us, and our fellow Marianne Norali, who will present our case. So, Marianne, you can go ahead.
All right, thank you. So this case is a 71-year-old female who had a previous Mason's gastroplasty and afterwards a conversion to a gastric bypass. Because of macroscopic hematuria, she underwent an abdominal biopsy, which showed accidentally the presence of a duodenal polyp. Yeah.
So we are going to show you the EUROEUS2024, which has a typical sequence of first identification of the solid, then inserts a saline anti-bulge needle, then insert a mass set, fix it, and afterwards we dilate and one step.
Va? Uno, ok. Abbiamo.
Europe. And now we can introduce the tip of the 19-gauge needle into the stomach. I'm using a standard Cook 19-gauge needle. We're using a Pentax linear echo endoscope and the Arietta 850 processor.
When we were waiting for the result of the first pass, can you tell us something about it? Still don't have the result of the first pass. I think we are finished. About yeah, say maybe let's have a tour in the pathology room. Yeah.
L'adeguato, adesso stiamo facendo un altro.
Perfetto.
So that we can fold the stomach maximally, and then we'll take out the needle, reposition. Nick, I think you can inject a little bit more.
Yeah, exactly. I think usually we use this for ERCP, of course, and we have to pass with the duodenoscope. It's a very safe procedure. It has a high technical and clinical
We'll collect together the result from the room 5 of the suspected mass of the tail of the pancreas. So, Professor, please tell us.
So the first step passage was adequate for an endocrine tumor. Now we are preparing again another private endoscope sample, and what is to be routinely examined with hematoxylinases, so we will make the comparison between the endoscope and the smear. Also, because
Can you please, let us see.
so we will prepare with acridine and fosgreen, then to have a cell block, because for neuroendocrine we need to assess K67 for prognostic purposes. So it's fundamental to have this cell block.
Also see you later.
Which may complicate matters a bit. We have enough room to place the axios. That's not an issue. But in this position, it may still be difficult even to pass a gastroscope through the antrum. So we're going to place the axios. So in preparation, I'm going to check for vessels in the wall. The gastric lumen is adequately distended.
And we will use, of course, a 20 millimeter lumen opposing metal stent.
So I think that is very important to use a 20 millimeter, especially if you're going to use this procedure for single session edge. I think if we are going to compete with procedures such as laparoscopic assisted ERCP, I think it's going to be important that we have a procedure that we can perform in one session safely.
I'm sorry, Professor Van der Merwe, here Cecilia Binda from the audience. May I have you make a question? Do you think that even the length of the saddle of the lamps can be an issue in this procedure? Because on the market there are available actually other hot lamps with a saddle that it's longer than the hot Axios one. Do you have an experience using that kind of lamps with a longer saddle?
I am a bit concerned if there's a need to use a longer saddle, then there's normally an issue. So can we just check? So I think that your apposition to the gastric wall must be so good that you should not need a longer saddle. And I'm concerned if you do need, it means that your apposition is not good, or that there may be some interfering tissue, and that would be concerning to me. So I'm not. I think that 10 millimeters should be okay in most instances. So I think we're now ready to go.
Wait a second for the. Yeah. So we use the hot axial setting, which is a pure cut setting, just to avoid the tenting phenomenon.
Scalca and Paolo, sorry, you are absolutely safe. May I ask a question? There are some concern about the position of the lamps when you put the lamps. Somebody said that it's better to put in the body and
not too close to the pylon. What's your feeling on that? That's absolutely right, Paul. Such that we want to be as close as possible. We want to turn over away from the placing it naturally. In this case, because of the previous gastric surgery, it's not possible. Unfortunately, in this case, we are not going to use a very light
that the guide is on the biliary tree. But if the nurse doesn't move the guide wire in a proper manner, doesn't help us to understand if it's a biliary tree or not. We have to use contrast medium. So that's why we ask it to move the guide wire. So this is biliary tree, not that contrast. The guide wire helps the operator to depict the structure. It means wisdom duct and common bile duct. But if your movements are too short, it doesn't help. That's not. Completely full of content.
choose the type of stem that you want to filter?
Are you using a therapeutic isotope to is the to fix the stem? The character power can use a static vessel structure. And the static vessel structure is efficient. Because the automatic automatics is having first to dilates to it's dilates first and to clip. Not to first clip and then dilate. Obviously, you want to clip the second position in the most ideal setting. Yeah. So that's although we talked about we have a bunch of experience and
Definitely a method.
Has already been said. Target is the king of the room. So, Alberto, which kind of stem can we use now? What do you prefer, the partially covered or uncovered? Partially covered. And the idea is to use partially covered. Confirmation of malignancy, let's avoid migration. So we are lucky to have the rapid onset evaluation now, so we also have we could take partial coverage. Then or I don't control the distance here, so I presume 6 centimeters. Yeah. Maybe we can use a dilation of balloon just to dilate the stenosis and have also a caliber of the because balloon is the balloon is 4 centimeters, so we can have a light or we are half. No light now. That's a question for the audience.
Una cuestión, yo era afraid in facing
Inflate the balloon. So I think it's the question. It is not set in stone. I think you want to inject enough fluid so that you can. Yeah, that's perfect, Nick. Thank you. You can inflate again. It is not set in stone. We want to be sure that we have.
So we have
can you just deflate again, Nick? I'm not getting a good.
Yeah, usually you see that the stomach, we always start with some contrast. So on the fluoroscopy, you can already see that the stomach is filling. And also during your EUS procedure, you already see that the stomach is nicely filling. And so the exact amount is usually not really set, but in our experience, it's a bit less compared to what we inject for gastroenterostomy, because there the fluid leaks away more easily. Usually in the stomach, it nicely fills.
I would say, Hannah, it would be fair to say about 250 to 500 milliliters of sodium chloride would be absolutely perfect in most instances. Okay, you can go to 30
Do you use any Buscopan or glucagon for this procedure?
No, we only tend to lower the head of the patient.
It's very unrelated, and also to have the length, because we are not sure what is the length whether to use a 6 centimeter or 8 centimeter. So we are going to place a balloon which is long 4 centimeter. So we dilate the structure, we straighten the position, and we measure the length.
Otherwise, I'm good at speaking. Okay, we can focus on how we get into this. Not had or retrofabrial lesion. This was kind of uncinate lesion, so you could see how short was the stenosis. I mean, the lesion was grasping the bile duct and with a very undulated course. So, we had the doubt whether we were in the pancreas or in the bile duct. In the beginning, some small amount of pancreas was going upstairs, so we were advanced and it was at the end. So, shut device into position, already the 11 and 4 o'clock position that we will demonstrate now. It's very similar as what you would do in the setting of a position. So, as you could do for banking, the type of problem, making sure that we can
deploy it. So now we can go back to the endoscopic image. It's of course very important to very gently insert this, as it can cause damage. You have to be careful when you pass underneath the vocal cords. So we're now back into the pouch. There one can see our stent, and now it's going to be important to choose the right place where we want to adhere, and maybe that is a good position. Anna, what do you think?
Exactly, because of course finally we will extract the stent as well as the clip, and to extract it is just you just have to pull really nicely in a nice position, and we aspirate and place the clip.
Okay, so now we're going to suck some tissue. The stent fix is now in position.
And we will then come back, remove the cap, and then we will proceed to pass the gastroscope.
So let's see how we enter the stomach and if we can pass the pylorus easily. So with the upper endoscope, it's quite easy. Maybe, Salek, you can also show fluoroscopy just to see the position of the stent as well.
So I think in using the gastroscope, it should be no problem. We can directly pass through the pylorus, and we'll inspect this area where the polyp was seen on the CT scan. Just going to inspect a little bit further.
I think that's the Davex vulva.
So I think that we may have already seen it in the bulb, but I just want to be sure that there's nothing more distally. And I think there is the polypoid lesion. Very likely. Yeah, I think it's going to require us to really be very careful in removing it. But there seems to be a polypoid structure there, if you agree with me. That seems to be matted. We will have to go about doing this very carefully.
Scott?
But I think this is what we wanted to show, being able to perform a gastrogastrostomy safely, being able to gain access to the extruded stomach that allows one to perform therapeutic procedures. In this case, it will be removal of the polyp, but I think this is what we have to show for now.
Yeah.
Paolo.
Scott, thank you very much. Thank you very much. It was a fantastic procedure. I think that we will see you in a while for the next case. So by now, thank you very much and see you very soon. Thank you, Scott. Thank you, the team. So now we start.
Just one small connection with group number 7, which I think is Dr. Lavinia, Professor Di Matteo, at which point they are in their procedure. Jose, can you hear me? Yes. Okay. I've seen that you have been able to pass the guideline and pass the stricture. So, how you? By faith. Okay. I can push sure about procedure. Second, Francesco, interpretation. I don't know if you can look at the picture. So, we have it. You have 1 minute to put the step. Yes. That's the 31 minutes. But look at the picture, please, the first picture. Because it's a lot of calculation of the CVE. Now, you push sure about the
position. No, this is not the picture. And it was very difficult.
Larger?
Yes, it's a little bit long. We are going to use a 6 centimeters. I'm not sure about the length. We measure with a balloon, with a dilator balloon. I believe that 6 centimeters of length is enough. But the problem was the angulation. You look now at the picture. Yeah. It's completely angulated, and we thought that we were even in the pancreatic duct.
Yeah, we have seen everything with the US Express channel. So we followed you by the US Express channel.
Okay.
So go ahead.
Okay, so we're going to deliver the step. Okay. So I have to say that this procedure was performed with Pentax equipment again, the fluoroscope of Pentax. I'm using an of company. Okay. And then we did a enterotomy and a dilation. Enterotomy to take the position, to save a good position. We have to recalculate. And finally, we're going to deliver a stent. We were discussing about the type of the stent that we're going to use. Finally, we decided for a partial cover, that's the normal stent that we normally use in our center in a resectable patient. Partial cover of 10 millimeters of diameters of size and 6 centimeters of length. I guess, or I hope that it's going to be enough. Okay, so now we are introducing the stent, and now we are going to see by scope. Okay, let's see. We are able to reach. Yes. Yes, because the stent is, wait a minute. Yes, it's enough. 6 centimeters is enough. It's much than enough. More than enough. Because we have a lot of stent. And finally, okay, this is the end of the stent. So we are going to remove a little bit. Okay, now it's a good position for deliver the stent. So now please start with the.
I don't know if we can have the X-ray image larger.
Adesso mettiamo l'immagine da tua parte. Dai.
Sigue. Okay. We are delivering the stent. Have to remove a little bit more. Okay.
Now, stent is delivered. Endoscopic image. Endoscopic image. Endoscopic picture, please. So now we're going to remove first let me see just a minute. Very adjust at the ampulla, but I think it's all right. Let me remove the guide wire first. And let me.
Okay, I believe it's all right. Let
Okay.
me move this. Okay,
Thank you
now.
very much, Jose. Thank you very much, Francesco.
Thank you. I'm sorry for the US drainage because
You-
it's not possible to do it.
Don't worry. Don't worry. It was fantastic. Thank you very much. We go ahead and present the next case in room number 6.
Next case is a 31-year-old man. He had in September 2022 an intensive care unit admission due to idiopathic acute pancreatitis complicated by multi-organ failure. He underwent abdominal CT and MRI scan, which showed a large retrogastric necrohemorrhagic collection and also lithiasis gallbladder. A further CT scan showed the evolution in the womb, compressing the splenic vein, appearance of collateral circles and gastric varices. This is the CT scan. Today's procedures is the US guided fluid collection drainage. Operators are Professor Canusi and Professor Shai.
Hello, hello. Can you hear me?
Hi,
Professor
Paolo.
Canusi, Professor
Who's
Shahal.
Hi,
We have
can you hear us?
yes, we can hear you perfectly.
Pabline is here next to me. Livia is here and all the
You
team.
are perfect.
Livia is here and she's great. She's helping us set up.
Yeah. So you can start your procedure.
Okay, so you
Thank
have
you.
listened to the story. You have seen probably the pictures from MRI and CT. The last one is CT. We have already performed the full EUS evaluation before we transmit. So we have been through the liver. There is no dilation. There is no CBD stone, and there is a lot of gallbladder stones. So maybe it is probably a biliary pancreatitis. That's we have probably discussed before. And we see this fluid collection, as you can see. It's big. We have measured it before. It's almost 10 centimeters on 8 centimeters. And I need your feedback also. What do you think of the content? I'm just showing you the whole range of the collection. Can you hear me?
Yeah.
The panel?
We can.
What do you think?
We can hear you perfectly.
Can you see well the EUS image?
Yeah.
Okay.
Yes,
Very
we
well.
can
So
nicely hear even from the audience.
we have, I'm showing you the whole range of this collection very slowly, so you can see how big it is, and second, what's the content. And we have agreed that it's more than 50% solid necrotic debris. The patient has no signs of infection right now. He has signs of compression and vessel compression, and we have noticed a lot of collateral circulation and some varices in the mucosal layer and the submucosal layer of the stomach. So we have discussed extensively with Pavlin before. Which procedure will you use? Is it indicated to drain this collection right now? We are at 5 months from the acute pancreatitis. It's compressive, so the indication is definitely yes, it's a 1. And which procedure would you select? What do you think? Will you go for a plastic stent, double pigtail plastic stent, or will you go for lumps?
We can do a quick check in the audience
please.
here. Who would go to LAMS directly? Raise your hand. So I think it would be quite unuseful to ask the second, because most of the audience would go directly to a LAM positioning here.
Yeah, it seems that it's the right choice. It has been there have been a lot of publications comparing both procedures, which is most effective, which is most safe. And in this situation, with the vision we have and the contents of the cyst, even the liquid is very, very thick. So we expect a double pigtail, 2 double pigtail would not do the job right. And the patient will have probably to go back and forth a lot of times. And we will definitely need necrorectomy at some point. And that's why we also agreed that lumps seems to be the right choice. So the distance between the cyst and the wall is 5 millimeters. We have just measured it. And as you can see with Doppler, that's the safety and checklist measures that we are doing. The distance with the cyst, wall and cyst, less than 1 centimeter.
no interposition of any digestive structure or any vessels. We have some vessels there up the right part, but if I push just a little bit, I have no interposition. And the fluoroscopy situation is pretty good. The endoscope is straight. We will adjust the image. And from cardia point of view and distance from cardia, we are right down the cardia, so we are safe in this area. I'm just putting some air just to show you, maybe endoscopically also. We are in the stomach, a bit far from the cardia is here. So it's better to be a little bit down the cardia, not very close, of course. The cardia is here, it's 45, and the situation we have, the bed situation around 45, 50, 55 centimeters. So we are safe in this area. And the position of the endoscope is straight, no interposition, no vessels. So what kind of stent would you choose? The panel, can you check with the audience? What's the preference?
Yeah, so who would place a stent which would be less than 15 millimeters?
That's the question.
So
would it be 10 or 15?
Nobody? 15 or 20, 15? So new 15 millimeter, 20 millimeters?
Sold to 20 millimeters.
Okay.
Who offers more? More than 20, no?
More than 20?
No,
Okay.
nobody is offering more than 20.
Okay. I think that
20 is the final offer.
If you think that 15 is good, we think here with Bradley, yeah.
So I mean, I think if you look at the picture, he is shown to be a little bit better,
Very
especially with extensive necrosis. You may not have to remove the lamps in a subsequent necrosectomy sessions. For 15, sometimes we have to take the lamps out if we want to do a bigger chunks of necrosectomy. So I would agree with the majority. 20 is preferable in this situation.
Okay.
So there's a question from the audience, if you don't mind.
There is a question from me.
Yes.
I'm just provocative. Why do you think to perform necrosectomy? The patient is not has no sepsis, is not no fever.
Yes, for now there is no indication to perform necrosectomy immediately.
So
we are just expecting maybe in the future. So maybe choosing the right stent from now seems to be a good choice. But anyway, once the stent is placed, if there is no need to do necrosectomy in the next 4 weeks, we will remove the stent, and if needed, we can go back without the stent and do the necrosectomy afterwards. But for now, I agree with you. There is no need and no indication to perform necrosectomy immediately. But we are just anticipating, just in case, once we are manipulating and getting into the cyst, maybe there is also a possibility to have an infection afterwards. So we are ready to prepare the patient for all and envisage all the scenarios.
Actually, there's a question from the audience asking if the compression of the vessels always requires a drainage. So do you always perform a drainage when you have vessel compression?
That's a very good question. And I think one of the most severe complications we can have in this situation is to have a very big circulation, collateral circulation, and having the splenic vein, impaired flow of the splenic vein, and having a lot of collaterals can be a very serious complication for the patients. And yes, I think that compression is an indication to perform a drainage. What do you think?
So I'm going to give you a conflicting viewpoint.
Okay.
We generally don't at our center. Vascular compression is not an indication for if a patient is completely asymptomatic, because we don't know if it's going to change the course of the disease, right? If there's already a vascular compression, patient already has collateralization at this point, are we going to change the course of the disease at this point? So I think that point is debatable. And for that reason, we don't intervene just for that indication.
Well, now that we have the collection, the content, and how big it is? Do you expect it to
It's not going to get better on
resolve?
its own.
It's not going to get better anyway. And the level of collateral circulation for now is not so bad. It's going to get worse, for sure. So I would maybe be in favor of really draining this collection.
15 or 20 millimeters.
But yes, you wouldn't have in this situation at all. You would have just follow up.
We don't. We follow. Yes.
Okay, so we have a conflicting opinion here. We need your help.
No, we'll drain this.
No, we need your help. What do you think in smaller audience?
So, who would proceed to the drainage in case of compression of the vessel, regardless the history of or other symptoms, and who would not? So, who would drain this wall off in these cases? So few, and who would not and would just follow the patient? So probably half and half, but very few raise hands.
A lot of people didn't raise their hand.
Yes,
Okay.
There's a lot of uncertainty.
Okay, so
I
the patient.
doubt this patient is really asymptomatic with such a large collection being in his abdomen for 5 months.
Yeah, it's more than 5 months now, and it's not going to resolve. And I think it is wise also to drain at this point before any complication further. Okay, so we'll go with the 20 we have. Even if I think it's a bit large, but if we have done it any future necrosectomy, yeah.
So, question for the audience and panel. If you're not doing necrosectomy at the index procedure, could you dilate the stent, number one? Number two, would you put a coaxial pigtail stent through it? When would you bring the patient back for necrosectomy? Because this is extensive necrosis.
Very good question.
So more than one question.
Very good questions, probably.
Who is answer? You, Prof.
So the first question was, shall we just insert the stent and see how the patient does, or should we go for necrosectomy today? So who will just place the stent and do nothing else today? Okay, who would do a necrosectomy today? Okay, so we have an absolute majority voting for just inserting the lens today.
I probably would have. I would lead to dilation without necrosectomy, because sometimes it's useful to see what's in the content of the collection. I would not proceed for necrosectomy, but probably I would have the doubt of making a dilation. And if the patient could be discharged, probably I would have the doubt to put a double pigtail coaxial if the patient is discharged, or if has the indication to stay. Probably would not.
Professor Canussi? Professor Canussi?
You prefer to be safe.
Can you hear me?
Yes.
Yeah, you have just 1 minute more to deploy the
Okay, that's a lot of
Thank
pressure.
you.
Okay.
A lot of talking and
Not so much
truth
action.
is
I
gone.
understand. I understand. Okay. Okay, so
yeah. Use your elevator a little bit. Bring it in the middle. Good.
looks fine.
Yeah.
Okay, stable position, no interposition.
Yeah.
Just maybe bend a little bit.
That's what
Dips. Okay. Oh wait, can block. Okay.
Yep.
Okay. Next step.
Yeah. You have right in front of you, yellow.
It's the yellow. Going in.
Use your elevator a little bit more.
Yeah,
So
it's
it doesn't
maximum.
slide. Yeah. Doppler off. All right. Keep going.
In.
Yeah. Push
Yep.
more. Push more. Keep going. Keep going.
Okay.
There you go.
Perfect.
There you go.
So now we can start unlocking.
Okay.
Yes, please. Yes, please.
What, 15 or 20?
Okay, this is a 20.
20.
Okay,
Good.
okay. A little bit more. Okay,
No, no.
perfect. We lock.
Perfect.
Okay.
Lock.
Yes.
There you go.
Okay, perfect.
Yeah, go. Good. Excellent. Good.
Okay, we have a full deployment.
Yeah.
Now we can unlock again, pull back.
A little bit more.
That seems enough. Okay.
A little bit more. There you go. A little bit more.
There you go. There we go.
It's okay.
Perfect. Unlock again. Okay. Yeah. Can we move to the endoscopic view?
It's okay. Deploy it. Deploy it. Yeah. Open it. Go, go, go. Don't worry about the endoscope. Yeah, let's go.
Yeah.
I wouldn't worry about that. Don't worry about
Okay.
the endoscopic
Okay.
wrapper. Deploy it and then you push it out. There you go. Yeah, good. Okay. Unlock.
Okay.
Push it down. There you go. You got it. Perfect. Push it, push it, push it.
Maximum.
Pull back up.
Pull back.
Not the endoscope.
Yeah.
There you go.
There we go.
Yep. Good. Good.
Okay.
Yeah, you got it.
Thank you very much. Excellent procedure.
Okay.
Very nice discussion.
Hold on. Take this out.
Thank you very much to this
Okay.
to our women endoscopy team,
Now we can see.
and
Oh,
the fluid is
see the
coming
fluid.
out. Thank you very much. So we can go and present the next case in room number 5.
Okay, so the next case in room number 5 is a 68-year-old woman. The patient was admitted to emergency department in January 2024 for abdominal pain and fever. She underwent an abdominal US and a CT scan showing a lesion at the pancreas body of 24 per 28 millimeter in size. An abdominal MRI confirmed the pancreatic solid lesion with no contact with the superior mesenteric vein. The tumor markers showing an increase in CA 19.9 and a CEA of 2.5. Here we can see the lesion in CT scan and today's procedures. US plus fine needle aspiration with rapid on-site evaluation. The operators, Professor Seichian and Professor Palazzo.
Hello, Andrade. Hello, Laurent. Can you hear us?
Good afternoon.
Thank
Yes,
you
we can
for
hear you.
thank you for the patience, and go ahead with your case.
Thank you, Paolo. This is a very nice case. I'm very happy here to have Professor Palazzo near me and all your team, Matteo. It's a wonderful event. So here you can see at the level of the neck of the pancreas, there is this hypoechogenic lesion. So it measures about 2.5 centimeters. And we see it that it's very inhomogeneous. And if we rotate a bit clockwise, and as you can see here, that we are very close to the vessels, the mesenteric vein, and to the portal vein, as Professor Palazzo show you here. Can you explain us a bit? It's very nice. It's power Doppler device used here. You can see the vessels inside and around. Up there, there is the gastroduodenal artery, and the SMV is beyond the lesion. And the FMA also is situated over there, but this is not involved. And if we switch to other Doppler possibility, you can see this is the, you see the velocity that you use here is about 19 centimeters per second, because we want to avoid allying And you can see here very nicely how the lesion touches with the SMV. And Professor Palazzo measured it before, and it was about the 1 centimeter distance involvement of the SMV.
Now we move to the food. It's blue and green.
So it's what we expected here.
Yeah, we're expecting blue and green. It's blue and green. Now we use not elasto, DFI. It's black.
If we go for dual, perhaps we can see better. Yes, it's black. Is what we expect in adenocarcinomas. In fact,
Carcinoma, no vessel, and you see the of the mesenteric vein. You see the compression of the mesenteric vein.
It's pushed a bit over there,
which is very well seen using DFI. You see that? Okay.
Yes.
And we will do contrast.
Yes.
So DFI, we stop it. Where is DFI? Yeah, it's here. Okay, so now we move to contrast. CHI is here. No.
Please prepare contrast.
No, it's not that. Sorry. No, it's not that. It's here. Okay, so so here we have the lesion.
We use here the mechanical index of 0.21,
which is intermediate. So you can inject, and we push on the counter. Yeah. Finished?
Sorry, again.
Okay. Yeah.
So you can see the micro bubbles coming into the vessels. It's the arterial time.
And, like with DFI, there is no vessel at all in the lesion, which is likely necrotic and or fibrotic, or both.
And here we can see very nicely the SMV, which is again pushed. So it touches a bit the SMV. Yeah. So this is what we have discussed as an indication for neoadjuvant therapy in this case.
Yes. Near 3 centimeter, resectable, of course, but with poor prognosis after surgery alone. Neoadjuvant. So exactly. We have done a first biopsy. We will do a second one. We are using a sharp core needle.
Can I have the needle, please?
So do you think that this marked hypo enhancement is informative about the technique of sampling that you should adopt?
Yes, theoretically, this kind of lesion, we use aspiration. And we avoid to do slow pull. Slow pull has interest in small lesion, in vascular lesion, and aspiration is more interesting in big lesion without enhancement. So yes, I will say DFI and contrast help to choose the way to puncture. The important point, in my opinion, is to adjust the way to puncture and the needle to the lesion. All the lesions are not the same. And of course, if you do always the same way, always the same needle, you will have good results. But your good result will never be more than 80% sensitivity. And 80% sensitivity in 2024 is totally suboptimal. We have to imagine that 30% of adenocarcinoma of the pancreas are emergency. They go very quick, and you don't know which kind of tumor you have in front of you. Some tumor, even you have 1 month delay, change nothing.
but 30% of them change everything. And so to obtain the proof and to start neoadjuvant immediately is very interesting for 30% of your cancer. So you have to try to be
push it out and
yes, we will put you have to try to be effective at the first attempt, not 15 days later. Okay, so it's the reason why if you can do all this kind of thing, elastography, DFI, contrast, use the way to puncture with aspiration or no suction or only slow pull. You have to use all these possibilities, but you have to adjust them to the type of lesion you have, the size, and what you suspect. Adenocarcinoma, and the fact that the DFI and the contrast show nothing means that you have to aspirate. You have to use the suction.
okay, so here we are. We talked a bit inside the lesion because it was quite difficult when we entered. We put some suction, 20 cc's, and now we are going out and we will check for the accuracy, adequacy of the sample.
Because we already have done one.
Thank you.
In case when you have the suspicion of a largely a necrotic lesion, do you perform directly a contrast enhanced US guided biopsy, or you reserve this strategy when after an inadequacy of the first sample?
No. If you have finally the goal that I want to, my take-home message on puncture is that you don't know which kind of lesion you have. You try to have 100% accuracy on your lesion. So if you have contrast in your unit, you did at the first time, and you discover if it's a standard case or not a standard case. And if you see, for example, no contrast at all, and a part of the lesion which is echogenic, it means that it's necrosis. If it's avascular, no vessels, but the lesion is hypoechogenic with attenuation of the beam, it's fibrotic. Fibrotic and necrosis is not the same thing. Fibrotic, you can go through the lesion in the centrum and fanning. Necrotic, you have to go on the edge of the lesion because the only part of the lesion which is still yes, it's the edge. So using the contrast and the B mode, the combination of them, you know if it's necrotic or if it's fibrotic. And when you have vessel inside, you have enhancement at the beginning of the injection of contrast, but 10 seconds later you have nothing. It means that you have a vascularized adenocarcinoma. And a vascularized adenocarcinoma is 20% of the cases, and you need to do only slow pull and no suction. You understand? So it's all that things which allows you to arrive to your goal, which is 100% at the first attempt.
Here, what I want to show is the fact that the Wilson duct is increasing in diameter over there.
Yeah.
If you can show,
Yeah.
it's very nicely seen, and that's why it is important in case that we see a stenosis and the dilation upstream to put the needle just near the stenosis and
Yes.
to be very sure that we have cells over there.
Yeah.
Okay.
Yes. And when you have a mass and you have a jaundice, you have a double duct sign, but you have, when you look at the head, you have a big thing, but you are not able to say what is the pancreatitis and what is the tumor. So finally, you have nothing which is really the mass. Put your needle immediately after the narrowing of the PD. It's the best area to find the cancer. If you don't know where is the cancer, put the needle immediately after the stenosis of the PD, and you will have more chance to have the adenocarcinoma in this area than in the other part of the big mass that you have, which replace the head of the pancreas.
Here there are some changes of the parenchyma
Yes.
with some stranding and some foci, hyperechoic foci. Perhaps
It's obstructive chronic pancreatitis,
yes.
and you have the side branch dilated, but they are not dilated like in IPMN. They are dilated like in obstruction. They are parallel to the dilatation of the PD and not perpendicular to the dilatation of the PD. When you have dilated side branch in IPMN, it's more perpendicular. When it's parallel to the dilatation of the PD, it's a sign of obstruction without side branch IPMN on the part of this pancreas with dilated.
And now I scan the left lobe of the liver to be sure that everything is correct over here. I see no lesions suspected to be metastasis and no ascites over here.
You know that our colleagues from Japan has published a beautiful study 2 or 3 years ago about contrast with sonazoid, not Sonoview, in the left lobe of the liver to look for liver met, and they do a prospective trial, comparative trial. We showed that it was better than CT scan. But unfortunately, as we know now that MRI is better than CT, and now all the pancreatic adenocarcinoma have MRI for liver met, of course, this study is not very interesting because we have no the comparison with MRI for the left lobe.
The CBD is normal over here in the hilum of the liver, so we can say that the lesion is completely staged.
Yeah.
Do you agree? So
yes.
we wait for the.
Look at the celiac trunk if you can. I finish always when I do not see at the beginning that there is involvement. Here we have the SMA, and no, this is yes, no, this is, yes, celiac trunk and SMA. So now the celiac trunk, because as you know, pancreatic adenocarcinoma is a spatial cancer, and without direct involvement of the celiac trunk, you can have an involvement which is 2 centimeters far from the tumor because of the involvement of the nerves which are into the pancreas, and this involvement move back along the celiac nodes and move to the artery into the wall of the artery because the celiac trunk has this kind of possibility.
Laurent,
yes,
Andrada, thank you very much for
Thank
this
you.
fantastic demonstration. We go in the pathology room just to see the final results of your biopsy.
So here we are. Thank you, Professor Arcidiacono. Here we are with the Vivascope material. Now the Vivascope is starting to scan the material that we have, and soon we will have the result. Okay, now we get the focus, and we will have the first scan. So this is highly necrotic, as it was also on the previous smear. So we look for vital cells in the inside. So now we prepare and we prepare for the full scan of the area. Okay. Yes. So here we are. Okay. In the meantime, we have on the video on the desktop we can appreciate the very severe atypia of these cells with these large nuclei, and some of them look also a little bit sarcomatoid. And
So the first passage was adequate for the diagnosis, and here we will come back with the Vivascope soon.
Firing now.
Okay. Okay. So we will move soon where we have some nuclei and see if they are vital to be evaluated.
Ancora un minuto dove?
Okay. Okay, so this looks very, very necrotic, but at least these are residual of the nuclei of the cells, and there is extensive necrosis to all the sides. So as prevented, as we already know, there is necrosis. So this is the only part in which we have the cells. Okay.
So thank you very much. Thank
You're
you very
welcome.
much, Professor Sapedica and all the pathologist team. See you tomorrow.
Thank you.
So now we close the first day of the live from Milan, but we move back to Leuven, where I see that Skalk and his team are already working. Hello. Hello,
Hi,
Skalk.
Paolo.
Hello,
Thank you.
guys.
Welcome back.
Hello,
Yes.
Michael.
So if I can introduce you to the team, Anna from Hallenstein, our expert pancreatic specialist, will perform the procedure. And we also have in the room our rising star, Dr. Michiel Bronswijk, and our team with Nick and Nurse Eva. So I'm going to ask our fellow to introduce the case.
Okay, so the case is a 72-year-old female with a chronic calcifying pancreatitis.
Can you hear us?
Yes,
Yes.
absolutely.
Okay.
Yeah. Okay, so this case is a 72-year-old female presenting with a chronic calcifying pancreatitis and having persistent pain. On abdominal CT, we could already see a large obstructive pancreatic duct stone and some calcifications in the parenchyma of the pancreas. An MRI also showed upstream dilation of the pancreatic duct, as you can see here. Because there's a surgical contraindication due to local collateral circulation, and so there's an indication for endoscopic therapy. There was already twice a failed retrograde cannulation by experienced interventional endoscopists, and so today we are going to attempt an EUS-guided procedure or an EUS-guided pancreatic gastrostomy or an rendezvous procedure. Back to you.
Okay, so I'm here in the stomach, looking at the body of the pancreas, and you can already see the dilated pancreatic duct. I will turn to the neck where it goes down, and you see some parenchymal calcifications. And I will follow it back into the body here, and you can see that it's quite dilated.
I think what is quite interesting is that there seems still to be, despite the degree of parenchymal, the degree of ductal dilation, the pancreas parenchyma seems to be quite preserved, Anna.
Yes,
So,
indeed. It's not a lot of lobularity or stranding. There are some parenchymal calcifications. Also on fluoroscopy, you can see the huge pancreatic stone already present in the pancreatic head. And since the retrograde ERCP failed, we will now do an EUS-guided procedure.
I think that you can appreciate the position of the echo endoscope in the stomach. So we aim to position the echo endoscope fairly towards the pancreatic tail, so that you have enough landing space should you need to place a pancreatico gastrostomy. So you should appreciate now the stent, the sheath of the stent, the sheath of the needle protruding. We're going to use a Cook 19 gauge standard EUS needle. One can appreciate the parenchymal calcification there. We are using a Pentax linear echo endoscope and the Arietta. And I want you to concentrate on that trajectory where Hannah will advance the needle, yes, very nicely into the pancreatic duct. So you can see that she's nicely in the pancreatic duct. And we will now inject some contrast to define the anatomy. So I think it's fairly easy to see that the pancreatic duct is dilated. And I think under these circumstances, we can use a wire to push the wire down in the direction of the papilla. So we'll use
your
a standard
first plan
easy
is to
glide
do
wire.
a rendezvous? Is that right? Your first idea?
So that would be the intention, to perform a rendezvous procedure if possible. You would notice that there's a very, very large stone in where the tip of the guide wire is now. So if we cannot pass that stone into the small bowel, it may be necessary to perform a pancreatic gastrostomy, prepare the tract, and in the second session we'll use spyglass to fragment the stone, but in an antegrade fashion. But you can see, I think the stone is highly obstructive.
Yeah, sometimes we see that there's an obstructive stone, but sometimes the wire passes through your minor papilla. And yeah, it's just during the procedure that you can evaluate. And we have some data that even through the minor, it can be very efficient and successful.
But I think it's clear that the wire is not going to go anywhere. Maybe we can, yeah, wow, Eva.
Straighten it a bit, maybe. Yeah.
Fantastic. Okay, maybe what we can try is to use a cystotome to give you some more support, and then the wire will pass. So the first step is to gain access to the pancreatic duct. I think that was the main concern of previous surgical studies, where many of the endoscopic procedures failed because of inability to gain retrograde access. So a priori, you already had a likelihood that surgical therapy would have been superior to endoscopic therapy based on the fact that retrograde failure of cannulation occurred frequently in those studies. So now with EUS and the ability to be able to work in an antegrade fashion, to hopefully be able to pass either now or in a second procedure, then I think that new studies need to be performed comparing endoscopic therapy with complete ductal clearance to surgical therapy, and maybe the outcomes will look differently. So in the first instance, we will advance over the guide wire a 6-French cystotome to gain access, but also with the intention to support the wire, and hopefully, if I can then manipulate the wire across the papilla.
Just one question regarding to access. In case you cannot do the rendezvous and basically the wire doesn't get into the small bowel, would you then proceed with the pancreatic gastrostomy?
Yes, we would proceed with the pancreatic gastrostomy plus allow the tract to mature, and in the second session in a week or two's time, we'll use the tract between the pancreatic duct and the stomach to then introduce a spy scope in an antegrade way. So it allows you for antegrade therapy as well.
And this patient failed conventional ERCP, I presume?
Yes, twice. So the patient had 2 attempts by a very senior endoscopist. Yes. Now Hannah has successfully passed into the pancreatic duct. So no, I think that's the message as well, Michelle, that there should be the conventional therapy is still endoscopic therapy in the form of ERCP. But given that we are a referral unit, we see many of these patients where ERCP has failed, And this allows us another way, not only to achieve access, not only to perform pancreatic gastrostomy, but ultimately, and that should be the goal, to remove that stone, either by rendezvous approach or by anti-grade spyglass approach.
Yeah. In your conventional, procedure, when you have like a typical chronic pancreatitis with intraductal calcification, when do you offer? Where does the ESWL stand in your algorithm?
I think that's a very important question. I think that we use ESWL. We use ESWL especially for stones towards the pancreatic tail where endoscopic therapy is futile. But with a stone this large, it would be very unusual to get it ESWL to really obtain clearance of this duct. So ultimately, you will need an endoscopic approach as well. But yes, ESWL still is part of the algorithm. We commonly use it for stones more upstream, where endoscopic therapy is unlikely to be successful. Okay, so now Hannah is positioned. I think now we've got an opportunity. You can also already see contrast. Nice, very nice, beautiful.
Very, very nice.
So
very
nice. So you can see that that Hannah successfully passed the stone. Eva, that was wonderful work. And now we're in the small bell.
Can I ask
advance the wire as far as we
who
can
was
in the
playing
small
with the
bell.
wire?
Our very experienced nurse. This really helps.
But she's not for sale.
What is her name?
No, she's an absolute expert, and without her, we cannot do these procedures.
That was
I think
very
you
well
can
done.
advance the wire further, Eva. Just advance it further.
I cannot follow transpapillary.
Okay, so I think that we will try now with balloon dilation to see if we can get balloon to make it easier when we're going to try retrograde access. But there seems to be quite...
I'm bending. Yeah.
Okay, so you can advance the wire a bit further, and then we're going to use a 4 millimeter dilation balloon. Let's see if that helps.
I return.
So I think in the new era of EUS and therapeutic EUS, this procedure will gain more and more traction because it does allow us access, which we may not have, and it does allow us therapeutic other therapeutic possibilities and where we can claim complete ductal clearance. That is not the case always with ESWL. So the ultimate aim in this case will be complete ductal clearance at the end of the procedure.
There is a question that comes from the audience. Is cystotome through pancreas more or less likely to cause pancreatitis than mechanical?
I think that's a very good question. That's a very good question. In our hands, it's not the case. In our hands, I think the most important is ductal drainage. In this case, you would not have been able to advance the guide wire through that without having having the possibility of the cystotome to give you support.
As you can see, it's not easy to pass the stone with anything else but the wire.
Yeah, it's very, very hard there. Maybe we can try a rigid dilator first, and let's see.
Okay, kom terug.
So it's not the case that if you're in the small bell that the procedure is over. There's still issues that we have to overcome. So we're just going to use a rigid dilator, 3 to 5 French rigid dilator, to see can we prepare the tract for a balloon. That is a huge stone.
So question from the audience now, a little bit more precise, specifically from Sandeep. Would you burn your way into the duodenum using a cystotome?
Oh, that's a good question. I think that in my case, I would not. I think that I have an alternative, and the alternative is to use spyglass in the next session. I think that there may be risks associated. I'm not very sure exactly where the guide wire, if the guide wire is in close proximity to the duct wall. So I think that it may be risky. So I would not, yes, I think Hannah could pass. You can see the, so hopefully
you
we
made
can
some
now,
progress now with the balloon.
yeah, I think we should.
It's a dilator, so it's 3 to 5 millimeters. So it's 3 to 5 French, sorry. So it's.
If we can perform a retrograde approach, we will use spyglass already today. So that is the reason for wanting to continue. Okay. So you can see that Hannah has passed the rigid dilator quite nicely. And now we will see if we can dilate, because that will enhance the likelihood of retrograde access at ERCP. So we follow the standard protocol also of administering diclofenac. So that is, and also, as Anna rightly pointed out, antibiotics, because we're crossing a sterile space into the through the retroperitoneum into the pancreas. So obviously there will be a need to give at least one dose of prophylactic antibiotics.
Did you, in your experience, did you notice any correlation with pancreatic duct dilation and the risk of pancreatitis? I mean, if you have a really huge pancreatic duct, probably the patient is less likely to have a pancreatitis or not. There are some few experience with pancreatoscopy. I don't know if there's any data even on this type of procedure in chronic pancreatitis. Do you have any experience in it?
Yeah, I think it's a very good question. In this case, I would be more concerned about pancreatitis because the parenchyma actually looks quite okay. So in the patient with very severe calcifications, I'm less concerned. But specifically, your point on the duct, the size of the duct, I think that we try to limit the tract so that we don't have to pass through too much parenchyma. So in this case, Anna demonstrated that beautifully, where the tract was very between the stomach and the dilated pancreatic duct was actually very short. It was only a few millimeters. So that lessens, I think, the risk of pancreatitis. The size of the duct doesn't really matter that much. So we do this procedure also in patients where the duct is much less dilated than in this case, also successfully. So I think there are quite a few factors that may play a role.
Yeah, usually we say that you have at least 4 millimeters of dilation.
Yeah.
But
okay, so now we're going to dilate to 6 millimeters.
No, it's again 4 because
okay.
the other one.
Okay. So we're going to dilate. You can see the tract. So we also have to be careful. We're not going to overdilate. It should just be enough so that that the retrograde procedure will be perfect. Will be perfect. Beautiful. Okay, so now the difficult part of the procedure starts because we're going to leave the wire behind. We're going to remove the endoscope, leaving the wire behind, and then introduce a duodenoscope next to the, or we're going to then pass with a duodenoscope and cannulate next to the guide wire. So it's going to be a tricky procedure. Because of the risk that you may lose the wire. So I think it will be good to concentrate, focus on Anna's hands as she removes the EUS scope. And with the help of Eva, the guide wire will remain in place. We keep the guide wire as far as we can.
A very good comment for Sandeep. What about placing a stent in an antegrade fashion from the stomach?
I think that's a very good suggestion. It's something that we can absolutely, we could have done. I think it's a very good suggestion. I think we feel quite confident that it should work now. But that would have been an excellent suggestion as well. My only concern is there's not a lot of space down at the bottom. So it may still be difficult to get a stone past. And if you don't get it past, then obviously you're stuck because but it's certainly a possibility. I think it's actually a very good suggestion, Sandeep. Thank you for asking all the difficult questions.
Skalk?
Yeah.
Skalk and all the
Yes.
team. Unfortunately, we must leave, but the procedure was fantastic. I hope that we will have the possibility to know about the rest of the procedure and the success of the procedure. Thank you very much for joining us this year
Thank you,
as well,
Paolo.
and thank you for the perfect exam that you have prepared for us. Thank you very much to the whole
Paolo.
team.
Thank you all.
Bye
Bye-bye.
bye. Thank you. So now we can.
Please send me the picture.
So thank you very much to Leuven, and then we move to the first US connection. So we are now happy to connect with Orlando Health Hospital in Orlando, Florida, and to connect with our friend Shyam Radajulu. And Shyam, can you hear me?
Orlando Health Digestive Health Institute, the premier destination for specialized digestive health care, where our team of internationally recognized doctors are doing groundbreaking research that impacts patient care around the world, and pioneering how artificial intelligence can improve early disease detection, aid clinicians in decision-making, and save lives. Here, patients receive advanced access to the latest technology and treatment options, even for the most complex digestive disorders. Here is where world-changing research meets innovative digestive health care.
Hello, Shyam. Welcome.
Hi, Paulo.
Hi.
Thank you. Well, welcome to Orlando, and here I am with my team, my all-star team. So I've got Vanessa, who's my nurse anesthetist for today, Isaac, who's going to help me with the procedure, and then Jamie and Adriana, our nurses, and Conrad, who's a cyto technician for the procedure. So let's go to the slide to present the case. So this patient who's here for the procedure is a 67-year-old lady, 74-year-old patient with history of acute recurrent pancreatitis. She's been hospitalized over the last 2 years multiple times for an unclear etiology. And at every EUS, she had interstitial pancreatitis and an ill-defined area in the head of the pancreas, but no ductal dilation. She's right now asymptomatic. She had 2 prior EUS examinations that revealed pancreatic inflammation with borderline atypia, but no tissue diagnosis. She's not a diabetic, and she's come here for her 3rd EUS examination, first at this center, being referred by another EUS facility outside. So I've got the Pentax Slim J10 echondroscope, and I'm going to take a good look at the pancreas, and then we will use the AI software for looking at the pancreas to see what we see. So I'm in the stomach, and I'm looking at the body of the pancreas. I don't see anything, and then I'm talking my scope. This is all looking normal. There's a small cyst in the body of the pancreas. There is no ductal dilation, as you can see there. There's a very small pancreatic duct, and I'm tracing towards the tail region. I'm not seeing anything, and here's the spleen. So the pancreas looks quite normal in the pancreatic body, the pancreatic tail. I'm going to ask Stephen now to show AI. So this is a medical software that was developed by Orlando Health in conjunction with Adrian Sakitu's group. And what you're seeing is the AI image. And when you drop the scope, the AI will pick up the pancreas. You don't have to wait to point towards the organ. So green denotes normal pancreas, and there you see the pancreatic body on AI, which looks quite normal. And then as I tuck the scope, as you can see, the EUS imaging of the pancreas is normal in the body and the tail. So I'm not going to advance the scope past the pylorus to the duodenal, to the pancreatic head region. And that is the portal vein, the bile duct. The pancreas looks okay. And I'm going to put my scope down a little bit. And there I see an ill-defined mass. And usually on artificial intelligence, if there's a mass that is identified, it should be appearing as red on the screen. And it's pretty accurate for usually tumors. And I'm going to now push the scope into the uncinate process, the second portion of the duodenum. And then I'm going to retract the scope once again to get a better idea on the pancreas. Here's the unslit. The aorta is down on the screen. And then as I pull back, there's a common bile duct that you're seeing. Let's pull back more. And this is the unslit view. So this last episode of pancreatitis was about 2 weeks back. He's right now asymptomatic except for some abdominal discomfort. And there again, I'm in the pancreatic head region. And that was falling back. And there is the mass that I can see. And you can see on AI, it usually appears as a red lesion. So can we freeze the screen? I do not see a definite evidence of any vascular invasion, although one can say it's abutting the portal vein, which is right here. So this is about 17 millimeters. And I'm going to sample this. And for sampling, I'm going to use the sharp core needle. This is a 22 gauge sharp core needle from Medtronic. And we always depend very heavily on rapid on-site assessment, particularly for patients who are referred to us with a failed tissue diagnosis from an outside facility, because in the United States, at least, there's an expectation for most patients when they come to our facility that they will have a tissue diagnosis before they are discharged from the hospital. So we have a pancreatic cancer screening program at our facility, for which we get, for which we perform at least 1 or 2 procedures almost every single day. And right now, as you can see, this is a neck lesion, so it just goes back and forth, and it's a little unsteady, but we'll get to it. That is the mass again.
Are you using AI for each screening program in US?
Yeah, I mean, you can ask me, do you have data? We don't. That's exactly what we are doing now, is we are collecting as much information as we can. As you know, this is pretty brand new, so we have to train the model. At least until now, I can tell you that for solid masses, we are pretty damn good. It's close to 100%. Even for small lesions of a couple of few millimeters, we are able to identify them without a problem. For cystic lesions, it's being trained to identify lesions more than a centimeter in size, and we are working on smaller lesions right now. So those are the two things that we are working on: pancreatic cysts, solid masses. I think when it comes to normal pancreas, it's quite very accurate. It's very, very good with the normal pancreas on solid mass. It requires some more training on cystic lesions. So you can see the needle is in the right in the middle of the mass, and I'm going to perform about 7 or 8 accentuations, and then very more than likely do a rapid on-site assessment, and then send this for molecular profiling and cell block. I've not done a liver examination, but I very much doubt I'm going to see anything in the liver, given the small size of this lesion. So we are done here. I've in the interest of time, I know you guys will be probably busy transmitting between multiple centers. I've done one pass already, and I asked Conrad to make a slide so that you'll be able to see it. The differential diagnosis is simple. It's either a neuroendocrine tumor because there is no ductal dilation, or this could be an adenocarcinoma, garden variety, not diagnosed before. So can we show the microscope, Stephen? Can we show the microscope that is already being positioned at the slide? Move to the microscope, Stephen. Yeah, so you can see that Conrad has shown you what he's pointing to you is atypical cells that are significantly atypical and a normal group of ductal cells. So this looks like an adenocarcinoma, at least by rapid on-site assessment. An 18 millimeter pancreatic cancer, which is the etiology of pancreatitis in this case. As we know, there's enough data from the VA study group that tells you in 0.2% of patients with pancreatitis of unclear etiology, it happens to be unfortunately an adeno-CA. And I think this is some of the reasons why a screening program is very good. The recent study from the CAPS database shows you that the 5-year survival for pancreatic cancers diagnosed via screening is 57%. compared to about 8% for patients who have symptomatic pancreatic cancer. Patient is asymptomatic, doing very well, was referred by the doctor because they were suspicious that there is something going on, and we can see an 80 millimeter lesion with no evidence of clear vascular invasion, who possibly can go for a Whipple procedure followed by adjuvant chemotherapy. Any questions?
Shyam, that was very impressive. Sandeep here.
Hey, Sandeep.
So which are the cases you select for pancreatic screening?
Well, anybody with a strong family history of pancreatic cancer, patients with mutational disorders such as BRCA1, and then patients in whom there's a clinical suspicion for a pancreatic neoplasm with previously failed tissue diagnosis. And then you've always got these patients with a very strong family history, but they don't have a syndrome such as hereditary pancreatitis. So these are the 4 classifications. Next, we want to work on pancreatic cyst lesions to see if we can break the algorithm. As you know, with AI is only as good as the data that goes in. Right now, the majority of the data has been derived with only the pentactic endoscope. We are since this is a unit that has all scopes. We have Olympus in multiple rooms. We have got Fuji in multiple rooms. We have got high-end processors. We have got the boxed EUS. There's nothing in EUS that we don't have. So probably we will have to train with all these machines to get a platform that is close to 99.9%. There is no point getting 95. We need to get to 99% accuracy.
So, it's Anand. How's it going?
Hey, Anand.
I disagree that the pancreatic duct is not dilated. I don't know if it looks pretty.
So I'm going to use your own I'm going to use your own language and say, what is that supposed to mean?
Well, it's dilated. She has obstructive pancreatitis. That's why she has pancreatitis. But its duct looks at least 4 or 5 millimeters.
Let us measure it. So I'm in the body of the pancreas, 2.6.
But it's too visible to me. And if you follow it, that's a really irregular duct, and that's an obstructed looking duct to me anyway.
Well,
that would explain why she's having pancreatitis. Her duct is obstructed.
I mean, there's no rocket science. That the reason for the pancreatitis is the neoplasm. She is 67 years old. She doesn't smoke. She doesn't drink. She's got no medical history. So she's not a diabetic. And she's having these pancreatitis attacks for the last about 18 months now, 18 months to 24 months. So probably a very small tumor on the pancreatic head, missed on cross-sectional imaging until the last time when they saw a lot of fullness. The problem is she's had imagings only with acute pancreatitis. But so you can flip the coin. If you not have made a diagnosis without AI, unless I am blind, probably I would have seen it. It doesn't help me, but hopefully it will get to a point where we will be able to see lesions as small as 5 to 6 millimeters. Once again, we have to train and make it very precise. What needs to happen is if I don't do a good examination of the pancreas, I'll miss this mass. And that's what we are focusing now on. We want the AI to be able to tell us, well, this is the pancreatic neck, body, tail, head, and the unsnet. So if we can, if it is labeled on the software, then I think everybody will do a good exam. Because if you don't see that part, it means you've not done a good exam. And the second thing to do will be to focus on lesions as small as millimeters. I think yesterday, the day before, we found an 8 millimeter or a 7 millimeter adeno CA. That is exactly what we want to do. We want to be able to see very small lesions that people who may not be experts will have no problem using the software and identifying small lesions. It will lower the learning curve for learning EUS, identify small lesions before they are symptomatic, so that patients can have a curative resection. So that is the objective of this project.
Thank you, Shyam. That was very impressive. Sorry, please go ahead. Thank you.
Did you test this machine on chronic pancreatitis?
Not yet. I think Mike Levy has published a paper in in Gut looking at chronic pancreatitis versus autoimmune pancreatitis. That was not done on live patients. It was more a study that was conducted on recorded procedures of patients, where they said that they were able to differentiate an autoimmune pancreatitis from chronic pancreatitis. Right now, if I look at autoimmune pancreatitis, and if it is an anechoic solid, hypoechoic area in the head region, the AI software is showing it as a pancreatic mass lesion. So we have not worked on it at all. So right now it looks like a tumor to us on AI, but we have not done that.
So
okay. So I have nothing more to show you.
Thank you very much, Ayam.
Thank you so much.
We will see you in 20 minutes for the next
All right.
case. And now we move to Ecuador, to Guayaquil, to Carlos Robles Medranda unit. Carlos, can you hear me? Oh, yes. Just a while for the connection with Ecuador. It's quite complex to move around from different connections worldwide. So we need some more patience to connect.
Can you hear me?
We
Hello?
can hear you perfectly.
¿Me pueden escuchar? Oh, perfect.
Here you are.
That's very good.
Great.
Fantastic.
Thank you. Thank you for joining us, and welcome to EUROEUS2024.
Thank you to you. I'm very glad and very honored to be with you again. So I
It's a
believe we
pleasure.
will present the case. We will present the case, I believe. Okay, so tell me when we are ready.
The first patient is a 50 years old female with autoimmune liver pathology diagnosed 5 years ago. The labs showed pancytopenia with a child liver cirrhosis, but important portal hypertension. The upper endoscopy revealing big esophageal and gastric varices. Our proposal today is for US guided coils placement and cyanoacrylate injection.
¿Cuántos años tiene? So thank you so much. We have today a very interesting case. It's a 50 years old woman with liver cirrhosis secondary to steatohepatitis, chronic steatohepatitis. So now she have a cirrhosis, and I want to talk about a little bit about endohepatology. I believe it's one of the biggest advance that US is giving to us worldwide. And with new software and with new technology and all the things permitted to advance a lot in this area. And I believe it's not just the future, it's the present. Today I will show you a little bit what we need to do to evaluate these patients using US and performing endopathology. So first, I have here the vessels. You can see here I am using DF5, detective flow imaging technology. So in this, you can see all the vessels. This is the gastric varices, but with this technology, it's easier to identify where is the feeder vessel, because one of our papers published a few years ago using this technique, for treatment of gastric varices. One of the key points is how to detect the feeder vessel. Okay, so now I believe we need to evaluate this technology in the future to evaluate if it is possible to identify easier, as I can show you here with DFI, the feeder vessel, and go inside here and not here to perform just an unique treatment, less coils, less glue, with a very good efficacy. So this is one of the things that I wanted to show you today. So the other thing I want to show you today is the evaluation of shear wave in the spleen. So I have the expert Raquel here to my side, to my behind. So she made the measures today before, to win time. But I believe this is very important for the future. We just sent the paper, right? Of our Yes, we just sent the paper of our series um, for evaluation of liver cirrhosis and portal hypertension. So we can measure the spleen. So we can see the elasticity is very high. You can see it's 30 after 10 measures, and we can measure also the liver stiffness. ¿Cuál es? Oh, well, so I'm looking for the image. Wait.
Carlos, can you hear me?
Yes.
We don't have
Yes.
the echographic view online. Or you just
You don't have the echographic view?
No, yes, the live echographic view. We have only freeze frames. Do you perform only freeze
Yes.
frames? Okay.
Yes. I just take pictures to win time.
Okay, great.
So this is the right lobe, the right hepatic lobe, and you can see this is very high. That's why this patient have portal hypertension. So it means the elasticity of the liver and the spleen is around 30. So it means it's very hard tissue. So now I am going again. I'm going here to see to identify my vessels are here. You can see here. So initially, I love to put water in the fundus because this will help me to identify where are the vessels, as you can see here. And then I need to follow these vessels going in one vessel normally in 80% of the cases, but around 20 to 25% of the cases, we can have more than one feeder vessel. So now I will use the needle. I believe
Do you usually
this is
perform a CT scan before moving to this to US guided procedure in order to exclude the splenorenal shunt?
no, because I use always if there is not contraindication in the patient, I use always varicellography. This paper was published in 2019, digestive endoscopy by our team. So with varicellography, you can arrive to identify if there is any shunt. It's much better. In those cases, if you see the shunt, it's better to use just coil and not the glue. This is the way that I use or the way that I treat the gastric varices. So I see here, this is the feeder vessel that I showed you using the DFI. Now I will increase my image because I want that you see very well. So we can see here, take a picture. I confirm that this is the feeder vessel, and then I go inside the feeder vessel using a 19 gauge needle.
Yeah.
Okay, I will confirm if we are inside. Yes. So what I do is I put saline solution, and then I make an aspiration, and I see if there is a blood coming. So I am correct, and once I am inside, I will not prove anything. I will just start to do everything that I have. You see now, I I make I made a flush with saline solution, and one of the confirmation that I have that this patient that I am in the feeder vessel is that the flow of the saline solution is going in all the vessels. You see here. You saw that. I don't know if you saw that, but I can do
Yeah,
again.
we can
I
see.
need that you see, yes, in this area, so you can see the flush going in all the sides, all the way, and it confirms to me that I am in the feeder vessel. Second, I use fluoroscopy and I use contrast, and you can see very well. Necesito la imagen grande de la fluoro. So I will show you that you can see very well the left gastric vein. So there is not shunt. When you see the shunt, you see going the contrast the other way. So that's why I don't need to use a CT scan. Okay, so now I will flush again with saline solution. And now I will use coil. I believe 1 or 2 coils is enough. You can see very well the traject. Okay, I will use 12 millimeter coil of diameter. So I use the Nestor coil from Cook. And one of the tip, and it's very important because I see some difference between the series from Europe or from United States than us, is that you need to perform a complete obliteration
How
with the
do you
coil.
choose the size of the coil?
Well, now I use my eye, but at the beginning I measure and I see also the fluoroscopy. So normally it's around 8 millimeter to 10 millimeter this vessel in diameter, but it doesn't. It's not a big deal. In this case, you can use 10 or 12 millimeter. In this case, I prefer to use a 12 millimeter because it will. The coil is very how to say soft, so it will adapt to the form of the vessel. So you can see here. Go. Oh,
Carlos?
Can we see the
yes.
fluoroscopy image?
Yeah.
Yes. You see the fluoroscopy there. You see?
Yeah.
The coil is inside
It's
the
beautiful.
vessels. Yes. I will put one more coil. I know that I am complete obliterate now. For example, if there was a shunt, just that and finish because the varices will disappear in a few minutes. But now I will use another coil, one more, and I will put the glue.
So when you can, you do the double procedure, so combining both coil and glue. Is that right?
Yes, there is a study, a randomized study that we published it in endoscopy, I think 2 years ago, where we demonstrate that the, the double technique, the using coils and cyanoacrylate, is superior to coil alone.
Carlos,
Until now,
any worries about embolization of those coils into a major vessel?
well, I need to talk a little bit about the first series published by uh, my good friend Kenneth B. Muller. He had embolization, but I believe one of the problem of this is first that the technique used at that time was performed directly inside the gastric varice and not in the feeder vessel. And second, um, they didn't show well. They didn't had any evidence before of shunts. In my series, until now, I didn't have any embolization. Probably because I am lucky, or probably because I do this technique of variolography to identify if there is any shunt. So that's why I can avoid the glue going to other places and make the embolization. Now I will flush salina. I will flush with saline, and then I will pass the glue. I almost finishing. Okay.
Do you do this procedure just as prophylactic, as primary prophylactic of bleeding, or as secondary? So you wait for one bleed and then you treat in this way, or you do just as prophylaxis?
You can do in both ways, even in an inactive bleeding, because you can using variography, you can see confirm that you are in the correct vessel. So now I finish. I put the glue. I am going out with my needle. I use 2 octave cyanoacrylate because it takes at least 1 minute, and I will put the flow, and you can see I don't have any flow more. There is not more vessel, and this is a confirmation. So I'm very happy with the treatment. So you cannot see more gastric varices, and I will pass my gastroscope just to see the fundus and to confirm the obliteration, the complete obliteration. You
Carlos,
can
is the
see
patient
the core is,
intubated?
yes, I prefer always because we never know. Sometimes you can have some bleedings, and it's better that the patient be comfortable to avoid complications. But you can do it without. It's not
Yeah.
like a rule. I know that in United States or in other centers, they doesn't perform intubation in the patients for some therapeutic cases, but I believe it's more security for the patient, and
Yeah,
it just
I
takes
agree.
like a little bit more time. So now I am trying to see my fundus. You can see here, this is the side of the treatment. So normally, what we do, normally I start to see uh, the complete obliteration. Normally, it starts to disappear immediately in 80 to 90% of the cases. There are some cases that disappears after a few days because I have some reports from my colleagues that send to me the cases and they perform in the hospitalization another gastroscopy to confirm, and there is not more gastric varices. So you can see here is disappearing. The other thing sign that you can see is it becomes a little bit white. You see the vessel, but the best confirmation is the Doppler. That's why I believe US needs to become the standard treatment for this kind of gastric varices. So I finish. I don't know if you have any other question. If not, I believe we can pass
Beautiful.
to another place.
Carlos,
Thank you.
I have
Yes.
a question for you. Do you usually perform a follow-up of this patient, not only for the varices, also for the liver and so on by EUS, or you perform not only this kind of procedure by EUS? So, I mean, you perform also liver biopsy, HPV evaluation for the portal pressure measurement and so on. So you follow this
Yes.
patient
So
like that?
nowadays, yes. Nowadays, as I mentioned to you, I believe endopathology will replace all the steps that we do for patients with liver cirrhosis and portal hypertension. We are going directly to the liver. We don't have the problem of the obesity or patients or whatever that have in the skin. So with same results of share wave technology. It means FibroScan or other kind of technology like that. So the results are fantastic. Second, in the same time, we can perform um, indirect measurements with technology. It means, as I show it to you, using share wave to see the elasticity of the liver, the stiffness of the liver, and the spleen. And at the same time, you can see if there is any gastric varices or not. You can measure the portal pressure uh, immediately with a needle, and at the same time, well, you can perform a treatment. So we can do a lot of steps that normally the patient goes in weeks in one single step. The thing is the follow-up. Uh, in the follow-up, I normally perform just upper GI, just in cases that we perform, we submit like a beta blockers treatment. You need to do it in these patients with portal hypertension. Just in case of contraindications, you don't do it, but you need to do a follow up at least once a year by US. And in those cases that you are under beta blocker, 6 months after, you need to repeat the portal pressure measurements and see if the treatment is going well, not just by the clinical approach that we had before, because it's more security for these patients. So I believe we need to change a lot the way that we manage this patient, the management of this patient with liver cirrhosis by endopathology, and this is the future of uh, of the diagnosis and treatment for this kind of cases.
I definitely agree with you with this kind of uh, evaluation and kind of follow-up to treat this patient. There are some controversial data regarding the shear wave, particularly. Can you hear me, Carlos? Carlos?
Yes, I
Yeah,
hear you.
sorry.
Yeah.
There are controversial data about shear wave because of the movement of the breathing of the patient during the US, because when you perform shear wave from outside, so with transabdominal ultrasound, the patient can hold the breath, and so you can have a good evaluation of shear wave. How did you solve, or have you solved this problem by EUS? Because when we do that for the pancreas, the results are not that good.
Well, that is a very good question. I believe first you can stop the breath because it's under general anesthesia, so you can stop the breath with the machine first. Second, it's a big liver and a spleen, so it's not the same when are when you have the chest, the the skin, and you have other artifacts in the middle, like when you do fiber scan. So it's totally different. You are directly over the liver and directly over the spleen. So the results doesn't change too much, to my opinion. I'm not professional in this area, but this is what we saw here.
I see.
Do we have a few questions, if it's possible? A last question from the audience, asking a trick to decide how many coils and how much glue to inject.
Yes, very good question. First, you need to see if, as I mentioned during my presentation, you need to see a complete obliteration. If you don't see the complete obliteration with the coil, it's not enough. It means if you see using flow, for example, or Doppler, if you see if there is flow going like in the place that you put it, the coil, it means that you need to put another one. The other tip that I can say to you, I always start with the biggest diameter. It means if I use it, I have the minimum size of the coil diameter here is 10 millimeter with the Nestor coil, and then you have 12, 14, 16, 18, 20. It's very good for gastric varices. I don't have any conflict of interest with Cook, but the difference from Boston or other companies is the size. And so I always start with the biggest one. That's why I put it at 12, even if the gastric varices diameter was just 10 millimeter, and then I used it. The second coil that I used it was 10 millimeter. So it it performed like a complete obliteration easier, and not in the other way. Because when you put first a small one and then a largest one, it's difficult. It's complicated.
Carlos,
So
Carlos, thank you very
yes.
much. We will see
Thank
you
you
in
to
a
you. I
while.
will
We
do-
move back to Orlando
Okay.
and then to you. Okay, thank you very much for the
Thank you.
demonstration.
Thank you, Carlos.
So we are back to Orlando. Shyam, can you hear me?
Paulo,
Yeah.
welcome back.
Great. Welcome
we-
back to you.
So we are going to show you the second patient. Let's go to the slide. So this is a 79-year-old lady who has a history of cervical and uterine cancer. She is on a surveillance program. And they did a CT scan that showed multiple lesions in the pancreas. So she's asymptomatic. In fact, she's got a recent weight gain of about 10 pounds. She's not a diabetic and she's doing very good. So she's here for EUS, for evaluation of the pancreas and for possible sampling of this lesion. So let's go to EUS. So I'm here at the liver, clockwise talk. And by the way, I'm using the J10UT scope from Pentax. I'm right there on the pancreas, and immediately you will recognize this mass lesion in the pancreatic neck region. And as I tuck the scope to my right and I retract it back, there's another lesion in the body of the pancreas. The splenic vein is inferior. Now there is another mass. So there are two masses in the body. There's a fourth mass in the pancreatic tail region. And there is some gastric wall thickening in conjunction with this mass, and there is a spleen inferiorly. So there are about 4 masses that I can see immediately just examining from the stomach. So there is also a mass, I think, in the pancreatic head region. So I'm going to advance my scope into the across the pylorus, and you will see that one more mass very close to the portal vein abutting it. So now, Stephen, let's show the AI program. So there on AI, you see the same thing. You see this mass in the pancreatic head, and I fall back into the stomach, and then you will see these multiple lesions. All of them, the green is normal pancreas, and red again is going to be a tumor. So we need to sample it. The differential diagnosis is going to be quite limited. So this clearly, absence of ductal dilation, this has to be a metastatic cancer from somewhere. So cervical cancer causing multiple myths is it's a little quite rare actually, but let us see what it shows. So before you came, I already did a biopsy for Conrad, and he's just processing the slides to show to us. Okay, so we're going to go and get a tissue on one of these things, and then let us see what it shows. I'm using a 22 gauge Acquire S needle from Boston Scientific. And these needles, because of the sharp style, there is a less recoil. Doing a quick fanning, we don't usually use suction only because it makes the specimen bloody, particularly in metastatic tumors. Unfortunately, the slides can be even more bloodier. So we will try to get as much tissue as we can. And because it's going to be a metastatic lesion, we have to perform more passes so that they can do immunostaining, and they will be able to identify the source of the tumor. She had a colonoscopy recently that was negative. So done. I don't know if Conrad has processed the slide. Conrad, do we have a slide already made on this patient? So Stephen, can we show the slide? Conrad, this is, what do you think? Renal. How do you know? You're endocrine. Okay. So Conrad tells me all the cells. Can we go through the slide, Conrad, quickly? Can you just scan them on low power and high power? So we can see here, all the cells are uniformly monotonous. So all the cells are uniformly monotonous. So this is unlikely an adeno-CA, which we all know. So this likely is a neuroendocrine tumor of the pancreas is one. The differential also, Conrad, do we have a ground glass appearance within the cell to suggest something else? So there's a lot of cytoplasm and some foamy areas. So when this happens, Conrad was quite curious about it. Apparently, 30 years back, the patient had the kidney removed. We don't know why, but based on the slides and we're just getting a history, it could be, despite the duration of 30 years, could be a metastatic renal cell cancer, although the kidney is missing. So this is either a neuroendocrine tumor of the pancreas, or this is going to be your metastatic renal cell cancer. It's unlikely a squamous because uterine is squamous. Cervical is squamous. It's a little unlikely.
There's a question from the audience. Do you think that contrast could help in this case?
Uh, so let's go back to yeah. So this is United States. We don't believe in contrast. I think the contrast is an European phenomenon. For us, tissue is the issue.
Shyam,
We don't
we are in European EUS Congress.
so
At least
so
put a
Sandeep, we
topper
don't.
on it and show that it's very vascular. Both
I know it's
endocrine
going to look.
tumors and renal cells are very vascular tumors.
And then we still need tissue, and we still need tissue to make a diagnosis. So
You have it.
we don't just, yeah. I think this is probably I think it's a renal cell. Again, thinking doesn't help. We will do some ancillary testing and figure this out. Yeah.
On and again. All I
Yeah.
can say is thank God we have AI.
Well,
and the other thing is when you have multiple round lesions like that in the pancreas, the only thing I think that ever gives that is renal cell meds. Because the
Not
cervical cancer
necessarily.
goes to mediastinum.
Yeah,
But
that is
otherwise,
true.
multiple like that, you look at the chart and you say, and it can be 30 years later, but you look at them that have had surgery for their one kidney, it has to be like a renal cell.
Well, there's only 4, right? Small bowel cancer can cause multiple mets to the pancreas. Breast
Lung cancer too, but she doesn't.
Breast cancer can. Melanoma can. If it's a male patient, testicular cancer, and the 5th is renal. So here we have a history of nephrectomy 30 years back. So possibly, more than likely. And definitely it doesn't look like a melanoma. And last is neuroendocrine. Neuroendocrines usually don't have such large appearance. Usually they are much smaller. But again, tissue is the issue.
What about nodes? Do you detect any nodes? Because I have some suspicions at the celiac trunk, but I was not sure because you were so fast. Yes.
I mean, this looks like primarily a parenchymal lesion, right? I mean, I don't think these are lymph nodes. I think this to me looks like a parenchymal cancer. So I don't think it's a lymph node. There are possible. You may be right. There are some nodes inferior to it. I mean, right there, I can see these. I can
But
see these
renal
nodes.
cell it's a autogenous. So it's very unusual to have lymph nodes. I've only seen lymph nodes once with renal cell. But interestingly, when they have pancreatic lesions, I've really never seen lymph nodes around the pancreas at the same time.
All right. I think, but the bottom line is that it's not going to be operable no matter what. They're not going to operate on this patient. It's going to be primarily a palliative therapy. So let us see what the final tissue is. That's pretty much it. Is there anything else that you would like to ask or see?
Can you turn the AI on again, please?
We just routinely record everything, Anand. I think it's going to take for us ages and ages. As you know, AI is an exercise of perseverance and endurance, and it's only as good as the data that goes. So every case is recorded and it's very painstakingly worked on. When you get up in the morning, there's something to be worried about, and the AI is something it's a healthy distraction for us from the research perspective. So, but anyway, thanks for joining for this morning and allowing us to present 2 cases to you. I hope that you guys. I know that Milan is a very beautiful place. You will come visit us in Orlando for our course for Florida Live EUS later this year in August. Thank you.
Thank you very much, Shyam. Thank you very much for this nice presentation. I think that not that many are not involved in artificial intelligence in the audience. So I think that artificial intelligence in the future would be something that will add something to our clinical possibility. So thank you very much for your thoughts on artificial intelligence. So now we move back to Ecuador for the last case of this nice first day of EUROEUS2024. So we can connect directly with Guayaquil and Carlos Robles. Carlos? Okay, here we are back, Carlos.
Fantastic.
Thank you very much.
Very good to see you. You didn't give me time
Bueno, el caso.
to arrange this. Okay, so we have this case today. I want the Daniela, my European woman here in Ecuador. So I am collaborating with the European people here. Huh? Daniela, can you present the case, please?
The second patient is a 69 years old female patient with important past medical history of cardiac disease that presented in our unit with jaundice and weight loss. Biochemistry showed important cholestasis with a total bilirubin of 7.38 milligrams and a cancer antigen of 342 units. US revealed a 4 centimeter pancreatic head mass with CBD obstruction. US choledochoduodenostomy was performed with a 6 millimeter hot axios lamps, and the histopathologic report revealed well differentiated neuroendocrine tumor with Ki67 of 5%. Because of contraindication to general anesthesia, the patient is proposed for US guided radiofrequency ablation.
So, thank you again. Um, I want to show you a little bit the ShareWave technology again. How useful is for evaluation of this kind of lesion. So we have elasticity of 14. It's a hard tissue, but not so hard as pancreatic adenocarcinoma. And one of the other things that is very interesting today is to use DFI. This will replace for sure the contrast that we use. So you can see this mass here that have a lot of vascularization. So the, the histological evaluation showed a neuroendocrine tumor, and now we are proposing, after discussion with oncologists, is to make a treatment with radiofrequency. You can see here very well how the vessels are well observed using DFI. So now I will use contrast just to confirm. Please, contraste rápido. And this is very important. So let's see. ¿Pasó el contraste? So we pass the contrast. We will see in a few seconds. You're going to start to see exactly the same microvascularizations that we saw using DFI. You see? Very well. So this for sure will replace the technology. We have our presentation in ESG days, I believe, or DDW this year about this technology. And this is very important because we need to evaluate after the treatment overall in neuroendocrine tumors if we do a very good treatment with radiofrequency, because we need to see that these vessels disappear after the treatment. So now, I'm sorry. Now I will come back to normal view, and I will start my treatment. I will use, I'm using a Pentax scope with Hitachi 850, and I am using StarMed from Taiwan Medical for the treatment of this radiofrequency. So we have experience also in pancreatic adenocarcinoma, and in these cases, it's better to use less watts. I use 30 watts for neuroendocrine tumors. You can use from 25 to 30 watts. When I use 20 to 25, when the lesions are less than 2 centimeters, because to diminish the risk of complications. One of the complications that you can have using radiofrequency, more overall I didn't saw it in adenocarcinoma, but I saw it in neuroendocrine tumors a lot. It's because of the nature of the tumor, and this is very important. You need to
What about the
avoid.
distance with the pancreatic duct? Because I don't know, is this mass infiltrating the pancreatic duct? And do you perform in if it's really close to the pancreatic duct, as it gives jaundice, pancreatic stent as prophylaxis for acute pancreatitis?
No, I don't use any prophylaxis, my friend, to be honest. Because first, if you do an adenocarcinoma, sometimes already there is a, a stenosis of the main pancreatic duct. So the rhesus pancreatitis, I believe, is not do it because of the obliteration of the pancreatic duct. I believe it's more because of the heatness that the technology perform over normal tissue.
Carlos? Carlos?
Yes.
May I ask you which length of the probe are you using at the moment? 1.5 centimeters, 2 centimeters? How long is the probe that you use?
1.5 centimeters.
1.5. And are you planning to
Because
treat?
it's large.
Yeah, yeah. I see. But are you planning to treat by pulling the probe on the same line because it's so large
Yes.
to pull everything? Okay. And in this
Yes,
case,
I'm doing that. You can see.
yeah.
I start here, and when it becomes wide, I believe it's enough. You don't need to stay like 2 minutes just in one area,
Yeah.
because the tissue destruction is immediately. The power of the radio frequency is very high.
Yeah.
When you compare with microwave technology from Creo Medical, for example, not yet available for purchasing, but when you in those cases with microwave, you need to stay there inside 2 minutes. But here, because of the heatness, the technology is very important to understand how it works. So the heatness is very high, and also quickly. It's immediately. The difference from microwave. So this is why you don't need to stay like just the 2 minutes there. And that's why I believe are more complications when you stay the whole time inside the tumor.
But and in such a huge lesion, do you plan to treat the whole lesion in one session? So today, are you planning to perform the whole lesion?
Oh yes, full lesion, my friend.
Okay.
Always full lesion, because it's not necessary to don't
There's a
do it.
question from the audience asking if you would probably add even a systemic therapy as it is a huge to lesion.
Well, I believe the oncologists of our hospital, yes, they will do it.
So, Carlos, what about
You can see.
technically downstaging a lesion and making it more surgically resectable?
Yes, that is a very good point. Well, this patient have a contraindication because of a cardiac problem. But yes, when you do downstaging, it's perfect. We have very good results with adenocarcinoma, pancreatic adenocarcinoma, and we are publishing the whole series soon. And we had downstaging when you have a very good radio frequency. It means when you have a good necrosis, you can see the reduction of the tumor, at least in adenocarcinoma, in 40 to 50% of the cases. And in neuroendocrine tumors, less than 2 centimeters, the literature show it complete ablation in 97% of the cases. So it's very high.
So do you confirm the complete ablation with pathology?
No, we confirm with CT scan. You complete with CT scan, and the other way that you need to confirm is at least in neuroendocrine tumors, is using contrast. You need to use contrast to verify if there is all the lesions, the complete lesion was treated.
And that will be Sonoview.
Yeah.
Is Sonoview distributed in Latin America?
Yes, some parts we received from Brazil, some of you. In Brazil is approved. I think in Colombia also. And I don't know in Argentina, but we purchased from Brazil. So that's why it's available for us. But now with DFI it's easier because you don't need to use contrast more.
Is
So you see the
elastography
lesions
helpful in this situation?
No, elastography doesn't help because you will not change the elasticity immediately of the lesion. You will see a change of the elasticity just after 4 weeks to 8 weeks because it's in that period when the necrosis appear. That is a very important question, I believe, a very important thing that we need to understand.
In this lesion, Carlos, how many passage of RFA are you going to be doing?
Well, that is another very, very good question. I believe the passes necessary to destroy the complete lesion. All the paces that you need to, you see, I'm here now. I start down, distal, from the distal part of the lesions, and then I become up, proximal part.
Any issues in treating the most peripheral part of the lesion?
No, I didn't understand the question.
If you find there's some issues in treating the most peripheral part of the lesion with this technique.
Entendí la pregunta. Can you repeat again? I'm sorry, I had the problem to listen to you.
I think.
Can you repeat the question?
Trying to find out if you will be interested to treat the most peripheral part of the lesion, closer to the parenchyma.
Well, you need to. However, the risk of that's why I am not using 50 watts, but I believe I will increase the watts at least for the centric part of the lesion. So I will increase un momento a 50 watts. So I will increase to 50 watts because of the size of the lesion, but I will diminish in the peripheral area as you are mentioned now because I believe it's the risk of pancreatitis when you are using highest watts, you increase the risk of pancreatitis. So you see, I increased to 50 watts. I'm looking better. The ablation. So you don't have to have fear.
But usually, sorry, Carlos, but usually when you increase the watts, you increase the steam effect. So you have the bubbles very early, very quickly, but the real effect, thermal effect, is decreased as compared to 10 watts because with 10 watts you don't have the steam effects, so you don't have these burning effects around the needle, and so the flow of the temperature, the flow of the heating is increased around. So usually we do the opposite. we want to treat more tissue, we reduce the VATs, and if we want go for more tissue, we increase the VATs.
Yes, in theory, could be like that, but if you see how it works, it doesn't have to change anything, to be honest, because the thermal ablation is still there. When you use radiofrequency, the peak of thermal ablation is immediately. It's very high, even if you are using 20 watts. So, to my opinion, it will doesn't change. So that's why when you see the results from European series for adenocarcinoma, they use it 20 watts, and I believe it was not enough. That's why the difference between the results that we had here between when you compare for adenocarcinoma ablation. So the only thing that is very important to understand is this technique is not uh, you can you don't have to do it in patients with metastasis. It doesn't change anything, and this is what we show it in our series.
I don't know if there's any consideration of question from the audience.
You need to try to go in all the areas of the lesion. This is very important. So I'm trying to see what areas I need to go to put inside my needle.
So, Carlos, in your experience, what is the risk of pancreatitis with this technique?
Well, for neuroendocrine tumors, it's around, I believe, 5 to 8%. But the series, the European, the European series is the most big series until now published. Um, the mean of the diameter of the case has been 2 centimeters of lesion. So I believe that is why the reason of the pancreatitis, because when you use even 1 millimeter of the destruction area of the needle, you can burn easy normal parenchyma, and that is why you had more risk. In pancreatic adenocarcinoma, it's different because you have fibrosis, and this fibrosis is also around the tissue, around the mass. So that's why it's less risky to have pancreatitis. We didn't have pancreatitis in our series with adenocarcinoma. We had bleeding as a complication. That is also another important thing that we need to understand and to evaluate. Moreover, the risk of bleeding is when you are very near, for example, here to the wall, the gastrointestinal wall. You see? So if you see the bubbles going inside, you need to stop because you increase the risk of bubble. In my series, I had 2 cases of bleeding. However, it's important to understand also that this could be also a alternative treatment in cases of bleeding of mass bleeding, um, but by their own. It means we had a case recently, a patient with pancreatic adenocarcinoma that an ERCP was done, and a metallic stent totally fully covered was placed, and 2 months after, the patient becomes with a bleeding. Uh, so we didn't have a chance to send to radiotherapy because the the only equipment in the country was broken. So we do a radiofrequency of the mass, and after that, the patient stopped the bleeding. So could be an alternative when the mass bleeds, not when the wall bleeds.
I think there's a recent study from the French group with Bertrand Napoleon and Andrea Lisotti and Pietro Fusaroli, in which the only factor that was associated to adverse events in the series was the proximity of the lesion, less than 1 millimeter from the pancreatic duct. So probably this is why it's one of the issues that probably we should take into consideration further in order to see which are probably the correct and the correct position even for these procedures to be performed as much as safe
Yes.
as possible.
Well, I trust a lot Bertrand. Bertrand is first and all is my mentor, and I really appreciate him like a father. But I totally agree with him. But this is more for neuroendocrine tumors. For adenocarcinoma, I do not have the same uh, vision, at least because of my experience in adenocarcinoma. That's why I said in Europe you have more uh, experience with the neuroendocrine tumors. You have more of this pathology there. We have less here in our country. I don't know if Michelle have any comments regarding that point. Michelle.
No, I think your technique is very nice. I'm very pleased and happy to see this. One question that I had though is like, how far the lesion that you're treating should be from the bile duct in order to prevent any involvement of the biliary tree with eventually secondary biliary obstruction.
Well, I didn't have any biliary obstruction until now. I think the biliary obstruction will be performed by the tumor and not by the radiofrequency. I'm not so sure. I didn't have this experience, Michelle. But even if you arrive to have it, you can do it. Repermeabilization of the duct using US or ERCP. So I don't see as a big risk because normally those patients already have a biliary drainage, for example. So this is a big discussion about to use, the standard ERCP, technique for putting stents. Maybe we can prevent some damage of the duct using, plastic stents or biodegradable stents before to perform radiofrequency, for example. We don't know. We need more data. This is why we need more data. I believe we are in the, we know that it works very well. We know that we destroy tumors, but regarding the adverse events, I believe we can avoid these adverse events, preventing, putting plastic stents or, biodegradable stents in the pain pancreatic duct and in the biliary tract, probably. So, but I'm not so sure about that.
Carlos,
We
Carlos,
evaluate.
can you hear me? Carlos, can you hear me?
Yes.
Just because we are quite at the end of our day and we need to close the connection. Yes, this is what.
Yeah, I want to show you.
Yes, thank you.
I want to show you now. This is very nice. Look, I almost finished, and you see, I need to treat this area, but all this is the tumor. No, now it's not more vessels. It means that the result is fantastic. It's very good. So I just need to finish here, a little bit more of radiofrequency, and I finish. So this is the result that you need to see using DFI or contrast. Okay?
So thank
So
you.
I believe I finished.
Thank you very much, Carlos, for this fantastic presentation, and see you tomorrow for other very nice cases. Thank you very much, and see you tomorrow.
Thank you to you.
So,
See you.
Thank you, everybody.
so thank you to everybody. So now we are ready to close our first day of live demo of EUROEUS. So I hope that you have enjoyed the live demo and the meeting, and I hope that you are going to enjoy your dinner tonight. Thank you very much. See you tomorrow.
Thank you, everybody. This session is now over. I'll see you all tomorrow.
Bye-bye.